Hello. 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 Hello, can you hear me?
Yes, sir.
Is this better?
Yes.
Okay. I'm ready when you are.
Okay.
Good morning, Professor Sailesh.
Good morning. Good morning.
We are all set. Let's get an okay from the coordinators and we can start.
Sure. Thank you.
Morning, Dr. Atul Sharma. Morning, Shailesh. Good morning. We'll just start in a couple of minutes.
Good morning, Dr.
Sure. Good morning. Good morning, Professor Kapoor.
Good morning, sir. For starting our today's program, today's session, for the this session, I would like to invite Dr. Atul Sharma. He's online, and Dr. Osman Abbasoglu from Turkey for the chairing this session. Yes, sir. And I request our chairperson to introduce and invite for this session.
Good morning, ladies and gentlemen. I think it's time we begin because we don't want to cut into the speaker's time. And I have the honor of welcoming Professor Shailesh Srikande. He's, besides being the professor and head of cancer surgery at Tata Memorial Hospital, he's also the chief of GI and HPB service over there and the deputy director of the Tata Memorial Hospital in Mumbai. He has published over 300 clinical and basic science papers, including a series of 1,200 Whipple dissections in various leading journals, and has given over 58 masterclass operative demonstrations on pancreatic, gastric, and colorectal cancer. Editor-in-chief of 9 books on GI oncology and pancreatic tumors and surgery. He has also authored over 77 invited chapters in leading books across the world. He is the first Indian to be nominated Secretary General-elect of the ISGPS and also the President-elect of the Asia Pacific HPBA. In recognition of his developing GI and pancreatic surgery in this institution and across India, he was conferred the honorary fellowship of the Royal College of Surgeons of England in 2014. And in 2021, he became the first Indian cancer surgeon and the only second ever Indian to have the rare and prestigious honor of being conferred the honorary fellowship of the American Surgical Association in the 141-year history of the ASA. Heartiest congratulations, Professor Shailesh. And
Thank you.
Professor Shailesh shall be speaking to us and discussing the various modalities of assessing pancreatic surgery as suggested by the International Group of Study in Pancreatic Diseases. Dr. Shailesh.
Thank you. Thank you.
You want us to
Is
play
the
the
recording?
You want to present?
Yeah, no, I think you should play the video. I've sent you my entire recording. I'll be here with you.
Yeah, we'll play the video. That would be.
Thank you, sir. Thank you.
Good morning to everyone, and my best wishes to the entire organizing committee of the Jaipur Surgical Festival. I would have loved to be there. Professor V.K. Kapoor has been so persistent and so focused on this meeting. I wanted to be there, but certain domestic compulsions prevent me from being there with you. But I prepared my talk, which I will share with you on ISGPS recommendations. The time given to me is 15 minutes. It's a vast topic, but I'll try to still give you a brief idea about ISGPS recommendations. The foremost one which everyone would think of would be the 2005 definition of postoperative pancreatic fistula. At that time, it was the International Study Group of Pancreatic Fistula in 2005. And later we updated this in 2016, 11 years later. The defining feature was that we had grade A, B, and C fistula, but grade A had no specific treatment. Everything was negative in terms of radiology. The patient remained well. Naturally, 11 years later, something like this has been deemed to be just a biochemical leak with high drain amylase on postoperative day 3, for example, more than the 3 times upper limit of normal, but it has no relevance and it is no more defined as a POPF. What has happened is a far more detailed look into grade B and grade C. And very obviously, if you have infection without organ failure, it is clinically relevant POPF grade B. But if we have organ failure, if we have surgical intervention, if we have possibility of mortality, all this becomes far more severe clinically relevant POPF, and that is grade C fistula. So what we have with these definitions is graded severity. They are very easy to use. It's a very dynamic kind of a scoring system, and it's always in real time. And you can see the impact of these publications of the ISGPS. The clinical features are very clear that what you have is a straightforward situation where you have a very high acceptance rate for POPF, and you have a very high acceptance rate for POPF 2015, 2005, and 2016 as well, with a very high citations which continue to occur every year as we progress. So clearly, this has been a very successful paper for the International Study Group of Pancreatic Surgery. There are many more. When do you perform a histology? In the absence of a histology, when do you go ahead with a pancreatoduodenectomy? The definition of borderline resectable pancreas cancer, nutritional support, extended pancreatectomy definitions and consensus. The extent of lymphadenectomy has been extensively studied, evaluated, and also published by the ISGPS. How to manage the pancreatic left side after a distal pancreatectomy, how to manage the pancreatic remnant has been discussed. Chyle leak has been defined and graded, and then various efforts at defining pancreatic duct size and texture that would give us information about POPF has also been published. We have also looked at trying to standardize pancreatic anastomosis and where do we stand as regards the position statement of the ISGPS, which we published in 2017. Obviously, for constraints of time, I'm going to touch upon some of these papers. But once again, to highlight the acceptance rate of some of the papers we published in 2014, you can see very high citations for BRPC, for lymphadenectomy, for extended pancreatectomy, and a fair bit of citations also for pancreas anastomosis. The nutrition part has not picked up as yet, but even then it is cited close to 90 times already in the literature. Now, looking at more details, ISGPS paper in pancreatic ductal adenocarcinoma, when do we perform a Whipple resection in the absence of a positive histology? So the consensus statement was that in the presence of a solid mass in the pancreas head that is suspicious for malignancy, biopsy proof is not required before proceeding with Whipple resection, provided autoimmune pancreatitis is not suspected. A strong recommendation of this entire group of experts who sat down to work on this particular paper. Before the beginning of chemotherapy or chemoradiotherapy in patients undergoing neoadjuvant, objective confirmation of malignancy is mandatory, strong recommendations, and ERCP is preferred in the presence of jaundice, because in any event, we have to place a stent soon after. The other option, of course, is EUS-FNA, which has got a strong recommendation rather than percutaneous biopsies. In patients with chronic pancreatitis in whom a resection is considered the best thing to do, even in the absence of a histologic proof of malignancy, again, a very strong recommendation, one of the well-cited papers in literature. BRPC, well, there have been so many definitions, the American HPV Association, the NCCN, and we also have the ISGPS. It's a very controversial and a very hot topic currently in world literature for pancreatic surgery. But one of the important features that came out of this particular paper when we worked on it 8 years ago was the classification of portal vein resection. But broadly speaking, this is the NCCN definition. Localized and resectable means that there are no metastatic disease. There is no radiologic evidence of any vein or portal vein distortion, and there are clear fat planes around the major blood vessels. But in borderline resectable, you have the venous involvement of the SMV or portal vein with distortion or narrowing of the vein or even vein occlusion. And then, of course, you have a suitable vessel above and below, superiorly and inferiorly, to allow for reconstruction. But you can still have in these patients an arterial encasement of the gastroduodenal artery up to the hepatic artery, and even a small segment of the common hepatic artery, approximately 2 centimeters, which would be also BRPC, as well as tumor abutment to the superior mesenteric artery, even more medial to the vein, but of less than 180 degrees. More of an anatomical definition, and we are currently going to be working on a newer definition as well, incorporating biomarkers, patient condition, as well as new available data based on neoadjuvant therapies in the last 8 years. Unresectable would mean that you have complete artery encasement, aorta encasement, more than 180 degree involvement of the SMA or IVC, plus maybe none of this is present, but there is no vein inferiorly for, say, an uncinate process tumor that has invaded the transverse mesocolon, the mesentery, as well as the retroperitoneum. But the other highlight was the portal vein resection classification. Type 1 is just a side clamp. Type 2 is a bigger slide clamp with, say, a peritoneal patch or any kind of a patch to cover the defect. Type 3, something which we do more commonly, is a primary resection and end-to-end anastomosis. Type 4 is a longer length anastomosis, and you have to put an interposition or some sort of a graft in between so that you are able to reconstruct and establish portal continuity. The other aspect has been extended pancreatectomy. An extended pancreatectomy is different from a standard pancreatectomy, because here you may have to do a subtotal pancreatectomy, you may have to remove large parts of colon, stomach, kidney, adrenal, so on and so forth. But so the highlight has been that it has focused on adjacent organs as well as blood vessels. It has not focused much on lymph node disease and metastasis or recurrent disease which happens locally. Our own group in Tata Hospital has benefited by this kind of a definition, and this is one just example where we have compared our standard versus extended resections. a large number of standard and a smaller number of extended resections, an outcome correlation was done. Very obviously, duration of surgery, blood loss, blood transfusion was more in the extended pancreatectomy as compared to the standard pancreatectomy, but hospital stay, readmission rate, major morbidity, no difference whatsoever in terms of outcomes for these kinds of tumors. The other aspect, of course, has also been to look at tumor size, neoadjuvant treatment, and none of these show that there was a big difference when we compared only the vascular resections versus the multivisceral. The previous slide was extended pancreatectomy with standard pancreatectomy, and this slide is vascular resections versus multivisceral versus both. And this slide clearly shows that hardly any difference. It doesn't matter, the outcomes are the same in these extended pancreatic resections. Are they worthwhile? Well, this Kaplan-Meier clearly shows that in well-selected group of patients who have been treated well in a multidisciplinary clinic, extended pancreatectomy has a role to play. Our own figures suggest about 41% 3-year survival after offering these extended resections in pancreatic ductal adenocarcinoma. Another well-cited paper has been pancreatic ductal adenocarcinoma lymphadenectomy. This is a picture of a standard lymphadenectomy plus an extended lymphadenectomy. But the fact of the matter is that there is no role for extended lymphadenectomy. We require a minimum of 15 lymph nodes for good staging and for good prognostication for all practical purposes. But one of the topics out of this paper that was debated and it continues to get debated is this one about lymph node 16B1. Some of us use it routinely, but the amount of evidence to support or to not support is not very strong. And that's where no consensus was reached on lymph node station 16B1 due to variation in the literature and different expert opinions during the consensus conference. Some of us continue to remove, some of us don't. The prognostic impact remains unclear. Moving on to reconstruction after a Whipple, I had the pleasure to lead this as a position statement of pancreas anastomosis, focusing on surgical technique and perioperative management. We evaluated 109 cases, studies, and we had 9 randomized controlled trials and 17 meta-analyses in these 109 papers. We also looked at various aspects that result in the success or a failure of a pancreas anastomosis, whether be stent or not stent, internal or external stents, use of octreotide, single loop versus double loop, drains, whether early removal, late removal, or no drains at all, use of tissue sealants, type of suture material, use of fistula risk scores, etc. And again, we got great concurrence for a number of things. When it came to preferred method of pancreas anastomosis, this paper had about 26 to 27 experts working on it. And we had a pancreatic jejunostomy with ductal mucosa as the anastomotic technique with moderate ISGPS concurrence. Preferred method also for a soft gland, small duct, fat in the pancreas, or a posteriorly located duct. Again, PJ with a ductal mucosa was something which had the ISGPS concurrence. Does the vascular resection in PD change the strategy of a pancreas anastomosis? It may not change at all, and that was again a very strong concurrence of the ISGPS. So in short, we evaluated various aspects. Constraints of time prevent me from discussing each and every one of them in detail. In fact, every paper is worthy of a lecture. But here what we could clearly see was that we had a degree of agreement on a number of factors which dictate the outcome of a pancreas anastomosis. So we then started thinking, should we be having some sort of an ISGPS type of pancreas stratification? I think this was important so that can also further enable us to compare data across centers and across surgeons. Before I come to that aspect, we also looked at left pancreatic resection. This was done by my colleague from Nanjing, Professor Yi Miao. They looked at left pancreatic resections and the outcomes of fistula. You can see that amongst 41 members, You have a number of them doing staple, number of them doing electrocautery, number of them using a scalpel, and some of them using an energy device as well. Now, what came out was various reasons: safety, quick, convenient, better hemostasis, so on and so forth in terms of cost. But could we reach any sort of a clear consensus? We reached some consensus, but we never really had a clear solution. For example, there is no difference in the POPF rate after left resection between hand-sewn and stapler. Strong agreement. Specifically, hand-sewn fish mouth after left pancreatectomy compared to other techniques. Fairly strong agreement that it does not, that it makes a difference or not. Similarly, additional coverage of the pancreatic stump with an autologous patch decreases the POPF rate. Agreement was weak. So there was no clarity on that, no clear, easy solutions. Routine abdominal drainage increases the likelihood of fistula and other post-operative complications. Again, the agreement was weak. Nobody has a clear solution to these situations. Some more statements were there. No difference in the POPF rate or POPF-related post-operative complications after left pancreatectomy. Comparing laparoscopic and robotic, strong agreement that no difference, close to 90%. Similarly, looking at this, we had a consensus as to what is possible, but no clear solutions for the kind of paper that was evaluated by 41 experts of the ISGPS. As I come to the end of my talk, I should still touch upon a couple of recent papers in the last 2 years. We spoke about the type of pancreas 1 to 4. Here you have a definition now, which we published, A to D, simple classification. And the reason is very simple. You have a non-soft pancreas, main duct more than 3 centimeters, 3 millimeters. A non-soft main duct less than 3 millimeters. And then you have a soft main duct more than 3 and a soft main duct less than 3. Progressively, you will see in the third column, the rates of CRPOPF increasing from 3.5%, which is the lowest risk pancreas, type A, to going up to 23% in type D pancreas anastomosis. This is going to get more and more validated, and I envisage that this will be one of the better cited papers in the years to come to compare literature across surgical teams. More recently, I've had a personal experience of working very closely with my colleague and my former fellow, who's now in Adelaide, George Pareto, a dear colleague and friend of mine since many years, Giovanni Marchigliani from Verona. And I was guided immensely by Professor Claudio Bassi and Marcus Buchler, my mentor. And we came up with this definition of post-pancreatectomy acute pancreatitis. It's not exactly the medical acute pancreatitis that we all know very well, but certain inflammatory changes which happen in the pancreas when we do surgical intervention on pancreas for tumors. So it is defined as an acute inflammatory condition of the pancreas remnant, initiating within the first 3 postoperative days following a pancreatic resection. What do you get? You get a sustained amylase, which is high for more than 48 hours, then the upper limit of normal of set by the institution. So this is defined as POH, post-operative serum hyperamylesemia. But then the next step is to see whether there are radiologic features of post-pancreatectomy acute pancreatitis. Those have also been defined. And then if there is a clinically relevant change in management, it becomes grade B, post-pancreatectomy acute pancreatitis. And then after that, if there is persistent single or multiple organ failure, possibly leading to extended or readmission to intensive care, resurgery, or even mortality, this would be the severe form, and that is grade C, post-pancreatectomy acute pancreatitis. We are clearly working hard to validate such a definition, which has just been published, as I told you, this year in April in the Annals of Surgery. And hopefully next year, the ISGPS is in a position to look at this particular definition as to how relevant, how useful this definition is going to be for pancreatic surgery all over the world. So these are very clear definitions that we have tried to establish. I close this talk, but not without remembering that this has been a founding fathers of the ISGPS. Then the ISGPS has grown into a very strong body of people from all over the world with varied interests in pancreatic surgery. And it was wonderful to recently meet them just 2 weeks ago in Athens, when this particular picture was taken where a large number of the experts were available. Once again, thank you, Professor Kapoor, for this opportunity. I'm more than happy to take any questions that would be there at the end of this presentation. Thank you very much for your kind attention. Stop share.
Is my microphone on?
I can hear you well.
Okay. Professor Shrikande, thank you very much
Thank you.
for this excellent overview. We have a few minutes to take questions. Are there any questions from the audience or any comments? Yes, please.
My query is in a scenario.
I'm unable to hear the question being asked from the audience.
Can you hear me, sir?
Now I can hear you. Please speak loudly, clearly in the mic, and hopefully I can hear you.
Sir, we enjoy your talk as usual, sir. So my query is in a resectable pancreatic cancer, if you find a sizable 16B1 lymph node on a preoperative CT scan, so do you go for EUS FNAC preoperatively or you do a frozen section intraoperatively? If it is positive, will you consider further resection or you still go ahead even if it is positive?
So I think it depends on the given clinical situation. As I spoke in my talk, the 16 lymph node, interaortocaval controversial lymph nodes, you have proponents of surgery who do that, and there are proponents of surgery who would label this as M1 disease. Our own experience is that in a selected number of patients, we would still offer them surgery. Prognostically, it may not be very good, not as bad as 8A and 8P, but also this is as bad or it is bad in terms of being positive in terms of long-term prognosis. But patient age, number of lymph nodes, the number of lymph nodes that are positive, the underlying pathology, is the Whipple for a periampullary, is it pancreatic ductal adenocarcinoma, associated vascular pathology, the need for chemotherapy, all these factors you will factor in. A large number of them, we would offer them upfront surgery if it is deemed to be low risk and put them on adjuvant treatment with FOLFIRINOX. But in case there are concerns with additional lymph nodes elsewhere, not just 16B, then some of these would get an attempt at neoadjuvant. And if they are going to do well, then we will do a resection. So I think it's a controversial topic, as I mentioned already in my talk.
Thank you, sir.
We can take only one more question. Please.
Yeah, Dr. Professor Shrikande, thank you so much for your lovely talk. I am Lalit Mohan Sharma. I am medical oncologist at Jaipur.
Yes, I know you, Lalit.
Thank you so much, sir. The question is about the role of neoadjuvant chemotherapy in locally advanced disease and the molecular targets available on biopsy specimen pre-operative.
Yeah. So unfortunately, you know that less than 2% of pancreatic cancers truly have good molecular targets that we can target. Having said that, we know that at least in these 2% patients, you can add targeted molecules as well. But we start off as a routine practice, at least in Tata Memorial and worldwide, even if I have to speak on behalf of ISGPS, the thought process is systemic cancer and modified FOLFIRINOX, and we would give them anywhere between 4 to 8 cycles of neoadjuvant systemic chemotherapy. We would critically keep the surgeon involved in this because there are 20% to 30% patients of locally advanced who would respond well enough to modified FOLFIRINOX, not just radiologically, but in terms of biomarker, good palliation, and patients having a good quality of life. And then our intent sometimes will also change from palliative to a curative resection. This will admittedly happen in only 2 to 3 patients out of 10. but it's still much more than what it was 10 years ago. So we would first do this, and we would look at targets only at a stage when we feel that surgery, which is the only curative option still available in an aggressive cancer, is not available. And that's when we would see whether, in addition to the chemotherapy, whether we want to also look at some of the targets which rarely are resulting in a significant improvement for pancreatic cancer patients.
Thank you. Thank you so much, sir.
Thank you.
Professor Shrikande, thank you very much again. Professor Sharma, do you have any closing remarks? Then we can close the session.
Thank you. I can't hear you, Dr. Sharma. I think you're on silent.
Yes, Professor Shailesh has given us a detailed evaluation of the current guidelines, and I think it'll go a long way in improving the outcomes of our patients. Thank you very much, Professor Shailesh.
Thank you. Thank you, everyone. Thank you once again, and have a good meeting.
Okay, I think we can move to the second session.
Thank you, sir. I forgot to introduce our chairperson. Sorry for the apology, sir. Dr. Atul Sharma, and the chairperson was Dr. Atul Sharma, is a highly experienced senior case consultant, GI and laparoscopic and bariatric surgeon at the Alchemist Hospital. And Dr. Osman is a professor of surgery, and his general surgery training was conducted at Page University, Turkey. He completed a clinical transplantation fellowship at Baylor University Medical Center, Dallas. He served as a professor of surgery and director of nutrition support team of HESTEP University between 1997 to 2020. He is the director of clinical nutrition and master degree program at the same university. For the next session is on the chronic pancreatitis pre-malignant. So I would like to invite Dr. J.K. Banerjee as a chairperson for this talk. Dr. J.K. Banerjee is a professor, Department of Surgery, Bharati Vidyapeeth, Deemed University Medical College, Pune, and other online faculty, Dr. Tobias Cake. Dr. Tobias Cake is a specialist in abdominal surgery and director of Director Department of Surgery at University Hospital, Lübeck. And I request chairperson to invite the speaker and introduce the speaker. Thank you.
Good morning. I have the privilege of inviting Professor H. Ramesh from Lakeshore Hospital, Cochin. Professor H. Ramesh does not need any introduction, particularly in this forum. He is a known figure in the field of pancreas and pancreatitis in India, particularly in the field of chronic pancreatitis. He has got more than 30 years experience in gastrointestinal surgery. He has served in key positions in GI surgery and digestive disease centers at renowned hospitals in the state of Kerala. He has performed the first laparoscopic cholecystectomy in the state and pioneered the growth of basic and advanced laparoscopic surgery. He is currently working as HOD, Department of Surgical Gastroenterology, Lakeshore Hospital in Cochin. I invite Professor H. Ramesh for his.
Mr. Chairman, ladies and gentlemen, I wish to commence by thanking the organizers, especially Professor Vinay Kapoor, for his kind invitation to participate in this meeting, which is obviously a very comprehensive HPV update. And to apologize for by not being there in person to participate in the whole meeting. The task before me is to examine whether chronic pancreatitis is pre-malignant and to also elucidate some aspects of this association. In the year 1992, in a little village in Kerala, Dr. Philip Augustine and I were struck by the close association between chronic pancreatitis as it presented then with de novo or with adenocarcinoma. This was published in the American Journal of Gastroenterology. Essentially, we discovered patients with specimens, resected specimens having obvious areas of chronic calcifying pancreatitis, whorls of fibrosis with atrophic glands, obviously cancerous glands, and dysplastic glands as well, all in the same specimen. We were also intrigued by the fact that patients with chronic pancreatitis presented at the age of 39, whereas de novo cancers presented at the age of 61. But pancreatic cancers in chronic pancreatitis occurred 14 years earlier, at 47 years. There was much more calculi, mass lesions, complete duct block on ERCP, and poor overall health in patients with cancers in chronic pancreatitis. And the pain relief was also poor. All the patients who had chronic pancreatitis cancers had calculi, whereas none of the de novo ones had calculi. And whereas the de novo cancers tended to be mostly in the head, or at least 2/3 in the head, these were distributed through the gland. Survival was worse in patients with chronic pancreatitis than with cancer, de novo. So therefore, we found that cancer in chronic pancreatitis occurred 14 years earlier, presented with intractable pain, with greater incidence of diabetes and functional loss, calculi in all, and with a poor survival. And all this in the background of the fact that pancreatic cancer incidence in Kerala, as indeed in the rest of this country, is low, 1.3% in males and 1.1% in females in the regional cancer centers cancer registry. So it could not be a coincidence of or coincidental occurrence of two common diseases. The other possibility was that we were dealing with cancer-induced obstructive pancreatitis. After all, one of the causes of obstructive pancreatitis is cancer, and a cancer in the head can produce upstream changes which can be histologically shown to be chronic pancreatitis. But when we see downstream calculi, downstream strictures to a block in the head due to a body tail cancer, obviously we are not talking about tumor-induced obstructive pancreatitis. At this time, everyone was very skeptical and no one agreed with this. In fact, data from Orissa suggested that cancer could never occur. A year later, Albert Lowenfels from the New York Medical College put together a study, international study with 6 different countries, where he looked at the risk of pancreatic cancer and found that the standardized incidence ratio in alcoholics and non-alcoholics was higher. In fact, the cumulative risk of pancreatic cancer in those at 10 years and 20 years after the diagnosis was 1.8% and 4%, and that was significant. And therefore, it meant that regardless of etiology, regardless of sex, regardless of the type of pancreatitis, there is a higher risk of cancer in chronic pancreatitis than in the normal population. And this has been borne out by other data as well. The relative risk for cancer in chronic pancreatitis, currently our understanding is that for hereditary pancreatitis, it's 69. For tropical pancreatitis, the data published by Chari in 1994 in pancreas suggested a relative risk of 100, but I suspect it is substantially lower. And it's probably between that of sporadic pancreatitis, which is 5.1, and that of hereditary pancreatitis, 69. So I kind of feel that the data in the Chari study of 1994 seemed to select some patients, and therefore we had a higher figure. Is this genetically driven? Perhaps, but it's most unlikely. The reason why is, whereas the cationic trypsinogen gene mutation, the R122H mutation, increases the risk of pancreatic cancer, especially hereditary pancreatitis. There's been no increase in the risk of pancreatic cancer in SPINK1 or CFTR mutations. And actually, cystic fibrosis, transmembrane regulatory gene, and cystic fibrosis produces recurrent inflammations which may predispose to cancer, but not per se. And therefore, it seems a different set of mutations happens in pancreatic cancer, and a different set of mutations happens in chronic pancreatitis. In other words, in pancreatic cancer, we have P53, P16, KRAS, and SMAD mutations, whereas in chronic pancreatitis, if at all we have a genetic basis, we have a different set of mutations. So, however, if mutations do happen, especially as in the cationic trypsinogen gene, then chronic pancreatitis happens earlier, but this is not true of cancer. Obviously, we are talking about facilitatory situations that if these patients were, for example, smokers, they got cancer 15 years earlier. So it's possible that chronic pancreatitis simply predisposes to cancer at an earlier stage because of the recurrent inflammation. This is a Europac study where it showed that in smokers, the average age at presentation of pancreatic cancer was 56, and in the non-smokers, it was 71 years. If I like to ask myself and you the question as to, in the molecular genesis of pancreatic cancer, where are we putting in chronic pancreatitis? We don't have a clear understanding of where chronic pancreatitis can simply interject itself in this process. So it is actually possible that chronic pancreatitis and its recurrent inflammation produces DNA damage and DNA repair. And this cycle of repair and damage and repair and damage and repair eventually creates mutations, which also leads to failure of apoptosis and an immune system escape and unregulated growth and cancer. So this is possibly the current understanding of the process of development of cancer from chronic pancreatitis. It is also possible that the inflammation in the stroma tends to fuel this process rather than a pure genetic transformation of the acinar system, which one is quite happy to postulate, but is not borne out by data. How can you screen these patients? If you have chronic pancreatitis and if you want to prevent cancer or prick it up very early, is there a way of screening these patients? And this is very relevant in our clinical practice. And currently, the screening methods are not very reliable. We can look for KRAS mutations and combine it with the normal CA19-9. And then you can look for P53, P16, and SMAD mutations. And where do we get the specimen? Because we need a specimen. We need to use either a needle aspiration, which can have the problem of targeting error. We have pancreatic juice, duodenal fluid, and stool, all of which can be inaccurate. See, to get results out of serum samples is a very attractive hypothesis. The problem is, are we able to really do anything about it? Promising area is microRNAs, and currently there is data that a different set of microRNAs happened in chronic pancreatitis and different ones in pancreatic cancer. In fact, there are some which are common to both, and then there are some which are only present in pancreatic cancer. So if you had, for example, a 148B and a 222, down regulation of one and up regulation of the other, you could then consider that this could be a carcinoma in evolution. There is no data as yet which suggests that this actually picks out early cancer. No data as to how we are going to get a reliable specimen for this determination. However, the early data does suggest that we can do serum testing. Endoscopic ultrasound guided biopsy is considered a most promising tool, and my endoscopy colleagues would love to say that. But the CAP study commenced in 2007, was ended soon after, and no data is forthcoming. And I kind of suspect that really the the conclusions are not as promising as you would like. So I would like to introduce to you the concept of gatekeeper, caretaker, and landscaper mutations. And I wish to emphasize that chronic pancreatitis is a kind of a landscaper mutation, similar to ulcerative colitis, where you have recurrent inflammation, and this inflammation, DNA damage, DNA repair, and that process leads to malignancy, and that is of low penetrance, as opposed to the more germline processes, which have intermediate or high penetrance. And on the basis of that, it is possible to consider that if you relieve the inflammation, if you drain the pancreatic duct, if you release all the obstructions of the pancreas, remove the calculi, you may actually produce and decrease the risk for cancer. I wish to conclude with these data from a retrospective multicenter study from Japan, where a large number of patients were followed up for 20 years. Please notice that 87 and 57 patients had non-resectional procedures. In fact, 87, 51 patients had, 61 patients had non-resectional procedures. And despite non-resection procedures, the cancers were higher in those where surgery was not performed. This could not be because of removal of the gland. This had to be because of relief of inflammation. And fast forward to our own experience that whereas when patients present to the clinic with recurrent and or intractable inflammation and or complications, 1 in 7 or 1 in 8 have cancer already. It is also a fact that out of the 1,600 patients operated initially and who have been followed up for more than 12 years, median, 8 and only 8 had cancer. So I'll leave you with this conundrum and ask you whether drainage procedures can protect against cancer. Of course, the Frey procedure, which I favor, is not pure drainage procedure, but it achieves much better drainage. So, ladies and gentlemen, in conclusion, when we consider that this is very likely a pre-malignant condition, is it not better to treat symptomatic patients early rather than allow them to earn their disease? And unlike disease donor liver transplantation, where we have a donor pool which we are dipping into, and we don't need to make abstinence as a prerequisite for intervention. We must try and save patients before narcotic dependence happens. We must provide pain relief along with the addiction and rehabilitation. And this has the prospect of better pain relief, better preservation of pancreatic function, and the possibility of protection from pancreatic cancer. And I leave you with these last few words and look forward to your comments and questions. Thank you very much.
Thank you, Dr. Ramesh. Excellent lecture as always. Is the other co-chairman online, sir? Professor KK from Germany. Has he joined? Okay, thank you. Are there any questions, Professor H. Ramesh, regarding his book?
Good morning. Thank you, Dr.
Is he audible, sir? Dr. Ramesh?
I can't hear him.
Hello?
Why don't you relay the question?
Hello, can you hear me now?
Yeah, I can hear you better. Yes.
Yeah. Thank you for the excellent lecture. I have one small query. Since you have raised the question that we cannot take a biopsy for these patients to diagnose malignancy pre-operatively.
I'm afraid your voice is very low and I can't hear. I can hear parts of what you're saying.
We cannot diagnose malignancy in a patient of chronic pancreatitis decisively by doing a gene study. But can we give them antioxidants to prevent further development? On your 8 patients of your experience, could we have avoided by using antioxidants, like how it is being promoted by gastroenterologists to use antioxidants for managing patients of pancreatitis?
Well, my own view about antioxidants is that it is
There is as yet not enough data to support its widespread use. The use of antioxidants in the Delhi gastroenterology paper were negated by the Anticipate study from Manchester. I think the first thing you need to do in a patient with chronic pancreatitis is to study the morphology of the gland, and if there are anatomic pathomorphologic changes, it's really a brave person who would give antioxidants rather than address the pathomorphology. And so I think it's a little bit like, the cat closing its eyes and thinking the world has come to an end. If antioxidants were the answer for most of our diseases, then the best answer is to add it to salt, like iodized salt. And I think the data is still forthcoming. I think I would be very cautious to use antioxidants and presume that these patients don't get cancer. The problem that I referred to was the difficulty in getting, a screening test for pancreatic cancer. If you have a mass, then you can target it by an EUS biopsy or even a percutaneous biopsy. But even there, because of the extreme fibrosis in the gland, the cellular yield of the aspiration is poor. Often biopsies return negative. But of course, we must do biopsy ad nauseum. But in a screening situation, there is no mass in the gland. The patient has mild symptoms or no symptoms. And you think that this condition is pre-malignant. How do we go about prevent or at least picking up cancer when it just occurs? And that's really a big challenge at this moment. I don't think there is any data to suggest that antioxidants prevent cancer. If you have any information, please do share it with us.
Thank you, sir, for the lovely presentation. I'm Dr. Sen from Kolkata. This is one question: at what stage do you get your chronic pancreatitis patients, and when do you decide to operate? I mean, how do you decide to operate?
Well, we use an ABC approach to chronic pancreatitis. Patients who have no pain, patients who have pain but no complications, and patients who have complications. They may or may not have pain, such as chronic pancreatitis, portal hypertension may not have pain, for instance. An asymptomatic patient is usually assessed for the pathomorphologic changes to address if there are any gross pathomorphologic changes. We've even found cancer in chronic pancreatitis in a relatively asymptomatic patient. So we need to study them carefully, treat the type 3C pancreatic diabetes, and counsel them and keep them on follow-up. Patients who have intractable pain, then we use, again, imaging to assess the ductal and parenchymal morphology. Patients who have isolated head disease, patients who have low stone loads, patients who have ductal disruptions, patients who have cholangitis as a result of biliary obstruction will receive endoscopic therapy, whereas those who have diffuse strictures and stones, patients who have mass lesions, patients who have normal sized ducts with intractable pain, and those where the diagnosis of cancer is in doubt, then of course surgery is the best alternative.
Thank you.
Good morning, sir. Hello.
Yeah.
Hello. Sir, good morning, sir.
Morning.
Sir, I'm Dr. Umlak Reddy from Hyderabad, sir. Hello.
Yeah.
Yes, I can hear you. Go ahead.
Yes. Two questions, sir. About the intraoperative frozen section. So in last 50 cases, sir, two cases we have identified malignancy prior based on the diabetes CA99 and MASD. 3 cases intraoperatively with the frozen section we have identified the patient is having malignancy. And 3 patients post-operatively they came with the metastasis. So the incidence as per the literature, the 3%, I think the incidence are increasing probably. The 3% is not I could not say it in my practice. And what is the role of intraoperative frozen section routine? First point. Second, and taking that frozen that tissue for the any genetic analysis for further follow is the first question, sir. Second question about
I think you get him answer first.
Yeah, you already asked 2 questions. The first is that you what type of, let me ask you a counter question. How did you do the intraoperative frozen section? Did you use a biopsy gun? Did you use a transduodenal approach? Did you use a, from the surface of the pancreas? What did you do?
No, sir. Whenever I do trace procedure, sir, whenever we core the head, we'll take the bits from the head and then body, then tail, different tissue. We label it. It will send for the frozen section. Meanwhile, I'll be doing the Rolu Pandal. I'll prepare that. Meanwhile, we'll get the frozen section. Based on that, I'll go ahead whether to go for the ripples or continue with the brace.
One of the options, if you are looking at the head, is to do a I think it's, while we did publish in the Indian Journal of Gastroenterology a formula of how to deal with these patients, I think I've come away from doing a routine frozen section in all patients. I think if the tissue is abnormal in the head or in the body or the tail, then of course you should do frozen section. If you have a irregularity in the pancreatic duct after removing the calculus, then again you do frozen sections. Of course, it's not easy to get a positive report. As far as the 3% and that it's an understatement is perhaps not true, because you are operating patients at one end of the spectrum, patients who have intractable pain, patients who have complications, and obviously one of the complications is cancer. So perhaps what you should consider is using a heightened preoperative assessment program with a preoperative EUS FNA. In fact, we have a paper in the pipeline which talks about the only group in which a preoperative EUS biopsy should be used ad nauseum, not just one, maybe several, including rapid on-site examination, ROSE, so that you can identify these patients beforehand. And if you can, then of course you can take them down a different path with the hope that they can have a R0 resection. So that's my response to your question. What was your second question?
One more thing, as you said, based on the morphology intraoperatively, you can suspect malignancy. In few cases, we feel like this definitely will come malignancy, but it didn't turn. But in few cases, we never thought the patient has come out of malignancy. That's why I am asking you to direct us to take this tissue for further any genetic analysis, microRNA analysis, and at least for the follow-up, and to have a future study.
I'm not sure you will get enough data. You'll get enough positivity. None of these figures which I presented in my slides are as yet acceptable for routine use. The data is quite heterogeneous. It's not that if you have mRNA 148, it's only chronic pancreatitis, and if it's 211, it's cancer. We haven't quite reached that stage yet. So as a preoperative blood screening, serum screening test, it's okay. But on an intraoperative specimen, if you get the report a month later after genetic analysis, it's not going to help the patient very much, by which time the histology itself has told you that it's malignancy. So for the moment, I think genetic studies should be relegated to the research lab with the hope that it will bring up something in the future. But for the moment in clinical practice, I don't think it's going to make a big difference to your patient strategy. I really appreciate the point you said about the surgeon's inability to assess cancer versus chronic pancreatitis adequately. I think this is a wonderful comment, because it is really true that a heightened sense of suspicion, willingness to be patient in the head coring, to send all the entire head coring specimen, if you can, for the histology and wait, not even construct the loop, but wait, and then do the anastomosis is a wonderful approach, because it will save you the embarrassment of doing the wrong operation for the wrong patient.
Yes, sir. This may not be helpful for this patient, but for the future genetic analysis, for the future research, that's what I am asking to direct.
Yeah, I would definitely think about what you're saying. The question is, which markers must you do?
I have 20 specimens with me, preserved at 47 degrees. So
I certainly will contact you very soon with whatever information I have, and we can work out something.
Sorry.
I think one more question.
Good morning, sir.
Morning.
Morning, sir. Sir,
Morning.
considering the fact that chronic pancreatitis is a risk factor for a pancreatic cancer, and as you mentioned that preoperative biopsy is a little difficult to diagnose it conclusively. So are you suggesting that should we consider a low threshold to do a pancreatectomy instead of doing a praise so that we can diagnose them better?
We've gone over this many times in past meetings. Obviously, we have three groups of patients. We have a group which is obviously benign. We have a group which is obviously or very strongly malignant. And in each of these groups, it's very easy to take the appropriate decision. And you have an intermediate group, which is a gray zone, which is a variable size. And that is the problem. I urge you to do many preoperative biopsies, to use rapid on-site examination. The US scope remains in the patient. The FNAC needles keep going in and out until you have reasonable certainty that the entire diseased area has been targeted. And then you have a reasonable idea that it is not cancer. If you have a serious doubt at the end of the day, then a Whipple is perhaps the best answer. But please do remember that if you have adenocarcinoma, assuming you have an R0 resection, you may expect to have a median survival of say 30 to 35 months. If you have a chronic pancreatitis, benign, and if you do a Whipple resection, you're going to condemn the patient to a lifetime of pancreatic insufficiency, micronutrient deficiency, vitamin deficiencies, and this is a living hell because the patient doesn't die out so quickly as the patient with cancer, and the patient will have many years of poor quality with extreme pancreatic insufficiency. In the West, all pancreatic enzyme preparations post-operatively are supported by the insurance. In our country, it's not so. So once the patient is discharged from hospital, they have to pay for their own pancreatic enzymes, and that's a major recurrent expenditure. And that's something I would not like. I would much rather have, be closer to the reality, even err occasionally on the size of not resecting a cancer, rather than going overboard and resecting all the benign ones.
Thank you, sir.
Thank you. Thank you very much. No further questions. Okay. Yeah, last question.
Sorry, sir. Ramesh, sir. Again, I am Dr. Umlak Reddy. Sir, this is regarding mild raise of ALP without jaundice before going for praise. So if you leave like that, they are developing jaundice in 3 or 6 months. So whether to do prophylactic biliary bypass also, or leave it like that, or go ahead with the after praise, go ahead with the stent.
I recommend that you commence the operation with a catheter in the cystic duct and do an operative cholangiogram, which case you will see a narrowing no doubt in the lower end. You will also be able to map the extent of the narrowing, the extent of the biliary dilatation, the quality of the bile duct in terms of thickened bile duct, the degree of inflammation in the pancreas and the peripancreatic area. On that basis, proceed with head coring with the cannula still in the cystic duct. Repeat the cholangiogram imaging any number of times and see whether there is a free flow into the duodenum. If there's a free flow and the dilatation is not much, then I do not suggest you do a second procedure in the form of a biliary drainage prophylactically, because you have taken care of the focus of the inflammation in the head, and the more thoroughly you take care of it, the less likely the patient will have postoperative biliary problems. So I would recommend that you use an operative cholangiogram guided, thorough head coring, and then take an assessment at the end of your head coring.
Thank you, Professor Ramesh.
Thank you, sir.
Excellent lecture. Thank you very much. I close this.
Now, I would like to call upon our esteemed dignitaries, Dr. Sandeepan Jain sir from Jaipur, and we have another esteemed dignitaries on virtual platform, Dr. Naganathan Babu Obla, to chair the session on what are the borders in borderline resectable pancreatic cancer. Dr. Sandeepan Jain sir is currently Director of GI, Minimal Access and Bariatric Surgery Department, Fortis Escort Hospital, Jaipur. Dr. Naganathan Babu Obla from Chennai, he is Professor of Surgical Gastroenterology in Institute of Surgical Gastroenterology, Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai. Sir, dice is yours, Sandeepan Jain.
Good morning, all. I welcome Dr. Chetan Khantaria, who is a renowned surgical gastroenterologist from Mumbai. All of his education, right from graduation to postdoc, is from AEM Mumbai, and he is presently working as professor and head Department of Surgical Gastroenterology, KEM Mumbai. Welcome, Dr. Khantaria.
I just wanted to share that Chetan sir is my mentor, so I'm really glad to Chetan sir on that.
Good morning, everybody. Respected chairperson, seniors in the auditorium, colleagues and friends. The topic of my today's discussion is defining the borders of the borderline resectable pancreatic cancer. So we all know that the pancreatic adenocarcinoma could be either upfront resectable or non-resectable. And between these two spectrum is an entity called as borderline resectable, which accounts for as high as 30% of patients. Though the term borderline resectable pancreatic cancer was first adopted by NCCN in 2006, it was only in 2016 that IAP consensus statement was issued, which defined it properly, including anatomical criteria, biological criteria, and conditional criteria. So the anatomical definition, it essentially involves the proximity and relationship of the tumor with the surrounding blood vessels, which makes them at a high risk for obtaining a margin positive resection, especially when surgery is used as an initial treatment strategy. However, these are the tumors which, if neoadjuvant therapy, either a chemotherapy or a neoadjuvant chemoradiotherapy is given, there's an increased chance of obtaining R0 resection. Biological criteria are findings that raise the possibility, but not certainty, of extrapancreatic metastatic disease. And conditional criteria are essentially host-related factors, which takes into account the performance status and comorbidity. Here it is very important to understand that these criteria are applied even when a margin negative resection is considered likely following a upfront surgery strategy. So even if you can do a margin negative resection, but because of the performance status and comorbidities, these are labeled as borderline resectable pancreatic cancer. Now coming to the anatomical criteria. So these criteria are essentially defined making use of a MDCT images. So as I said, in contrast to the surgery first approach, these patients are likely to benefit from neoadjuvant chemotherapy to reduce the likelihood of R1 resection. And these are the patients who would require more often than not a vascular resection. So now let us look at into what are the criteria which are taken into consideration. So we take into consideration the superior mesenteric and portal vein axis, the superior mesenteric artery, the common hepatic artery, and celiac axis. So to the left, you see that there is the diagrammatic representation of the involvement. So we have three commonly accepted criteria. That is the MD Anderson Center criteria, which is essentially they have done a pioneering work in BRPC. We have the AHPBA SSO SSAT criteria and the NCCN criteria, which we like to follow very much. So coming to the superior mesenteric vein and portal vein axis criteria, it takes into account short segment occlusion, which is amenable to resection and or reconstruct. As far as AHPB SSO SSAT is concerned, it takes into consideration abutment more than 180 degree or occlusion, which is amenable to resection and reconstruct. And NCCN takes it that whether it is more than 180 degree or equal to less than 180 degree, or whether there is irregularity vein or thrombosis, it should be amenable to resection and reconstruction. As far as SMA abutment is concerned, there is unanimity in all the three criteria. They take into consideration that the abutment should be less than 180 degree, and that's it. As far as the common hepatic artery is concerned, again, the abutment should be of short segment, and you should be able to reconstruct and resect and reconstruct it. So again, there is unanimity. As far as celiac axis is concerned, there should be either abutment or no encasement, and as per NCCN, it should be less than 180 degrees. So these are the anatomical criteria defining the borderline resectable pancreatic cancer. Now, Japanese Pancreatic Society have further, in their 7th edition, classified the vascular involvement into venous invasion alone or with associated arterial invasion. So accordingly, BRPV means it invades only the superior mesenteric and portal vein axis. BRA denotes that it involves the arteries as well. And when both venous and arteries are involved, it is graded as BRA. Obviously, the BRA has significantly worse prognosis as compared to BRPV, that is the involvement of the venous system. Now, going down further, it's important to also know the extent of the tumor involvement of the superior mesenteric vein, taking into consideration its relationship with the border of duodenum. So if it extends, if the tumor invasion of the SMV extends up to the head of the duodenum, then it is considered as a resectable tumor, and you can go ahead and resect. However, as seen here, if it exceeds, if it goes beyond the, involves the head of the inferior border of the duodenum, then it makes it unresectable. So there is a classification proposed which takes into account the involvement of the tumor of the extending into the SMV up till the head of the duodenum. So they classify into group A, which remains until the superior border of the duodenum. Group B, which is till the center of the duodenum. Group C, which involves up till the inferior border of the duodenum, and group D, which exceeds the inferior border of the duodenum. So group A, B, and C are resectable, whereas group D is unresectable. Now, coming into taking into consideration the portal vein involvement, Nakav et al. Have classified, depending upon the involvement of the portal vein, into 4 grades, that is A, B, C, and D, where A is normal. B, as you see, is the unilateral involvement of the narrowing of the portal vein. C is bilateral narrowing of the portal vein. And D, as you see, is there is complete obstruction with collateral veins around it. So obviously type A and B have significantly better prognosis than type C or D. Now taking into consideration the relationship of the tumor involvement with proximal draining jejunal branch into the SM. So ideally, the borderline resectable malignancies should not have any contact with the most proximal jejunal branch which drains into SMV. But the problem is that it is very difficult to identify which tributary of the SMV is invaded by the tumor, whether it is the first jejunal branch or second jejunal branch. Besides this, these jejunal veins itself have a lot of anatomical variation. Very rarely you get separate first and second jejunal branch draining into the SMV. Hence, though it was proposed to include this in NCCN guideline 2016, it has not been included in any of the consensus statement. And instead, the duodenal margin criteria, which we saw earlier, is taken as a surrogate of involvement of the jejunal branch. Now we come to take into consideration the root involvement of the tumor to the root of GDA and celiac. So as far as the root of GDA is concerned, it is very akin to the involvement of the short segment of common hepatic artery. So if it is just abutting and you can reconstruct it, then it becomes a resection. As far as the celiac axis is concerned, radical distal pancreatectomy with R-block celiac axis can be successfully performed even if there is invasion of celiac axis without the involvement of the GDA. However, point to be noted is that it is not a common procedure and it is considered as locally advanced malignancy and not borderline resectable pancreatitis. So to cut the story short and to make it very simple, the common theme for anatomical criteria for borderline resectable pancreatic cancer is one should be able to reconstruct the SMV portal vein axis or the hepatic artery involved with the tumor, and most importantly, exclude tumors involving greater than 180-degree involvement of the SMV. So this essentially are the two important factors of borderline resectable pancreatic cancers, the anatomical criteria as far as it's concerned. Now coming to the biological definition. So these are tumors which are potentially resectable anatomically, but they have clinically suspicious findings which suggest but do not prove, are not proven of distant metastasis. So most important of them is CA19-9, more than 500 units, and presence of regional lymph node metastasis, which is diagnosed by biopsy or PET-CT. So this one study has shown that how involvement of CA19-9 alters the survival in months after resection. So as seen in this chart, if your CA19-9 is within normal limits, the median survival in months is 28.5 months. If it increases more than 500, then it decreases to 15.4 months. And if it is more than 2000, then it becomes 12 months. Now coming to conditional criteria. So this essentially takes into consideration the ECOG status, which is the important host-related prognostic factor. So it has been seen that performance status of more than 3 or 4, these patients are not suitable for surgery regardless of tumor stage. Because usually you find that they have less response to neoadjuvant therapy, they have increased post-operative morbidity and mortality, and overall very poor prognosis. So again, this study has shown that when the performance status is more than 2, that is 3 and 4, the survival in months decreases to as low as 3 months and 4.6 months. Now, an important point is as far as borderline resectable pancreatic cancers is concerned, we need to practice follow certain techniques to improve the R0 resection or to have an increased R0 resection. And these include the artery first approach, various vascular resection techniques, including the reconstruction of the superior mesenteric vein and portal vein axis, creation of temporary or permanent venous shunt, arterial divestment, arterial resection and reconstruction, Appleby's procedure. Follow the concept of mesopancreas and total mesopancreas excision and the triangle operation. So this is the artery first approach. Various approaches have been mentioned. You have a superior approach, an anterior approach, left posterior approach, mesenteric approach, uncinate approach, and posterior approach. So we in our practice follow a combination of the left posterior approach and uncinate approach, each one to himself, whatever he is good with it. The advantage of artery first approach is that you come to know the involvement of the vessel very early in the stage of surgery before you do, without committing yourself of going ahead with surgery, even if it is when you know that there is involvement. Now coming to the portal vein SMV resection and reconstruction, this is essential factor that the surgeon should be trained in performing vascular anastomosis. So you could perform either an end-to-end portal vein SMV anastomosis, or make at times, if the length of resection is more, then could use autologous IJV graft as shown here to reconstruct the portal vein. Now coming to arterial divestment. Now this is very important. Normally what we do is we would clear the vessel just here, but many a times we find that the tumor is involving the adventitious tissue. It becomes very important that you clear off or divest the artery from here. And when it extends beyond the adventitia, it is important to get an R0 clearance that you do a subadventitial divestment. It's very important to do an arterial divestment in patients with BRPs. Now coming to the concept of PME in pancreaticoduodenectomy, that is excision of the mesopancreas. This is very akin to the procedure which we are very well aware of in colorectal surgery, where we do a total mesorectal excision to increase the lymph node yield and to get complete clearance. So here, the mesopancreas is a well-defined structure, vascular fibrous structure, which lies posterior to the head of pancreas, which extends to the mesenteric vessel. And it is very important that when you do an upfront surgery in patients with borderline resectable pancreatic cancer, that you excise this mesopancreas, thereby increasing the chances of R0 resection. So depending upon the extent of mesopancreas excise, you have grades of mesopancreatic dissection, where level 1 is dividing the mesopancreas, leaving behind nerve and lymphatic tissue surrounding the SMA as it is. Level 2 is when you systematically remove all the lymph nodes adjacent to the SMA, and including the ligation of the inferior pancreaticoduodenal artery at its origin. And level 3 is when you entirely clear the cuff of autonomous nerves from the right and posterior circumference of SMA. And all this will definitely help to improve the R0 resection. So this is the mesopancreas. This is how it should, your operative field should look after the complete clearance of the mesopancreas. Now coming to the triangle operation. Now, the essential difference between the excision of the mesopancreas and triangle operation is that mesopancreas is followed when you do an upfront surgery, whereas triangle operation is something which you do following a neoadjuvant therapy being administered prior. So this is the algorithm which has been proposed, which one needs to follow. So you have a borderline or locally advanced pancreatic cancer who has received a neoadjuvant therapy. And if the patient is stable, you take up the patient for surgery. And at surgery, you take frozen sections from critical sites, that is the celiac axis, hepatic artery, and SMA. So if there is no vital tumor, means no tumor positive, then you go ahead and do a triangle operation with arterial resection. Whereas if there is a vital tumor, that means there is malignancy, so it becomes unresectable, and you do a palliative surgery. So what you do in this surgery is that you completely clear off the vessels of all its fibrofatty areolar tissue and make it bare clear, as you see this triangle, which is comprises of portal vein SMA, and the hepatic artery. So this triangle is completely cleared, which ensures an R0 resection in these patients. Now, this is a very nice algorithm which helps to make an intraoperative decision in cases where there is celiac axis or SMA involvement. So you have a viable tumor on frozen section, which you have taken from the suspicious arterial side, that is the celiac axis and SMA. If it is there, then you do a complete divestment possible. See whether complete divestment is possible. If it is yes, then you go ahead and do an arterial divestment plus the triangle surgery. If it is not possible, and if there is limited involvement of the artery, and you can resect it and reconstruct it, and if the patient has no comorbidities, then go ahead and do an arterial resection and reconstruction with the triangle dissection. If this is not possible, then no surgery, it becomes unresectable, and you go ahead and do chemotherapy. If the frozen specimen shows no viable tumor, then you go ahead and do a level 3 dissection with dissection of triangle. So this is an algorithm which explains how you go about intraoperatively if there is involvement of the celiac axis and SMA. So once when you report it, so this is how a classification of BRP, borderline pancreatic cancer should be given based on anatomical, biological, and conditional aspects. So if you have anatomical criteria positive, you report it as BRA type A. If biological criteria is also positive, then you give BRA type A, and along with A, then you give it type A and B. If it is not, then say BRA type A yes and BRA type B no. If conditional is also present, then you would say BRA type C present. If an A and B are, then the A, B, and C positive. So finally concluding and summarizing, so the anatomical borders for the borderline resectable pancreatic cancers as far as the SMV portal vein access is concerned is tumor contact of 180 or more with the ability to excise and reconstruct the vessel. As far as the arterial invasion is concerned, the SMA and celiac axis should be less than 180 degree without stenosis or deformity, and with the ability to excise and reconstruct the anatomy. As far as biological factors or borders are concerned, it includes CA99 level more than 500 and presence of regional lymph node metastasis diagnosed on biopsy or PET-CT. And for conditional orders, it is the performance status of 2 or more as defined when we have defined. With this, I end my talk. Thank you.
Thank you so much, sir, for your excellent talk. The house is open for discussion. And may I take the first question, sir? Sir, around 15 to 20% cases, we see anomalous right hepatic artery from SMA. Suppose that is involved. So is there any criteria for that also to define it, whether it's a normal kind of tumor or we still call it a borderline resectable?
So anomalous, this is considered as a borderline resectable.
It is included in the definition. Yeah. And the second question is, what are your recommendation and practice regarding borderline resectable? Do you go for surgery or do you recommend neoadjuvant for all of them?
So we usually in our practice follow neoadjuvant therapy. The important reason for this is to understand the tumor biology. It will give you, because it is ultimately the tumor biology which is going to dictate the outcome. So these are essentially tumor borderline where you, even if you do an upfront, you would likely to get an R0 resection, but you do not know what is going to be their outcome. So in our practice, we all give them neoadjuvant chemotherapy, not chemoradiotherapy. We give chemotherapy, wait and reassess them, and then take them up for surgery.
Yes, thank you, sir. Excellent lecture. I just wanted to add one more clarification. You said that when you do a distal pancreatectomy celiac section, you would also prefer to take the GDA along. The classical teaching which we are following in practice also is that the GDA must be spared when you do a pancreatectomy. You don't do the surgery when the tumor has crossed that particular point.
No. I was saying that I had taken two factors, involvement of GDA and celiac axis separately, though I included together. So I said involvement of GDA is just akin to involvement of common hepatic artery. So the approach is same. Celiac axis is a totally different this. So you don't include GDA in your distal pancreatectomy.
Understanding slide was
No. Actually, what it was, this relationship of the tumor with respect to GDA and celiac axis. So maybe it got conveyed wrong.
The second point, what I wanted to clarify is that you do a triangle resection. Do you still prefer to take off the splenic vein section from the fourth vein so that you can get access to the superior border of the superior vessel?
So no, we don't do that. We don't do that.
Doctor, sorry, not a question because unfortunately I'm not able to attend or concentrate on the presentation. So it's just an announcement for the students who have joined online. Although Dr. Chetan has covered the topic very well, but if you want to read even more about borderline resectable pancreatic cancer by former fellow Dr. Kailash Kudia, he's done a very good review on borderline resectable pancreatic cancer in Indian Journal of Surgical Oncology. So get it from the PubMed. If you can't get it, then email me, vkkapoor.india@gmail.com. Just write DRPC in the subject of the mail. That's a very good review he has done in.
Yeah, he has summarized and sir is also co-author, and they have summarized the entire presentation, entire into nice 2-page article.
Good morning, sir. Can I make some comments?
Sir, please.
Said you don't do radiotherapy. Free of bank.
No, sir. Because of logistic reasons, we are not giving radiotherapy. Though Prioprank has proved that there is important radiotherapy is as very important neoadjuvant therapy. We need to refer these patients for radiotherapy to a different center. That is why we are just following chemotherapy. Otherwise, Prioprank has proved beyond the doubt that neoadjuvant radiotherapy is very important.
I think we'll take the last question. The waiting period between the neoadjuvant chemotherapy and surgery. And before that, how to grow tissue because without
so essentially, waiting period is 6 weeks. And as I said, essentially this borderline resectable pancreas, you could otherwise also do an upfront surgery. You are doing it only to improve the R0 resection rate. So you basically depend on imaging and don't do a preoperative biopsy.
won't give you.
They won't give. You have to prove the malignancy.
JSF.
Yeah, US. It is US guided. Yes.
Good morning, sir.
Right.
Hello. Am I audible? Am I audible?
Dr. Opla is on.
Yeah. Thanks for Professor Chetan Gandaria for your comprehensive lecture on this complicated topic. So now all the society guidelines have evolved. Now we can correctly make a diagnosis, the type of borderline resectable cancer. And as you said, the biological factors and conditional factors also play an important role. So now it is better to assess the condition of the patient. In a frail patient, in very sick patients, there's no point in evaluating. We can just send the patient for palliation. And other patients, those patients will require various, multidisciplinary discussion and then treatment with the neoadjuvant therapy and following the re-evaluation. So all these points you have brought out, and also surgical techniques also you brought out nicely. And so the success will depend on the proper evaluation and then the proper treatment, including the neoadjuvant treatment, and then the appropriate surgery. Mostly these surgeries will require vascular resections. So comprehensive treatment would be a neoadjuvant, followed by appropriate surgery, followed by adjuvant treatment. So this should be the carry-home message to the delegates. Thank you for a wonderful lecture.
Dr. Chetan,
Thank
you very
you.
much.
Thank you very much for your such a elaborative and descriptive lecture on such a complicated topic of borderline resectable pancreatic cancer. So now I would like to chair our next session, which is another one is a very important and the topic which we are going to deal in our day-to-day practice while doing pancreatic. So to chair that session is algorithmic management of post-operative pancreatic fistula. I would like to call upon our esteemed chairperson, Dr. J. Mehta, sir. Dr. J. Mehta is retired as professor and head surgery, SMS Medical College, and he is presently working as senior consultant surgery and DNB guide at Narayana Multi-Speciality Hospital, Jaipur. He was trained in surgical gastroenterology at Royal Infirmary, Glasgow, UK, and was also president of Indian Society of Gastroenterology 2008 to 2009. We have another the esteemed chairperson, Dr. KJ Singh from Chandimande. Dr. KJ Singh is Brigadier KJ Singh is professor and consultant GI surgeon at Government Command Hospital, Chandigarh, a graduate and postgraduate from AFMC, and did his postgraduate training in GI surgery from GB Pant Hospital. That is yours, sir.
I'm thankful to Professor Kapoor for asking us to chair the session. And immensely, I'm grateful to him for bringing or raising the level of academics in state of Rajasthan and especially in Jaipur regarding the hepatobiliary pancreatic surgery. I invite Dr. Sadaf Ali from Kashmir for talking on pancreatic, post-operative pancreatic fistula. He is working in Sere Kashmir Institute from Kashmir, and she has done her training in surgical gastroenterology from Nizam Institute, Hyderabad. Thank you very much.
Worthy chairperson, respected seniors, friends and student audiences, a very good morning to one and all. At the outset, I need to thank the organizers for giving me this opportunity to talk about algorithmic approach to post-operative pancreatic fistula. As we all agree that most of the things in concern with pancreatic surgery is in the light of the International Study Group of Pancreas, so is the classification as well as definition. Any amount of drained fluid with amylase more than 3 times upper limit of normal is labeled as pancreatic fistula. Conventionally, it was classified into grade A, B, and C, but of late, after the latest meeting, it has been put up into 2 subsets. Grade A is the biochemical fistula, and B and C are clinically relevant fistula, wherein grade B is a fistula which has symptomatic symptoms which require change in the routine post-operative management protocol, the kind wherein your preparedness and proper management would lead to success. And on the other hand, grade C fistulas have severe symptoms, the requirement of aggressive diagnostic and therapeutic intervention, and this may end up in mortality in some of the cases. In regard to post-operative pancreatic fistula, we just cannot stick to persistent discussions on methods to prevent the fistula. Ample of work has already been done comparing various permutations and combinations, not leading to zero fistula. The concept to move on is very important. We need to agree to the reality that pancreatic fistula would remain till when we continue the complicated and challenging surgeries of pancreatic resection and pancreaticoduodenectomy. To anticipate a fistula is equally important as to avoid a fistula. It's time to contribute to how best we can manage a fistula, wherein your step-up approach will beat the stepping up of the fistula from a less severe grade to more severe grade with high mortality. And this would in turn avoid prolonged hospital stay as well as general things to be considered is identifying the subset of patients that are at risk of developing the post-op fistula, to take adequate measures to prevent the occurrence of same, to have a systematic protocol in place for early diagnosis, and to treat the fistula as per current guidelines. As far as the risk factors are concerned, majority of the risk factors are not modifiable in relation to patient and pancreas, male gender, high BMI, disease for which the PD is being done, amount of abdominal fat, depth to excess, and the pancreas factors of amount of fat in the pancreas per se, size of duct, high-risk disease, dense acinar cells in the pancreas, and broad and thick pancreas are some of those factors. Wherein the majority of the modifiable factors are those which are related to procedure, the amount of blood loss, maintaining a good vascularity. Considering your result, you need to stick to a method of anastomosis or reconstruction. We need to add medications only in the light of scientific evidences and individual case requirements. While operating, we always need to keep in mind that this is the best time to do whatever we can for modifiable factors. Other important modifiable factors are preparing the patient well nutritionally in the waiting period when you're searching for a slot for surgery, and taking care of nutrition supplementation in periop period. There are various risk assessing scoring system, wherein commonly most of the centers do follow the one suggested by Calgary et al. A score of 7 or more is very, very highly likely to have a post-operative pancreatic fistula. This is a study from BMC published in 2020, where the authors have looked into various factors which lead to occurrence of post-operative fistula. Both on univariate and multivariate analysis, they have seen that the combined vascular procedure and the texture of pancreas just intraoperatively are the commonest ones which have a statistically significant relation to occurrence of post-operative fistula. They have also seen a tune of as high as 45% occurrence of post-operative fistula in patients who had a visible fat of more than 0.4 in presence of soft and serrated pancreas. We have evolved a long way trying to master the techniques, looking into Sir Blumgard's view sutures and trying to come near to this 5% post-operative rate, modifying it further from side to side to end to side, ductal mucosa, invaginations, long segment invagination, four-layer invagination, taking it to more sophisticated levels of minimal handling of laparoscopic and robotic approach, using mitigations like stents, debating between the use of pancreaticogenictomy versus gastrostomy. But in most of the very well-planned randomized trials, giving due consideration into the variables which are important, like soft and hard pancreas, the results are very, very heterogeneous, not coming to a conclusion of suggesting a kind of anastomosis or a method of mitigation and abandoning the other. So what is ultimately very important is if you have taken due care of all those factors, you need to look for occurrence of clinically relevant fistula as early as possible in post-operative period. This is a paper in HPP 2019, wherein the authors are looked into around 3,000 odd publications in relation to the relevant factors leading to early diagnosis of fistula, selected 37 publications for further analysis. Majority of them were in context to Brentford amylase. And these are some of these 17 variables which are likely to predict early occurrence of post-op fistula, of which the Brentford amylase is the commonest one. So in patients who are undergoing pancreatic surgery, the unit should have a well-organized daily evaluation system in place. There should be a more vigilant anticipation in high-risk pancreaticogenictomy, starting from post-operative day 3 for early recognition. We need to pick up a complication before it is clinically evident. This will considerably decrease the failure to rescue rate. As it is that majority of the biochemical fistula do not need any intervention, the concern is treating the relevant fistula. A systematic approach and deviation from fast track protocol is required in most of these cases. The initial management is goal-targeted fluid therapy, electrolyte management, broad spectrum antibiotics, and taking good care of nutrition. The parameters to be assessed more vigilantly are clinical ones of vitals, volume and quantity and quality of drain, and biochemical ones, CRP, WBC count, and drain fluid amylase. If there is a biochemical fistula, we need to correlate it with other parameters. If the drain is functioning in place, we need to secure it well. Especially in case of grade B fistula, you might have to leave it for 3 weeks or more. In case the drain output has abruptly decreased or has stopped and pointers of grade B fistula are there, we need to consider ultrasound for ruling out any collection. Consider CCT if indicated without hesitation, especially if USG findings of no collection does not correlate clinically. We need to focus on appropriate antibiotics, prefer enteral nutrition as far as possible, and use culture, especially drain fluid culture, as a guidance. The source control in these patients is extremely important to avoid general peritoneal soiling and to make the fistula more controlled one. The need of delineation of anatomy is also equally important. Measures to decrease output of fistula by adding somatostatin is one of the way of taking care after the fistula has occurred. Skin care, where the fluid pours out through the wound with the help of tumor bags and wound manager would be required. But ultimately, the definitive management in case of persistent fistula may end up in placement of an extra drain or a need of re-laparotomy. We need to keep our nerves to have low threshold for re-laparotomy unless all the conservative measures fail. There's massive hemorrhage with no IR facilities, and there is clear diffuse peritonitis with drain block multiple collections, not amenable to radiological intervention. This is a publication in JAMA a couple of years back, wherein the authors have looked into management of severe pancreatic fistula after PD. In a cohort of 309 post-op fistulas, majority being male, the overall mortality was 18%. 227 patients were managed with catheter drainage, 82 required primary re-laparotomy. In the catheter drainage group, the success was observed in 175. In a subset of 65 matched patients in either group, mortality, new onset organ failure, and multiple organ failures were all statistically significantly low in the catheter drainage group. So in present era, the focus of many researchers is on management of post-operative pancreatic fistula in an appropriate manner, and the end result is targeted to further decrease the mortality associated with clinically relevant fistula. The Dutch group of pancreatic cancer surgery has put an algorithmic proposal managing the patient from post-operative day 3, looking into indications of CT removal of drain. They suggest that the indications of CT are there if one of the following findings are picked up: a fever more than 38.5 degrees Celsius, CRP of more than 300 or more than 270 after both post-op or more than 100, which has failed to decrease or has decreased by less than 10% beyond 24 hours. With no other clear focus of major infection, need to go ahead. They suggest to go ahead and perform a CT. Or if two of the following are present: WBC more than 12,000, heart rate more than 90, respiratory rate more than 20, with drain fluid amylase more than 3 times the upper limit, then we need to perform a CT. They also suggest that if there's a clinical judgment by the pancreatic surgeon that there's a hunch for need of CT scan to be done, one should not hesitate and perform a CT. If a CT scan is performed, it has to be evaluated very nicely. You have to look for one of the criteria: low density fluid in relation to pancreatic anastomosis, any reasons of the anastomosis, or other suspicion of pancreatic leakage and complication. If none of them are then your antibiotic treatment should be okay to further dynamically assess the patient subsequently as and when demanded. And if they are there, then you have to look into whether the drains placed intraoperatively are in proper position. If they are not, then you have to relocate the drain, put in a percutaneous catheter drainage whenever technically feasible under the radiological guidelines. You should also take into consideration if an extra drain addition would be potentially beneficial. If yes, you should go ahead and put it. There are few cases I would like to share. Our unit has, on an average, we do 25 to 35 pancreatic tumectomy annually. This year, we had come across 2 pancreatic fistula. This is a case of a pancreatic tumectomy done for a huge obese male for a big ampullary tumor in post-operative day 8, wherein he had a biochemical fistula and with a grading of grade B because of the other markers. His drain abruptly stopped draining, and so a CT scan was done, which showed a collection in relation to the PJ and PJT, and you can see that the drain was not in the area where it was supposed to drain. Patient was managed successfully with placement of percutaneous drainage and was discharged by third post-operative week. This is another patient of pancreatic tumectomy, a female, wherein she had undergone PJ with type 1 40 vein reconstruction. This lady had a grade B fistula, was there already for 3 weeks. The drainage had slowly decreased and stopped, and the drains were removed, wherein she showed some signs and symptoms after a few days, for which a CT was demanded, and we went ahead doing it. The CT scan showed a few collections which were quite deep-seated, and this patient also had a serious fluid in the pelvis. With inconsistent radiological senior faculty, A plan was made to reassess with another CT of 48 hours, but this patient slipped into grade C fistula, had a significant GI bleed, with the source being in hepatic artery. This patient was again managed successfully by embolization of the vessel. So, as proposed by the Dutch group, they have already published their work in Lancet this year, wherein they have compared algorithmic-based care versus the usual care for early recognition and management of complications after pancreatic resection throughout Netherlands in multi-centric trial in a strap-wedge cluster randomized study. The end result where they have actually labeled the group of algorithm as intervention and the group of the usual care as control group. And they have observed that all the primary endpoints in context to the bleeding that required invasive intervention, organ failure, or 90-day mortality were statistically significantly low in the intervention group, as well as the secondary outcome in context to bleeding requiring intervention and new onset organ failure, especially the circulatory and the respiratory failure, were all statistically significantly low in the algorithmic approach group. At SKIMS, over last 15 years, we are comfortable doing a pancreaticostomy with a fistula rate of 13% overall cohort, and of late we have come down to 7%. We have shifted from classical use sutures to 4-layer invagination. We always try to give a couple of sutures through pancreatic duct, leaving it open into the inner layer of the anastomosis. We have evolved to pay a lot of heed to time given to PG of high risk, avoid any cut-through sutures, adequate mobilization of the pancreatic stump, and we always give a umbilical gap. We believe that volume of the center and HPP surgeon availability keeps a check on postoperative fistula. We do not operate upfront in any patient having bilirubin more than 15, and we always take bile for culture, especially in stented patient, which help us in managing the fistula with right kind of antibiotic. We do a DFA on first postoperative day, followed by every alternate day, a CBC and baseline investigation of third post-op, and then repeating as and when required. In case of pointers of fistula are there, we use CRP as a simple marker to guide further management. A dedicated post-operative monitoring of vital signs, symptoms are given due consideration. In patients with high fistula risk score, biochemical fistula in presence of any of the signs and symptoms of fever, high counts, unusual symptoms, ileus, nausea, inability to tolerate, or occurrence of a little bit of sentinel bleed, we start with a baseline ultrasound. We add octreotide and see if there's any positive response. We draw it after 3 to 5 days, if not much benefit. We do a CT scan in selective cases timely if we apprehend a deteriorating fistula. We add, manipulate, and secure existing drain as per requirement. With progressive improvement in experience of interventional radiological services at our center, the need to laparotomy is very low, and the mortality has decreased from 5 to 3%. I need to add a word about those who actually ultimately need laparotomy in case of refractory SIRS, sepsis, multi-organ failure, or sometimes when you don't have interventional facilities, hemorrhage. If you go in for a surgery, consider a thorough washout of the abdomen, draining all collections, and then ultimately wide drainage of the abdominal areas, especially covering the PJ side or the anastomotic side. Revision is suggested by some of the existing anastomosis. Conversion of PJ to PG can be another option. A ductostomy to make the fistula more controlled. And in some cases, completion pancreatectomy may be inevitable if there's a lot of pancreatitis and there's the necrosis of the stump. If these have been done and your patient has survived all the event, it's likely that the fistula would turn to become grade A and grade B, because the other kind of fistula when you operate is, of course, grade C. And this you need to continue with routine care. So in the end, the take-home message would be post-operative pancreatic fistula is an unresolved issue universally. We have progressed with sound scientific efforts in decreasing the recurrence of fistula from 40 to 15%. A focus beyond prevention should be how best a clinically relevant fistula can be managed with an algorithmic approach, anticipating the fistula, grading it correctly, proper decision making for the need of CT scan, because many a time CT scan done at the right time would be the game changer. Managing with venting out of leak, placing drains, rational use of antibiotic and nutrition, going in for laparotomy in required cases selectively will further improve the outcome in terms of mortality, morbidity, hospital stay, and expenses. We need to look into and embrace the concept of algorithmic approach proposed by the Dutch group and many other researchers in the country and come out with the results of its utilization in our subset of patients. Thank you, ladies and gentlemen, for your kind hearing.
Thank you, Dr. Saga. The house is open for questions. Please.
Professor Sedef Ali, thank you very much for your very comprehensive talk. As you clearly summarized, most of the patients respond to interventional radiologic management and general support, but some patients may require revisional surgery. What's your experience in revisional surgery, and what's your intraoperative strategy in these unfortunate cases?
Yeah. First, I would like to make few points that once there's a revisional surgery requirement, most of our indications in pre-interventional radiology era were for hemorrhage. When your fistula turns out to be grade C, there's a lot of necrosis and necrosing of the vascular layers and occurrence of bleed. Even a very rapid kind of intervention, control of bleed, end up in at least 40% of patients dying. They are the main patients whom we lose in post-operative period. And our particular experience is we have been able to salvage quite a few patients. Sometimes the bleed has been in the PG site, and the bleeder is usually at the posterior layer of the duct, and sometimes in the GDA stump. And we do not believe in redoing the anastomosis at the time. We are believers that we should do minimum by draining, putting, removing out all possible collections and trying to make the fistula more controlled. So that has always helped us in with better results.
Yeah. Yeah, it's coming. Okay. So first of all, thank you because you shared a lot of personal insight. I want your comments and maybe some two personal experiences. The first is that we moved from pancreatoctomy, and if I'm not getting into the debate of comparison between the two, reduction of it, but it seems to me that if you have done a pancreatoctomy, the management of the terms of the fact that you can easily diagnose it, the fact that it does not usually cause bleeding because you are well away from the GDA stump, and the fact that you have invaginated the pancreas parent. These fistulas are usually easier to manage. That's my impression. We do about 12 ripples a year. We are a medium. The second point is that we have shifted in the last 7 or 8 years to the soft JP drain equivalent available. And we feel that it works better, gets blocked lesser, and the management of both grade A and even to an extent the clinically significant is better. So it's much easier to manage. I thought.
Yeah, the J drain, the soft one are very, we don't have much experience because we have got it in the Jammu and Kashmir state very recently of late. I personally felt that the collection box with that
It's easily available and 800.
yeah, it's a little small one. It's not, there's no cost issue in that. And the other thing is that debate between pancreaticogastrostomy and jejunostomy, I think the group of Topel et al. Is suggesting a little favor of the pancreaticogastrostomy group. So are many other studies suggesting because of the reasons you have already told that, you can approach the anastomotic site more easily. There can be an addition of endoscopic intervention if it is a pancreatic stump bleed. But then the long-term follow-up of pancreatic gastrostomy, especially see the subset of patients whom we take for pancreaticoduodenectomy and are more resectable are the papillary and the better tumors. And the pancreaticogastrostomy of late, the long-term follow-up results, these patients live long, aren't very good. They have more of other long-term problems of exocrine insufficiency and the atrophy of the stump. So the debate is still on, and but there isn't any, I don't have any quoting that this would be better and we should. That's what I showed, that the results are very heterogeneous. And if I personally believe that whatever is good for your center, you have been doing with the check with international and national standards of results, one should continue with that kind of anastomosis, whether it's PJ or PG.
And I have a question for you from the chairman.
Yeah. Yes, sir.
Once in a while, you find that along with the pancreatic juice, there is a tinge of bile, either because the CBD was not dilated or very thin wall, the tumor was placed in the uncinate and you didn't have a dilatation of the. So does that lower the threshold of going in again? What is your experience on a tinge of bile along with the high amylase in the pancreatic?
I didn't get you in smaller hepatic ducts wherein the indications are such that
What I mean to say is, suppose you find that there is a tinge of bile in
Yeah,
the drain
yeah,
along with the POPS.
yeah.
What is your experience? Does it lower the threshold of your going in?
No, not exactly. The threshold of going in is otherwise also very low in our center. We are believers of step-up approach when most of the measures are impossible, because intervention in terms of percutaneous drainage of the collection, even we have to use multiple drains, is quite feasible, I think, in most of the centers, even under as simple as ultrasound guidance. But the bile tinge in the anastomosis gives you only a little indication wherein you have already anticipated also in pre-op period that you had done it for a cystic lesion and your bile duct was very small, non-dilated. Then I would suggest that you have to give due care as you give it for PJ for HJ as well, with PDS, fine sutures, and trying to make it more foolproof. But it doesn't change the kind of nature of fistula. We have 1 in 10 or 20 patients having a bile tinge. And invariably, we have seen that this bile tinge is very transient in nature, and then it becomes again the pancreatic kind of. Yeah,
Another
we
quick
don't
question, ma'am. You mentioned about the use of somatostatin analogs. You know, it's quite debatable. What is your experience in your center?
What we do is we use it for not much. We haven't done any particular study on somatostatin, but
When
as a
you
protocol
started?
and suggestion from the literature, we started if we have great B fistula, and we look into the results of a decreasing trend of the quantity of amylase in the drain fluid and the well-being of the patient. If we have any positive response, we continue it for quite some days, maybe a week or 10 days. Otherwise, we take a call and withdraw the drug by 3 or 5th course of
So you don't start it
3 or
in an
5 days.
anticipatory
No,
manner.
we don't start it anticipatory in any all the post-op patients.
There are two more.
In continuation with the so about the patient, but the say, may leak more. If at all PG leaks, the chance of death is very high. The reasons don't know as per the literature, as per the practice, and I got trained the institute where PG and PJ both are practiced. One consultant is Dr. Ramesh Athanari, PG, Dr. Mohan does PJ. So even we publish paper PG. So there we have observed in the literature also. If at all PG leaks, it kills the patient. But the chances are very, very low. If the PJ leaks, it won't kill. That is the best. For somatostatin, so is there any evidence? I'm asking. So is there any incidence if you observe that the chances of post-operative bowel ischemia, which is related to probably without SMA is good, iliac axis is good, but the patient develops bowel ischemia, probably because of factor.
I haven't come across a patient who has ended up in bowel ischemia and post-operative period. I keep my fingers crossed, sometimes thinking about not about octreotide, but if there's a portal vein reconstruction, and if I believe that there would be cases and thrombus occurrence. But
you use a
octreotide, I take it as a concern in obese patients with cardiopulmonary comorbidity, and because of the same reasons as you said that there would be vasoconstriction. But I personally don't have any experience. I would also like to have your comments on your usage of learning both the techniques, because most of us practice a particular technique because we are trained into that technique. What do you practice? You practice both, or you practice one of the two?
I practice now PGA. Initially, I used to do PG, but I always tell no tension, good vascularity, fine suture, consistent ductal mucosa, consistent practice of one technique is always advisable. Now I do PJ only, pancreatic. Initially, I used to do PG, then I converted to PJ. Even in lab, we do PG.
That is the theoretical possibility of bowel ischemia, and that is a concern even if we go very deep into root of mesentery, and Dr. Chetan was discussing regarding the jejunal vessels, the resection or injury in those cases as well. But I am yet to come across this kind of complication.
Central pancreas.
Yeah. Central pancreatectomy is again a different area. I haven't touched the areas of distal and central pancreatectomy, because distal, the leaks might be more, but the results are far better. The management is good. Mistake and the morbidity of procedure is not that much. And usually they are uneventful at our centers. And central is, the literature is very sketchy, maybe 3 or 4 comparative trials about the kind of suturing, the coverage given, the stapling kind, and the hands given. And of course, you have to anastomose the area which is not being drained with the PJ.
Dr. Reddy, just one comment before the next question on we have had an experience of bowel gangrene, and we assessed it to possibly because of using energy device very close to the SMA in trying to dissect the uncinate. So please be careful of that. Whatever the companies might state, there is a lot of heat generation, even with whatever Ligashore or a harmonic. So be very careful close to the SMA. And second is, sometimes if you use a stapler, a vascular stapler on the uncinate blindly, it may impinge on the SMA, because at that point in time, we are not actually palpating the SMA. So please be careful. That is possibly the reason. Very unlikely to be postoperative.
Definitely, while doing, we always safeguard the SMA.
Yes.
And if any complication occurs, being a surgeon, first we suspect ourselves. So for that, we did CT angio also completely. In that case, we have done laparotomy. There will be complete dusty, not complete dusty. It is depending gangrene patient. I observed in my PG days and in my practice. That too after laparoscopic.
Some injury to the
So when I called, I discussed with the people, I called my boss, same thing you've seen, same thing. It can happen.
Yeah. Can we have the next? Thank you so much. It was a wonderful presentation.
I think clinically we are all skeptical about. One of the important criteria is
Yeah, we have actually of late completed an outgoing postgraduate student thesis on the amount and the occurrence of positivity of dendritic amylase. I cannot give you the exact result, but we have seen the higher the level of the dendritic amylase, the more relevant the fistula is one. And second thing is that if you have an early occurrence of high level of say on day one, then the likelihood of occurrence of clinically significant fistula is high. The rest of the correlations with morbidity, mortality, I wouldn't be able to tell right now, but we might come up with the results and publish it very soon, maybe a year or so.
Thank you, Dr. Sadaf. That generated an excellent discussion. Thank you for my co-chairperson, and thank you, the
Thank you very much, sir.
Now we will have 10 minutes tea break. We will resume our session at sharp 11:20. Please be there.
So what time is mine? At 11:20? Yeah, I am on the platform. I am seeing, I was listening to the last speech. Okay. So I will present from here if there's any problem, and I have 20 presentation there that they can keep as a stand. That's up to you. If you think the quality, the problem is that the movie doesn't have a video. It doesn't have sound over because I was not able to give the sound to the movie. Then because I couldn't give the sound to the movie, I have tried my best. So I could give it to the slides, but couldn't. Though it is there, it is not. Yeah. Okay. சொல்லுங்க சீக்கிரம் சொல்லுங்க, நான் மீட்டிங்ல பேச ஆரம்பிக்கணும். சொல்லுங்க. எது? ஆமா. இல்ல இல்ல, நாம அது வரைக்கும் மண்ணு போட்டுடலாம், அவ்வளவுதானே. அதுக்கு நம்ம மண்ணு போட்டுடலாம். அந்த 5 அடி அவங்க தோண்டி நம்ம சைட்ல போட்டாங்க, அந்த 5 அடி நம்ம போட்டுடலாம்ல, நம்ம இடம் தானே. அவன்கிட்ட சொல்லிடுங்க, அந்த 5 அடிக்கு மண் அடிச்சிடுவோம்னு சொல்லுங்க. நாம அவன் தோண்டினா நாம மண் அடிச்சிடுவோம்னு சொல்லுவோம். அது நம்ம மண்ணை வெட்டினாலும் நம்ம மண்ணை போட்டு அடைச்சி சரிப்படுத்துவோம், அவ்வளவுதான். அது சரி. அதுக்கு நீங்க ஏற்பாடு பண்ணிடுவேன்னு சொல்லிடுங்க. பாலன்ல டாக்டர் வந்து ஏற்பாடு பண்ண சொல்லிட்டாரு. அதுக்கு மண் 5 அடி உங்களுக்கு அடிச்சு, ஏன்னா அது இங்க இடம், அது அவன் வாய்க்காடு அவன் தோன்றதுக்கு வந்து தப்பா தோண்டினா நம்ம அதுக்கு ரெஸ்பான்சிபிள் இல்லை. நாம மண்ணை போட்டுடுவோம்னு சொல்லிடுங்க. ஹலோ, சரி. bro. File hundreds of more letters. Making bother.
Salary.
Hello. Yeah, join a meeting, sign name. क्या हो रहा है ये? I'm not getting the join. I joined it. Is hello.
ऑडियो की वॉल्यूम खोल दीजिए लैपटॉप की ईपी.
Hello, hello.
बढ़ाओ और खोलिए. थोड़ा और बढ़ा दीजिए खाली.
There was much more calculi, mass lesions, complete duct block on ERCP, and poor health in patients with cancers and chronic pancreatitis. And the pain relief was
I think everybody have their cup of tea and snacks. So shall we start our session? So our next session is video session on minimal invasive pancreatic surgeries. To chair this session, I would like to call upon our esteemed chairpersons, Dr. Mahendra Narwaria from Ahmedabad. Dr. Mahendra Narwaria. Okay, and we have another the chairperson with us, Dr. Pitambaran, MS. Dr. Pitambaram, MS, is consultant surgical gastroenterologist at Avitis Institute of Medical Science, Palakkad, Kerala, India. Am I right, sir? We have another chairperson with us, Dr. Ramesh Rajan. Dr. Ramesh Rajan is professor and head Department of Surgical Gastroenterology, Government Medical College, Trivandrum. And we have our other chairperson, Dr. Sadiq Sikora, sir. Dr. Sadiq Salim Sikora is an eminent gastrointestinal surgeon with an experience of more than 28 years. He is currently Director Gastrointestinal Surgery at Sakora World Hospital. And we have our esteemed chairperson, Dr. Ajay Sharma, sir. He is my mentor, my teacher, my guide at presently where I am working. He is head of the Department of Surgical Gastroenterology at Mahatma Gandhi Hospital, Jaipur. A very fine, minimal invasive laparoscopic surgeon, currently to whom I learned a lot laparoscopic skills. So, sir, the dais is yours to chair the session on video session on minimal invasive pancreatic surgery. Sir.
Ajay, we start with Dr. Ramesh Arnari's presentation. He's already on.
Okay. We are about to start our next session. Just before starting our session, I would like to invite everybody for our next conference, which will be held in 2023, and dates have already been announced on 2nd and 3rd. This will be actually on biliary diseases and malignancies, and it will be organized in association with ISGO. It's a PG course at that time. So with that, I think I hand over my mic to my co-colleague to introduce Dr. Ramesh Adnari, sir, for the next.
Welcome all to this Jaipur Surgical Festival. And I'm very much happy to introduce my own teacher, Dr. Ramesh Ardhanari. He completed his MBBS from CMC Vellore, completed MS from All India Institute of Medical Sciences, then completed his MCH from MMC Chennai under Dr. Rangabashyam, and he has been conferred with honorary FRCS degree. I'm very happy that those 3 years, the training that he had imparted on me, that changed my whole life. Hereby, I welcome Dr. Ramesh Ardhanari to present this on topic on minimally laparoscopic distal pancreatic splenectomy. Welcome, sir.
Audiovisual team, please
The
allow.
audio is not available.
No, no.
Can you?
Yeah, please allow Dr. Ramesh to present it online, because in this video somehow the audio could not be recorded. So he wants to make a live presentation online. He's already there online. We stop the video.
Okay, stop the video, restart, and can we have a
have Dr. Ramesh?
Yeah, Dr. Ramesh Adnari on the small screen, please. Yeah, we'll have to restart this video. You can first show Dr. Ardnari on the main screen so that he can start, and then subsequently we can see the video. Yeah, we have Dr. Ramesh Rajan. He's our co-chairperson for the session.
Morning, everybody.
Hi. Morning.
He's joining.
Morning.
He's joining. He got disconnected. Yeah, please come.
First, can we have Dr. Ramesh Adnari on the online? Yes, yes. I think they have to first get him connected, and then subsequently we'll start the video. Video will start after he has joined. We have to see him on the screen and let him introduce what he is about to start. Let him speak, and then subsequently we'll start the video. So while we are getting connected, let me just have some inputs onto laparoscopic
pancreas, how many among the audience? Can I have the raised hands? How many of you are doing laparoscopic pancreas? 1, 2, 3, 4, 5, 6, 7. Oh, gradually they are increasing, and rest of the people are in T room. I think we are having 10 people here who are doing a routine lap PD or a lap pancreas. That is good. So we can have a good interactive session with these videos, because quite a good number of audience here we have who do a laparoscopic pancreas. So my co-colleague is asking that how many of you do distal pancreas and how many of you do PD? So first, you can raise your hands. How many of you do mostly distal pancreas only? Distal pancreas only, not PD. Distal pancreas. Okay. And how many of you do PD laparoscopically? Okay. So pancreas is TLVD. You have to present in your distal pancreas also. So anyway, that's a part. So I think since we have quite a few people who do distal pancreas laparoscopically, we have quite good number of sections on distal pancreatectomy laparoscopically. So can you just point out some important things for how and what steps that you do for what you guide for distal pancreas?
Yeah, distal pancreas, the first thing that we usually will identify the location of the tumor, that is where there is infiltration to the posterior structure, whether it is free from the kidney, whether it is feasible to do distal pancreatectomy laparoscopically. And
Pidambaran, you're not very audible.
Yeah, clear?
Yeah, better.
Okay. So we have to see whether it is feasible laparoscopically, and whether you are anticipating any infiltration into the adjacent structures. All these things we have to take care of. And then starting with, usually I will start with the antegrade distal pancreatectomy rather than, most of the probably do antegrade pancreatoduodenectomy. So first open the gastrocolic ligament, identify the pancreas, then do the resection in the retropancreatic plane, identify the pancreatic vessels, and usually we'll prefer not to clip the vessels, because in future when we put the stapler, it may hamper with the previously clipped. So prefer to tie the vessels, and as in splenectomy, I would always like to ligate the artery first, so that the size of the spleen will get reduced subsequently with the reduced perfusion, and then divide the vessels, and then divide the pancreas with the stapler. Depending upon the stem, I may oversew or not oversew, and then proceed distally and continue the dissection further.
Dr. Ramesh Rajan, I think you have something to add to that. Yeah,
I would agree with most of the things with Pidambaran said. I also do a little bit of lap distal pancreatectomy, not on the head side, the lap distal. Antegrade approach, of course. But Pidambaran, I think if we dissect the vessels a little more to the right, sometimes we can apply clips in such a way that it doesn't hamper with the stapling, with the later stapling. I agree. Tying always helps, it makes stapling easier. But clips can be applied in such a manner that it doesn't come in the way of the staples. And suturing, I think we also need
just see if they can see me or not. I am seeing them.
Sir,
we can't see you, sir.
I am seeing Ramesh Rajan. Can they see me?
No, sir, you're not.
No, sir, we can't see you on screen. We can hear you, but your video is not seen. It is video is not seen, Dr. Ramesh Rajan, sir.
Can you
the on-site presentation in the
Okay.
meantime, Dr. Ramesh
Yes.
can join.
So in the meantime, let's start with the video. Video of the presentation. Dr. Ramesh Rajan, sir is so. Sir, can you see the screen right now, Dr. Arnari, sir?
I could see the screen. It keeps disappearing. Yeah, I can see. Come on, yeah. Why
No,
it
what
is?
I'm saying, let Dr. Arnari connect. In the meantime, we can go on with the next video, which is on.
Yeah.
Okay,
Probably the
so
next.
we in the meantime, we start with the next video presentation, which is laparoscopic distal pancreatectomy, Dr. Praveen Suryavanshi. Dr. Praveen Suryavanshi. Yes. So he is professor and head of the Department of Surgery, Deputy Dean, CEO, MGM Medical College and Hospital, Aurangabad. So he will be presenting on laparoscopic distal pancreatectomy. Can we have his video here? The screen.
Morning. At the outset, I'm thankful to organizing committee and Dr. V.K. Kapoor for their kind invitation. So I will be presenting a short video on the laparoscopic distal pancreatectomy. Both videos were video pancreatic splenectomy, the spleen preserving distal pancreatectomy. So as we discussed that there are lots of benefits of laparoscopic distal pancreatectomy, which has been proved in the terms of higher rate of spleen and spleen preserving distal pancreatectomy, low rate of intraoperative transfusion, low rate of pancreatic fistula, especially B and C type of fistulas, and the less perioperative morbidity, less hospital stay. Only thing which was of concern is the increased operative time. So as we discussed, there are two techniques, either antegrade or retrograde. In laparoscopy, most of the time we do antegrade technique, distal pancreatectomy, because all vascular division become possible under direct vision. So this is a 18-year-old female who she presented with abdominal pain with fullness of upper abdomen. Now on CT scan, you can appreciate here, there's a large, about 8 centimeter mixed density tumor with dilated vascular channels in the gastrocolic ligament. Also, you can appreciate the dilated left gastric vein. So it was obviously shown it is a compression of the splenic vein, which has led to the left-sided portal appendation. In this film also, you can see there are the dilated channels in the gastrocolic ligament. So obviously, this was a case for the laparoscopic distal pancreatectomy with splenectomy. So port position, usually port position, supraumbilical camera port, 2 working port on the midclavicular line, the 1 5 mm working port for the retraction of the stomach and the in the epigastrium, more on the right side. So you can appreciate now this is the way retracting stomach and dilated vessels in the gastrocolic ligament. So as we discussed, we opened the gastrocolic ligament to enter into the lesser sac. After adequately lesser sac is open, you can appreciate here dilated vessels in the gastrocolic ligament. We have to assess the tumor for its resectability and any adhesions with the retroproteinous structures. Then we divide this at the superior border of the pancreas peritoneum and identify this pancreatic splenic artery, but we don't divide or ligate this at this stage. And we come to the inferior border of the pancreas and divide the pancreaticocholic ligament. Here we start little on the left side of the supramesenteric vein, where the pancreaticocholic ligament is thin out. And then we proceed towards the neck of the pancreas and head, where we get a lot of short, stumpy vessels, tributaries from the pancreas, which drain into the superior mesenteric vein or the splenic vein. So you can appreciate, these are the short, stumpy veins which are draining into the superior mesenteric vein. If you try to dissect right from the anterior surface of the supramesenteric vein, then it's very difficult to control these veins. So since we are going from the left to right, so under vision, we can identify these vessels, we can dissect them, and then we can clip them and divide them. So this is same we do when we do a laparoscopic repulse procedure also. So instead of going on the right bank on the superior mesenteric vein, we go from the left to right side. Then we further dissect this splenic vein all around, more on the left side, so that we can preserve the left gastric vein. So this is the left gastric vein here. So we go on the left side of the left gastric vein so that we can preserve it. And then it's again very easy to go around the splenic vein without injuring the left gastric vein. If you go on more on the right side at the confluence of the splenoportum, then the chances of injuring the left gastric vein are always there. Same way, we dissect the splenic artery. So we take all these vessels from behind the neck of the pancreas, then taking this splenic artery from at the anterior border of the pancreas. So this is the portal vein, left gastric vein, and this is the splenic vein. So we dissect and ligate this splenic artery from behind the pancreas. So you can appreciate it is better, we can identify it and dissect it from behind than trying to retract pancreas at the superior border of the pancreas and ligating the vessels. As we discussed, first artery first, after 2 to 3 minutes, when there is adequate blood drainage into the systemic circulation from the spleen, we ligate splenic vein. Then we take, after ligating splenic vein, we get further better exposure of the splenic artery, which is then clipped. So we feel more comfortable doing all this vascular control from behind the pancreas, then partially from behind and partially from superior border of the pancreas. Then we create a tunnel between the at the superior border of the pancreas. So once you take the vessels, it's very easy to create that tunnel, and we can lift the pancreas further with the tumor, and then we prefer to do with the these endogia staplers. If the pancreas is soft, and then we use the white cartilage. If the pancreas is firm, then we prefer to use blue cartilage. So prolonged pre-firing compression technique we adopt, and then after that we divide these short gastric vessels till the superior pole of the spleen. Then we lift this tumor along with the splenic vessels. So we already planned for the splenectomy. So a complete tumor with the splenic vein and the residual pancreas will lift from the retroperitoneum from the anterior surface of the renal vessels and the aorta. So now we are dividing this the anterior lip of the splenorenal ligament. If you are in the right plane, you will not encounter any vessels in this plane. And now the most important job is the vascular control. Once that is achieved, just we have to lift the tumor with the pancreas and the spleen from the retroperitoneum. So this is the splenocholic ligament. We have to take the splenic flexure down. We have to be very careful, especially if it is a large tumor, where the colon will be adherent to the tumor sometime. Now we are dividing the posterior lip of the lienorenal ligament. So once this posterior lip of the lineal ligament is divided, the whole kidney will be exposed. This is the anterior surface of the kidney. All gyrotous fascia along with the lienorenal ligament is divided. Then we come medially. We divide this medial aspect of the splenorenal ligament. And then this is the final part of the splenic ligament. So we go in a one plane throughout. We don't go from multiple planes from behind or from laterally. Just take the plane and single plane you follow till the diaphragm. So this is the now the exposed erythroperitoneum. This is the splenic artery, and this is splenic vein here. So after proper hemostasis, we put the drain in all patients, and if there is no drain after 48 hours, we take out the drain. And if it persists to drain, then after 72 hours, we check for the drain fluid analysis. And then the histopathology of this tumor was a solid pseudopapillary tumor. Just another short video on the spleen preserving distal pancreatectomy. So there are two types. These are splenic vein preserving, spleen preserving distal pancreatectomy, which is preferred for the benign tumor, low grade or low grade malignancy, where on CT scan there is no involvement of the splenic vein. Another way is the splenic vein resecting, spleen preserving distal pancreatectomy. Here it's comparatively easy to splenic vein preserving. It can be done where there is a short segment of the splenic vein is involved. And then we have to resect the splenic vein and the splenic artery. And in this case, the blood supply to the spleen is maintained by the short gastric vessel. So we have to take care not to divide these short gastric vessels in the later part of the dissection. So this is a patient again. There is a 22-year female. You can appreciate there is a 6 centimeter sized tumor of in the tail of the pancreas. And the splenic vein is well preserved. So here this is the video of the splenic vein preserving and spleen preserving distal pancreatectomy. Again, we enter into the lesser side. Now we can appreciate the tumor is well mobilized, and this is the splenic vein posteriorly. So we identify splenic vein throughout this course. Then we come medially, where the on the retropancreatic region. And again, we have to carefully identify and dissect the short stumpy tributaries which drain into the splenic vein from the body of the pancreas. So once you go all around the splenic vein and splenic artery, then we transect the pancreas with white cartilage. So now we have to be very careful not to injure this splenic vein or the artery. And the most important part of it is the dissecting splenic vein from the tumor, posterior surface of the tumor. So in most of the cases, it's spaced out and is very close proximity of with the tumor capsule. We have to be very, very careful and very precise while creating plane between the splenic vein and the posterior surface of the tumor. So we can use gentle traction over the splenic vein with the blunt forceps, and we can create plane between the splenic vein and the posterior surface of the tumor. You have to take care not to open the tumor capsule, and also equally not to create a rent in the splenic vein. Otherwise, it becomes very difficult to control intraoperatively. So we have bulldog clamps with us, laparoscopic. So if at all there is a rent, you have to apply bulldog clamp and we can repair it laparoscopically. So this blunt suction tip is a very good instrument to create, this like what we do finger dissection. Same blunt dissection can be done laparoscopically wherever there is a loose areola fibrofatty tissue between the vessels and the tumor. So in these cases, slower is the faster. You have to be very, very slow and careful and gentle so that we don't encounter any bleeding. If at all there is a bleeding, it takes a lot of time, and not only it becomes stressed, very stressed out. So we have to be very careful so that we can finish it fast. Now we can appreciate the whole splenic vein is preserved and the tumor is excised. Thank you very
much. Nice presentation, and I think 2 credits to your video. One thing is a beautiful surgery that you are doing, and a nice recording. I think both the things were very apt. Can we have any questions from the audience if there is anything? Any questions or? Okay.
Yeah.
Yes. Yes. So, yes.
Do you have any experience with this splenic thrombosis post spleen splenic preservation?
Unfortunately not. We have just done 4 cases till now with clinic vein preserving distal pancreatectomy. We don't have till now any splenic vein thrombosis incidents. At least patient has not turned up. We don't have that rigorous follow-up also, but there is no obvious cases.
So, which are the condition you will contemplate splenic preservation in preoperative consideration? What are the things that you consider?
Yeah, actually, good CT, triphysic CT scan is very important.
No, I'm not saying that. Which are the patients you take for splenic preservation, and which are the patients you don't contemplate splenic preservation? So how will you?
That's what CT scan finding. If CT scan, we can trace the splenic vein completely. There's no obstruction. There is no signs of left-sided portal hypertension. Then we can think of splenic vein preservation. But obviously, there is a left-sided portal hypertension. Splenic vein cannot be traced out. And we can trace completely throughout the course. Then there is a splenic vein involvement. Then you should not, attempt to do preserve the.
Will your decision change based on the type of the tumor or characteristics of the tumor?
Obviously, if you are suspecting malignant tumor, then definitely you should not. This is what I am talking only non-malignant tumor.
Dr. Praveen, can I?
Yes, please.
Can I make the nice video? Nice videos. So regarding stapling.
Can we have it on screen, please, Dr. Raju? Hello.
My video is not opening it because the host has stopped it.
Host, please, on Dr. Ramesh Rajan's video. You can put Dr. Ramesh Nari's video, sir, also.
Okay.
In the meantime, yes, Dr. Ramesh Rajan is on.
Yeah. So nice videos, Dr. Praveen. Regarding staplers, you had shown the white cartridge. Is it most often would you be able to do a white cartridge, or I tend to use more of a purple cartridge. We tend to need a purple cartridge most often for the pancreas. So I would like to know your opinion on that, as well as the other chairperson's opinion.
Yeah. See, the purpose of stapling and to prevent the fistula formation is to obliterate the pancreatic ducts. Yeah. So that's why this is the prolonged pre-compression technique is utilized. Where we fracture the pancreas and we just squeeze the pancreatic parenchyma, and so that we can successfully obliterate the ductal system.
True.
So for that purpose, I think white cartilage is good enough. But if as I mentioned, if the pancreas is firm, more firm, and then we prefer to use blue cartilage. But if the soft supple pancreas, then only we use white cartilage.
So since most of the distal pancreatectomy specimens, the pancreas may be soft, you tend to use white cartridge more often. That's what you mean to say. Is that?
Yeah, it's not whether distal or proximal. It is the basic morphology of the pancreas.
Yeah.
Which decides.
And I think I saw only 4 ports. Do you need a 5th port most often for retracting the colon down? Is it
we give stiff head eye position and then a little like a 45-degree tilt left side up, so that falls the colon below. So we don't require in none of the case we use.
And is it most often better to
myself and
yes, sir. Yes, Ardhanari, sir.
Dr. Ramesh, you can ask a question in the meantime when
is it better to
audience
ligate the artery or clip the artery before the vein?
Yeah. So that, the blood gets drained into the circulation, the vein get collapsed, and that's why.
So, so even if technically, if the access to the artery is more, if the vein is a hindrance to getting to the artery also, I mean, we should probably clip the artery immediately after the vein is clipped. Whenever possible, probably artery should be clipped first before the vein, I suppose.
Yeah. So that's what, if you go posteriorly, it's really become very easy to clip the artery first. You must have seen both the videos that we could dissect artery all around very nicely. We could clip it very safe.
Okay, last question, Dr. Siddharth, please. Yeah. Yeah, good, Dr. Saab. I think Dr. Praveen, you can join us here on chair, because I think we'll have the same questions, because we have still screen preserving the splenic vein preserving pancreatectomy frequently again also. So please join us here on the chair. Is Dr. Ardnari's video on? Can it be switched on? Audio visual department, please. No, can we see him on the screen? Other than his video, can he be visible? Can you start his audio? Can he speak to us? Dr. Ramesh Ardnari, sir, who will unmute? Dr. Ramesh Ardnari, you have to unmute. Hello.
Yeah, I can hear you. Can you hear me?
Yes, sir. Now we can hear you. You're audible, and your video is on the screen right now. So
You can see my slides?
yes, sir. We can see you. Yes.
Very wonderful. So, very good morning and maybe an early good afternoon to all the people. Sorry for all the confusion. I had some health issues, so I was not able to travel for the cold weather. My voice is also not perfectly all right. It may break down in the middle. I'll ask for some apologies at that time. When we talk of, let me see if I can get this full screen.
It is coming on full screen.
It's coming full screen?
It's not showing as the PowerPoint show.
Not full screen, sir.
And now it's a full screen. Yeah. Okay. Now it's a full screen. So, Vinay. Yes, Vinay. Vinay Kapoor is trying to call me. Can you just tell him that I have started to speak? Can you see the screen now?
Yes, sir. We can see the screen. It's full screen now.
Yeah, full screen. Okay. So the next, whenever we do a procedure new, for example, a laparoscopic procedure versus the old operation, which was the open procedure, to justify a procedure, it doesn't matter whatever procedure it is. The new procedure should be adequate for the pathology that we do. So as Praveen showed, that he chose the procedure depending on the pathology. And I think that's a very important decision to make. You should not go into the theater and then decide, I will try to save the spleen or I will remove the spleen. That decision has to be done before. And sorry, yeah. Can I go back? Yeah, the procedure should be equal in outcomes to the existing procedure, if not better. If it is worse, then it has no place to be done. Should offer definitive benefits. There's no point in doing a new procedure with no benefits if it's just going to be another way to do it with the same results. and should be recommended after some time when enough studies are there by official agencies. We perform pathology for distal pancreatectomy for cystic neoplasm of the pancreas, endocrine tumors like insulinomas, ductal adenocarcinoma. We rarely get a chance. I have done one case where the chemotherapist had given chemotherapy, shrunken the tumor. Then we did a thing. The patient lived for 3 years and died of multiple lung metastases with no local recurrence. And we can also do the LAP ramp, the radical antegrade modular pancreatitis for a very large tumor, especially if the tumor requires that our excision be from the superior mesenteric vein. Lap distal pancreatectomies are classified as two types, major and minor. It is major if it is a resection to the left of the superior mesenteric vein. It is minor if it is well to the left. So if you're on the superior mesenteric vein like Praveen was, that's a major distal pancreatectomy. The procedure takes longer laparoscopically, obviously, but has significantly less blood loss. And the retrieval is usually done by a fan steel because we don't want to rupture the tube. The post-op pancreatic fistula is the same as open surgery. There is no difference. We can use a stapler or a suture with equal results. Sometimes I do a stapler and then I suture over it because I'm not happy with how the stapler has fired or something. Does using seam guard on the stapler offer benefits? The answer is no. So don't waste your money putting seam guard on the stapler. I actually have a very low pancreatic fistula rate. So in my distal pancreatectomies, I don't put a drain. After distal pancreatectomy, no drains are placed in my department unless there is a definite indication such as bleeding or there is oozing which we can't control. The NICE guidelines show that it is a safe and adequate procedure. It should be performed in types where in centers where it is normal to do this procedure by open. The benefits are cosmesis, less pain, early return to activity, and return to work faster. So this is the layout, slightly different. My patient lies with the left side raised because the spleen will then come up onto the left side so we can see it better. Then I place under vision the telescope, and then I put two accessory ports depending. I stand on the right side of the patient. The cameraman stands next to me. The nurses stand on the left side. And we usually have two monitors because if you have only one monitor, the nurses will have to turn to see, and so they will lose their. So this way they can see onto one monitor. And we can see on the other monitor. So let me now try to open my video. Yeah, can you see the movie coming?
Not the movie. We can see the screen with the three folders.
No, can you see the screen with now the?
We are seeing the folders only. We are not.
Oh, okay. Okay, I think I didn't share that. I have to share that. And then I have to say share again. I have to go out of this and say new share. And there I have to
Yes, we can see the video now.
Now you can see the video. Okay. So this is a laparoscopic distal pancreatectomy with splenectomy. Again, a 17-year-old female. This is the common age for SPEN. And you can see this big tumor. And there is going to be very little chance to save the spleen and the splenic vessels with this larger tumor. After putting the ports in, then just like Praveen, first the lesser sac is entered and the surface of the pancreas and the surface of the tumor is shown. Now, one of the secrets of using the harmonic scalpel, if you don't want any bleeding, is to use it at a power of 3 for everything. Never use the power 5. If you use the power 5, sometimes it cuts very fast and there's a oozing. So if you use the power 3, and if you have a larger vessel, you can even go down to power 2 and use it. The first thing that I do is that once I have opened the lesser sac, I go to the base of the pancreas, as Praveen did, and create the retropancreatic window by dividing the mesocolic layer as it comes onto the pancreas. We also do this dissection regularly whenever you want to mobilize the transverse colon and distal colon in a colectomy. So this area is usually avascular, and you can usually do it slowly and gently. And like Praveen, I think it's a duplication. We all follow the same technique. The suction is a very good instrument for dissection. 2 reasons. One, it is comparatively atraumatic. Second, as you do with the suction, you can clear the blood. So I think it also eliminates the vision problem. So if there's a little oozing, that also can be removed. So I'm going all around, freeing the cyst all around. And I've used another port to just retract the pancreas up and keep it. Now that is very useful to do. Once you do that in a big tumor, you can retract the pancreas away. And that will really make a lot of difference when you're doing, because the splenic vein lies below. And we try to create this tunnel under the normal part of the pancreas first, not under the tumor. So the difference is that we create the tunnel under the normal pancreas. So you see, this is the normal pancreas. So that is where we try to create the tunnel. We also sometimes can't create the tunnel fully from below. We may go on top, release a few fibers, and at that place, if you can see the splenic artery, you can just either tie it or clip it. I preferably would not like to clip it nowadays, especially because if you clip it at this stage, then what happens is that if you put a stapler, sometimes the stapler may lock on the clip. So if you're going to clip it, then when you apply the stapler, you have to be very clear that it is well away. So that was the left gastric vein, which I divided. And now again, I'm proceeding to go from below and do the dissection. So unlike Praveen, I do some dissection from below. Then when I'm not comfortable, I go above the stomach and do the dissection. And that way I completely free the tumor. And you can see that there are some short gastrics. So we remove, because we are not going to preserve the spleen. So no washout technique for this. The procedure that of leaving the splenic short gastrics is known as a washout technique, after the famous pancreatic surgeon from Harvard Medical School, Andrew Warshaw. So I like to use a gauze piece from below so that I can see from above if the gauze piece has appeared. If it has appeared, then I know that I have crossed, and I will see if I can deliver the gauze piece from above. So once it is not yet this thing, I do some more dissection. And so that means that I'm not crossed. And now I might have crossed. I can see some on the other side. So I will divide these small structures all with the harmonic at the slow speed so that they don't bleed. And we look from above, and we're trying to create the tunnel below the normal pancreas. This one takes a little time because you don't want to injure the superior mesenteric or splenic vein, because then it becomes hell. It will bleed very fast and you won't be able to control. So then you'll have to, as Praveen said, take a bulldog if it is available in your theater. Most theaters won't have, we have. And we would also put a bulldog and we would clamp that vein. And then I once had a hole in the vein and I used 6-0-prolene to close the splenic vein. And 2 weeks after discharge, I repeated an ultrasound. The splenic vein was patent. So that is, and again, just like Praveen, I have done the splenic artery dissection from below and clipped it from below. So I think most surgeons who do these are the same. In this case, it's a little thick pancreas, so I'm using the blue load. And Praveen just went fast over it, but this is the technique where you apply the stapler and then leave it for about 2 minutes. The Japanese have proved that if you apply the stapler, leave it for 2 minutes, and then fire the stapler, the leak rates are lower. So all of us, I think now we routinely follow that technique. So a little bit of tissue is left behind. So whenever there is a little tissue left behind, it may have a vessel, and this one has a vessel. So I am, like Praveen, dividing the vessels. In the recent last few years, I have changed the type of scissors that I use to divide tissues. When you use the curved scissors, especially if you put 2 clips, because of the curve, the cut tends to go closer to 1 clip. So that side has a shot. So I started using a straight scissors to cut. Then I can cut right in the middle. It doesn't bend one way or the other. This is something that I have now started doing recently. And please remember that the artery that is most at danger while doing distal pancreatectomy is not splenic artery, because splenic artery can be sacrificed. The artery that is most at danger is the common hepatic artery. The common hepatic artery actually has a long course on top of the pancreas. And when you go towards the portal vein, the artery that you will see is often the common hepatic. And I know cases where they have mistakenly clipped it thinking it is splenic artery. And then they've had to go in and open and then reconstruct, because you can't just leave the common hepatic clipped and come out. So always be aware that the structure that you have to be careful of when you're doing distal pancreatectomy should be the common hepatic artery. This is something that many people forget. If you look at the anatomy, the celiac trunk was split and go into 2 on top of the pancreas. And you actually have a fairly long course on top of the pancreas. When you do a D2 dissection, you can actually see that along the head and body of pancreas, the splenic artery lies for quite some time. And that is where the hepatic artery lies there, common hepatic. And that is where we usually dissect the lymph nodes from. And then the remaining, of course, tissues to the spleen are divided, because in this case, we have, as I said, it's such a big tumor that we have decided in the beginning itself that we, and so why it is important to decide in the beginning, because if you are going to conserve the spleen, you may sometimes be unable to conserve. So always you have to take consent for splenectomy. If you can't go in and do a splenectomy without taking consent for it. So in today's world of litigation, even if you plan to save the spleen, tell them there is a chance that I may not be able to save it. Therefore, I would like to have consent. If they refuse to give consent, don't do the operation, because you can get into trouble in a court of law. Now this tumor is almost completely free, and we made a fan and steel incision and removed it. Laparoscopic distal pancreatectomy is a very nice operation to do if it is done gently and well. Though they say that there is an incidence of pancreatic fistula, we have had a pancreatic fistula when we have enucleated a small tumor from the tail of the pancreas, which we managed with just a stent in the pancreatic duct, and that stopped after some time, and the patient became all right. There was a question whether splenic vein thrombosis can occur. We have not seen, we have not followed up, so we don't know whether it can occur. But I can tell you we have done about 6 cases of the washout technique. And in one of the cases of the washout technique, on the second post-op day, the patient had sudden tachypnea, respiratory distress, fall in BP, high fever. So I suspected the necrosis of the spleen, so I immediately took her to the theater. The whole spleen was black. Obviously, the short gastrics were not sufficient. We did a splenectomy, and then she completed a splenectomy, and she recovered very well and went home. But in a washout technique, that's one danger. In the second danger in the washout technique is that if you do an endoscopy on the patients after 3-4 years, almost every patient of washout technique will have fundal varices. It usually doesn't bleed, but it can bleed. But it is good to know that the operation can have long-term problems. Why do distal pancreatectomies, and why do, in some cases, central pancreatectomy? Somebody had talked about it. I have a wide experience of central pancreatectomy. Actually, I was the first in the country to do a laparoscopic central pancreatectomy way back in 2000. And I have now done more than 20 of these procedures. And the reason why I believe that it's a good procedure is these people don't become diabetics. If you did a distal pancreatectomy, you will find that in 5 years, 30% of patients who are non-diabetic will become diabetic, and then they may require insulin. So I, whenever possible, try to do a central pancreatectomy. If it fails, then I do a distal pancreatectomy. I think the price of a higher fistulization rate, which we have not seen, which people have written in the literature, following a central pancreatectomy is worth paying for the avoidance of new onset diabetes, which will ultimately, in many patients, require insulin for treatment. So I always like to spare the distal pancreatic as far as possible, also partly being diabetic myself. So with that, I would like to thank the organizers for this opportunity. And if there are any comments or questions, I'd be happy to answer. And I'm so happy to see Pitambaram, my DLB postgraduate, who's doing so wonderfully well in Kerala, sitting there on the dais as a chairperson. This shows how we have progressed, that we have really become elderly teachers, that our students are now chairing and giving lectures. Thank you.
Thank you, sir, for the wonderful words. And I would like to ask one question. You had discussed about central pancreatectomy. Yeah. And how much distal pancreatic stem would you residual
should be a minimum of 5 centimeters. Unless you can get 5 centimeters of distal stump, it is not worth preserving the distal pancreas, because you can't do a tension-free anastomosis, and then less than that, anyway, many of the islets would have gone. So at least 5 centimeters, at least, is the minimum amount that you can spare, and then you can think of central pancreatectomy.
Yeah, one more question I want to ask is that if there is only 5 centimeters stem left behind, and how much mobilization we can do to do a pancreatic gastrostomy anastomosis?
Pancreatic gastrostomy may be difficult because, you see, as the anatomy of the pancreas and stomach concerned, as they go towards the tail, the stomach goes away from the pancreas. So after a Whipple, you have so much of pancreatic length that mobilizing it and putting it into the stomach is easy. But unless you get that much length after a central pancreatectomy with 5 centimeters, I would advise that you should do a pancreaticojejunostomy and not a pancreaticogastrostomy, because that will be under a lot of tension.
Yeah, because whatever I have seen during my tenure was pancreaticogastrostomy during.
Yes, I try to do that, but I would really advocate 5 centimeters.
Yeah. Thank you, sir.
Yeah, hi, sir. We have questions from audience. Asif, yeah. Please.
So thank you for a wonderful presentation. Just wanted to ask something. I mean, even literature says there's close to 40 to 50% leak rates in distal pancreatectomy, and even we see same in our patients. You said you have close to 0%. What are the things that you do differently that we can learn?
I really don't know. I think I leave the stapler on. In most patients, I put a staple. I also use a 2 or a 3-0 PDS, depending on the thickness of the pancreas, to oversew it. And Pitambaram has seen, we don't put drains also after distal pancreatectomy. It is possible that there is a small, fluid leak inside which just gets absorbed. And the problem is you put a drain, you will get 20, 30 ml, and then you will measure the amylase and that. If that is high, you will say this is grade A fistula. And I think most pancreatic fistulas are grade A fistulas, which won't require any intervention. So I don't know whether really putting a drain in a distal pancreatectomy is all that valuable. Whipple is a totally different. We will put a drain. But for splenectomy, distal pancreatectomy, I don't use drains.
Do you ever have to resort to any percutaneous interventions post-operatively in any of your patients?
I told you the one case where we had to do the enucleation. We damaged the duct and there was probably some leak of fluid, and for that we had to put a percutaneous drain and then put a stent. The first time I did the central pancreatectomy was actually a patient where I went to do an enucleation. When I was, before the enucleation, what I had done was I had put in a nasopancreatic drain the day before. And then I enucleated this tumor. After I enucleated the tumor, I injected methylene blue through the tube. There was a massive leak, which meant that the duct was wide open. So then I saw that a lot of pancreas was left because I had just enucleated. I cut both sides a little bit. This side I stapled toward the duodenum. The other side I put into the stomach. That is how I did the first. It was an unplanned central pancreatectomy because I'd actually gone to do an enucleation.
Thank you.
Hello, sir.
And therefore, for enucleation, I would advise that if you have a cooperative endoscopist or you are an endoscopist, before enucleation, place a nasopancreatic drain, very small tube coming out of the nose. Do your enucleation, inject methylene blue, make sure that there is no leak. If there's a leak, you can do one thing. Either you can put a drain and then change the NPD to a stent. Now that you've got access to the duct, it should be easy to change it to a stent. And change it to a stent so that there will be no leak later. It will stop.
Arjuna, is a nice lecture and video. Ramesh here.
Yeah.
One thing, you seem to be using the patient on the right lateral position and standing on the right side of the patient.
Yeah.
In lesions located closer to the portal vein or the splenoportal axis.
Yeah.
Do you go for the French position, or do you think
no, what I do is that if it is closer to the thing, from 45 degrees, I have come down to a 30-degree tilt. Of course, if it is very close, then it may not be suitable for a distal pancreatectomy at all. It may be more suitable for the Whipples than for a distal pancreatectomy. So some of the large lesions in the head and all, they would be more suitable for a Whipple, in which case I think you have to put the patient supine and do.
But you are not changed over from the French position initially to the right, standing on the right?
No, I have always been doing this for both my splenectomies and my pancreatectomies and any other work on the, and for especially for diaphragmatic hernias. This position, you have more and then put the head up, this contents will reduce and you will get space to put your mesh.
Fine, thank you.
Thank you, Dr. Ramesh for a very nice video and a very elaborate discussion on that. Now, next I invite Dr. TLVD.
Thank you.
TLVD Prasad Babu from Hyderabad. He is a consultant surgical gastroenterologist and bariatric surgeon, and he's practicing at Yashoda Hospitals at Secunderabad. And he will be showing his video on lap spleen preserving distal pancreatectomy. So now to TLVD.
Good afternoon. Thank you, JSF, Dr. Kapoor sir, my professor, Ajay Vas, and friends. So after the stalwarts talking about the same topic, now justifying me is a difficult task, but I'll just go through few insights. Might be some repeating things will be there, and I just try to avoid few of them.
Can we have a video on the screen, please?
Yeah. No, it's okay. You have to do. So important is the answer to the question. When while choosing a clinic preserving distal pancreatectomy is few factors like tumor location. When the tumor is close to the hilum, there is probably difficult, especially when you are targeting for a tumor of, and also even for a Varsha also, it is very close to the hilum and anatomy. In some patients, the vessels are embedded into the parenchyma, might be difficult test. Certain times these tumors create local inflammation and instead of pancreatitis, well, may be difficult task to dissect the vessels. And if we have an invasion and associated portal hypertension in certain patients, these are all the difficult patients where you can to perform a splenic preserving procedure. So what are the indications and all? Some confusion. Probably neuroendocrine tumors, especially they are low grade and G1 or where the Ka67 index is low. And there is some controversy about using a preservation in a miscellaneous cystic neoplasms. Uh, Dr. Professor Tanaka says that you should not do preservation in a MCN, but later on, few people have come up with you can do in a selected cases, probably less than 5 centimeters miscellaneous tumors. When you don't have features of malignancy, probably one can resort to clinic preservation and certain benign tumors, commonly insulinomas. Here is I would like to show one patient where a preoperative scan where the clinic vein is very upping to the thing. This case we thought of doing a clinic preservation, but end up with a distal pancreatic splenectomy. One can appreciate see how closely the tumor is here. I could not able to dissect it actually. So there's certain times what happens is you tend to do a preservation, but you end up doing a pancreatic splenectomy. So with this note, I will just take you through few of the case scenarios. To begin with, a simple case where one can see this is a young girl where you can see big cystic lesion in the. I think not going to discuss with the port position and all these things are discussed. I think universally all of us will do the more or less the similar way. Dissection, first taking down the colon, entering into the lesser sac, exposing the lower part of the pancreas. So here, because what happens is the projecting cyst outside, naturally there will be stretching of the mesocolon. Patient will dissect this, so reach at the plane. One can appreciate the cyst. So then slowly dissecting all around. So more of an towards the hilum side it is. So now the entering there's a plane between the gerota fascia. Slowly that is being separated. This is some mesocolic fat which is stretched onto the cystic tumor. So that is being separated. So thing is no clear-cut head-to-head comparison whether splenic preservation versus while if we do splenectomy, but all the data we have extrapolated from the OPSI and all from the different scenarios where you have done a splenectomy in a different cases. But in a literature, if you take a head-to-head comparison, it's very difficult to find out the advantages of splenic preservation. But we all believe that spleen is an important organ for the immune function. We try to preserve wherever possible. So here, one can now enter into the lesser sac. Now you can appreciate the pancreas is seen. Now it's the retropancreatic dissection. So what we are doing is for the purpose of retraction, the stomach is held with a suture. Now I think we can use one hand. We can make it free. Now slowly because the lower part of the pancreas. So combination of ligation, bipolar, and harmonic scalpel will help you in doing an bloodless dissection. Superior part of the pancreas is being dissected now. For the vessel, that is an artery which came into the picture. This is a splenic vein. This is the small branches. So we'll try to clip all those branches. The young girl, the nice planes, you can see these are all the arterial peaks which are crossing over. So certain patients, the common anatomy is splenic artery will have an curved course on the upper surface. In certain patients, it will have a very straight course. Those are all little difficult cases. But the most difficult is if it is embedded into the substance of this is a gold finger. One can use this instrument for getting a tunnel, and with this, once you have an access, you can put a some sling, either vascular loop or an umbilical tape, which can aid you while you are applying a stapler. So which stapler is difficult to answer. Change several staplers. Certain times you will feel happy, certain times again you feel difficult. I think probably if you have a good supple pancreas in this scenario, probably one can use a white stapler. But if you are certain Western surgeons, they also transect both the vessels with the stapler. Probably that scenario one has to be careful where using which side sort of. Here, I think the transection has been done. So now along the vein, just try to cauterize the tributaries and going towards the hilum. You can see the entire vessels are separated. So if you can, one can notice keenly, there is an infarct which you can see on the lower polar pole of the spleen here. So usually it doesn't do anything much. There are certain recommendations, especially came from Warsaw group while they do procedure. If you have 50% of an infarcted spleen, less than 50%, it doesn't matter. It is not going to give much trouble. So if it is more than 50% of the, so I think I'm just taking this out. So by the end, I always prefer to put a drain, especially nowadays what we are doing is Jackson Pratt type of drain, elastic drain and put it. You can see notice the infarction. This drain, usually I leave it. Majority of the time they are all grade A. This is a patient, so by the end, this follow-up scan, one can appreciate done after a year. See, there's a nice staple line one can appreciate, and the spleen is almost normal. You can see nothing is there in the spleen. So in fact, up to less than 50% of the times one can ignore, and still you can do. This is a patient where a patient with a neuroendocrine tumor. Yes. Similarly, you can NAT. So little bit controversy in G3 tumors and all. I think probably if you want to include a note into the specimen, but there you should avoid doing an splenic preservation, and probably in a grade 1 tumors and the tumors of a smaller size in neuroendocrine. This again for exposing the lower border of the pancreas, similar to the section. That's the felt fascia where the fusion fascia will be there. There you can enter into this plane. But while planning the ramps and all, the different scenario where you take the gerotophagia, the retro pancreatic dissection. Now you can see the splenic vein is exposed, getting exposed, and we can use the clips, and sometimes you can use energy source, ligature, whichever you are feel convenient. Like now I'm doing 50% of the tunneling I have done, and now going towards the superior surface of the pancreas, one can see we are exposing the artery there. See now holding the splenic artery. And certain times, good to have a control of the splenic artery. Certain times you can, if you are able to do it, one can. So now we are catching hold of the splenic vessel and apply a vessel loop. So this this vessel loop, certain times what you can use it, you can use it for attraction while you are dissecting the splenic vessel. Now proceeding towards the lower part of the dissection. Now again, see these are that's we are using the vessel loop for the traction purpose, and there are certain arterial peaks going towards the splenic parenchyma and tumor side. Those vessels are taken care with the help of ligature instrument. Now there is a small twig of the veins coming, which are, I'm applying a clip here. So again, making a tunnel with the help of certain times, if you pre-applying the tunnel itself, if you put the umbilical tape, that you can use it to avoid another step. Then we do a transection. I think we're using a white stapler. So certain times, you have to be prepared for gush of blood, all these things, and also, of course, you have the here a little bit parenchyma is left that I am taken care with the clip. There is an sputter coming over from the transected and that specimen side that is going to control it with a clip. So it's a little certain times suddenly field becomes little bloody, and again you can control with the patient. And this is the venous tributary that is going towards the pancreatic side. Now that I'm taking it with clips and combination of like that. So this is more gratifying, especially while you are doing a laparoscopic surgery in a obese patient. You can see now in this patient, you can see the spleen is in almost in a normal color. There are certain situations where we have done this patient where when the really the patient is an insulinoma, what we can do is you can do an entire mobilization of the pancreas, and especially it is towards the tail side. What is then you can do a transection and remove the specimen. See, you can see an insulinoma that is arising from the tail of the pancreas. Again, entering into the nice plain post-retropancreatic region. The vessels are which are coming in the upper surface. This is an actually relatively easy anatomy where the vessels are nicely seen and all. So here what we have done is completely first dissected the vessels from the pancreatic parenchyma. And by the end, we put the stapler where, once you now see the entire tail is mobilized from the splenic hilum towards the body side, and now just applying the stapler. In this case, I'm applying a tie stapler. That is the pink one I'm using. So biochemically, I think a good number of, I think close to 20 to 30% of the cases you see a grade A leak, definitely. Invariable, whatever the technique you use. But clinically, but that which has no clinical relevance, one can say. I'll just end up with a scenario where I'll just show only a glimpse of it. I don't take this is the patient. I've shown for an neuroendocrine. I've shown one indication for splenic preservation in a missinus. This is a patient where it's an old video way back in the first one, probably in 2014, 15, like that. And so where this is the first patient splenic preservation done for a pen. Small pen. Usually we come across a big pen, but in the patient where probably we picked up very early, these are splenic vein tributaries were ligating. And there's a stapler, white, there's a transection. You can see splenic vein tributaries, but this lesion is also towards the tail side. So combination of, I think a lot of times, we'll have mental block, but since you are working under magnification, it's very difficult to tend to injure any vessel with the patients and all. One can, keep on dissecting. This is a lot of clips and good length of the splenic vein is being dissected. What people suggest is when compared to the Kimura and Varsha's technique, the almost results are fine. But if the dissection plane is more than 5 centimeters in a sick patient, probably people suggest that better to, do a washer procedure when compared to this one. This is I'll take a last bit, I'm not saying, where recently encountered, with the transaction is an already spleen preserving procedure. You can see there is a stump bleed, and here the white staple has been used. This is an surgical powder which we have applied to the stump. It has achieves really instant hemostasis, and I don't know, probably this cut surface and all, we put a drain, but this patient didn't leak. I don't know whether there is a role for it, but definitely it has a role in achieving a good hemostasis you can achieve when your surface is raw. Thank you very much. Thanks for your patience here.
Thanks, Dr. Ludi Prasad. It was really good presentation and good conglomerate of showing quite a variation of cases. I think spleen preserving distal pancreatectomy is an important procedure, and most important cautious things which I could understand is one is preventing bleeding and doing a dissection close to the splenic vessel and pre-operative planning. So if we can have any questions from the audience, anybody who wants any discussion, or my co-colleague.
Only my observation is that, in the initial stages, we were going on the left side and taking down the colon and dividing the renal ligament. That makes specimen to fall on the, middle side where it's a crucial dissection is required. So what I prefer, I go first to the behind the pancreatic neck when the tumor is added to the, retroperitoneum posteriorly. It doesn't fall on the neck of the pancreas. So we get nice space, we can lift it entirely. So that's only my comment. But everything excellent, nice variety of cases.
Thank
Dr. Ramesh Ardhanari also raised that possibility of injuring common hepatic artery at the superior part of the pancreas. So that for that to avoid that injury, what we do, we remain on the left side of the left gastric vein. So always the hepatic arteries will be on the right side of the left gastric vein. So if you follow that principle, so you will not, in any chance, you will not injure hepatic artery, and also you will preserve the left gastric vein. So if at all you are doing this spleen preserving distal pancreatectomy and splenic vein get thrombosed, there will be alternative drainage through the left gastric vein. So we preserve that and we stay on the left side so that all vascular injuries are taken.
We have a next session which will be presented by Dr. Arun Kumar ML on pancreatic and portal hypertension. So we are running short of time. I think Dr. Arun Kumar.
Dr. Arun Kumar ML is a good friend of mine. He is working as a senior consultant, GI surgeon in GG Hospital, Trivandrum, and he is associate professor in Sri Gokulat Medical College, Trivandrum. Arun, over to you.
Distinguished chairpersons, Dr. Praveen, my friend Pitambran, my senior, Dr. Ajay, the offline chairperson, my mentor, Dr. Ramesh Rajan, my life-turning member, thank you so much for the opportunity. And it's very, very wonderful to have you been a part of your conference. I'm really, really honored and thankful to you. After watching all minimal access videos, I would say this is a bit maximally invasive procedure, but which was demanded by the patient and its morphology itself. So it's going to be a case capsule presentation with supportive videos. Solid pseudopapillary tumor in the head of pancreas, but presenting for the first time with features of portal hypertension. She is 28-year-old, otherwise well, generalized tiredness, and for the last 2 months, And the patient presented with a massive upper GI bleed, showing large lower esophageal varices, for which endoscopic colleague have done endoscopic varicose ligation. She also had anemia. And next on evaluation showed this CT scan. Can I have control on my, yeah. Yeah, I'll play the video, please. So this is a CT scan of this patient showing ascites. Ascites, lower esophageal varices, bilobar IHBRD, portal vein stenosis, and the large tumor at the head of pancreas with necrotic areas and occasional calcification. A long segment of portal vein is narrowed with portal hypertensive, gastropathy, enteropathy, and colopathy. So this is a patient, we know it's radiologically, it's a solid pseudopapillary tumor in the head of pancreas, but presenting with portal hypertension. So on one side, we have tumor with portal vein narrowing. On the other side, the presentation is something like an extrahepatic portal vein obstruction with bleed from the esophageal varices, ascites, and colitis. Definitely, this is not going to be an easy resection of the head of pancreas. So we had a plan like 2-step. As if this patient had no pancreatic tumor at all, an EHPEO, massive bleed, recurrent bleed, what will we do? So the first step is a proximal splenorenal shunt. So this is the operative video of the first step. The trapdoor incision on the left side, ascitic fluid sample analysis. Trapdoor incision. First, the omental vein is cannulated for the pressure. It was 18, the pre-shunt pressure. The omental vein is sequered. Next is opening of the gastrocolic omentum using a combination of energy devices, harmonic shears, larger ones with ligases and clips. Then some of the large retroperitoneal collaterals, we are comfortable more with ligations, especially on either side. And once these large retroperitoneal collaterals are taken, we start something known as a very close to splenic approach. That means we run very close to the spleen, the splenic capsule, gradually and carefully using multiple energy devices as and when it is indicated and it is required. Some of the large retroperitoneal collaterals we tend to clip and ligate. Any surface ooze from the spleen, just like in the liver, is better controlled with argan. Argan works really well here. A minor ooze from the splenic surface laceration can be controlled. All major oozes in the retroperitoneum may be close to the tail of pancreas. We secure with fine sutures with poroproline. And these are larger silks for the inferior splenic vein. Again, that is closely secured. Next, again, another splenic surface laceration controlled with argan. This is the upper polar vessels, a larger one on the patient side and the large clip on the splenic side. So this completes almost the splenic mobilization. So a good amount of ascitic fluid has already been emptied. Now carefully looking for the hemostasis before we do the shunt operation. The spleen is out. So all the ligations of the splenic vessels are done close to the splenic, I would say splenic parenchyma or splenic surface. The retroperitoneum is closely look for any good hemostasis, taken with fine poroproline suture. So this is almost preparation now for the proximal splenorenal shunt. So this is the tail of the pancreas that we have. Just like in the laparoscopic mobilization, the inferior border of the body of the pancreas where the mesocolic reflection happens. There's a good plane there, not much of collaterals in this case. So a reasonably good stump of the pancreas, the tail of the pancreas has to be mobilized for easy access to the splenic vein, which needs to be anastomosed to the left renal vein. So this is preparation. By the time we prepare something on the left renal hilum, carefully, meanwhile mobilizing some more amount of tail of pancreas from the left to right fashion. Initially the inferior border, later to the posterior retroperitoneal border. So there's a very good plane between the tail of pancreas as well as the rosa fascia. Now the left renal vein is in our front. So we are right now doing some calculation which part of the splenic vein will lie most easily to the left renal vein, somewhere in the middle. So the tail of the pancreas is reflected towards the right side, and a segment of splenic vein is identified. Ligation is actually the distal, again intraparenchymally after some amount of mobilization. Now this larger stouter silk suture is the splenic stump, splenic vein stump, which is about to get anastomosed. Any fine bleed, again, it's very, very important before the anastomosis to have a good feel. Now the stump is ready. Splenic vein stump is refashioned. So this is going to be an end to side anastomosis. A side biting clamp on the left renal vein and appropriate size opening made on the left renal vein. And this is end to side anastomosis using 5-proline in a continuous manner. We don't do intraoperative Doppler, but generally we feel the vein for any thrombus, especially on this splenic vein side. So once the anastomosis is completed, the clamps are being released, looking for hemostasis. Even from the drain side, there is a small bleed, which is again controlled, and the typical drain is done and wound is closed in single layer using number 1 proline. This is splenic operative picture. So we would like to reassess this patient after 4 weeks to look for the portal hypertension component. So this side we have the initial CT, the other side we have the post PSR CT. Definitely there is regression of ascites. There is less collateral, but the ISBRD is still persisting. Tumor did not grow much over the last 1 month. The rest all things look fine, better. The portal hypertension component has significantly come down, and a repeat upper G endoscopy showed definitely the size of the varices have come down. Now this is a controlled situation. The second step of the surgery is classical Whipple resection. We were prepared for a portal vein graft. We planned the left intrajugular vein with a preoperative Doppler. This is a slow and steady surgery, not just like in periambulatory cancer, because this particular area we did not dissect or even touch during our shunt surgery. We limited ourselves to the left side of the abdomen, left upper quadrant. The plane, even over the IVC, was very tough, partly because of the collateral, partly because of the size of the tumor. And there was dense fibrous reaction, which was all around the tumor, probably because of the long duration and partly because of our previous surgery. So varying energy devices at varying steps. So that's a superior mesenteric vein we are able to see at the end of cauterization. Small tripodal vein, all those are controlled. Now this is our classical Whipple. So distal 40% of the stomach at the level of incisura angularis will be divided. Pylorus preservation is out of question, especially for this patient. Just like in any neuroendocrine tumor or cystic neoplasms pancreas, we have a normally looking gallbladder, not a distended gallbladder, even though there is significant ISBRD on image. Even the LFT was almost near normal. Again, fibrous tissue, slow and steady. Finally, we could define the dilated bile duct, and which is confirmed with a bile aspiration on a needle and which is sent for culture. Generally, we may divide with sharp division, but in this case, because there are bile duct collateral, it's a sharp division, and this is a routine in our unit just to have a good retraction on the distal stump. Just in the upper border of inferior aspect of neck of the pancreas, where you have the hepatic artery, lymph node, we do some amount of dissection there to have a good pancreatic neck. The dense fibrous tissue reaction was something like a continuous process till the left side of the hepatoduodenal ligament. It was not just confined to the portal vein alone. This is a mobilization of the DJ flexor, just like in any other cases. In resectional pancreatic surgery, we almost always avoid energy devices for any major named arteries. So almost always there's a ligature or a clip or a fine suture control. we can see a whitish kind of stuff over the portal vein. That's that's a stuff. We thought it could be tumor, but the frozen came out as fibrous tissue. And this dense whitish tissue is continuing even beyond the level of the hepatic artery. We were in fact prepared for a portal resection, but still there is a narrowing with a fibrous tissue there. But the tumor is intact. There is no rupture. The capsule is intact. Probably this is a dense fibrous tissue reaction. The digiplex is taken to this area. In our unit, we follow a modified cattle anastomosis for the duct mucosa PJ. PG never, because our mentors taught like this. The duct mucosa anastomosis, outer poropedia, inner a very small opening made in the jejunum with 6 to 8 6-opedia, just like an arterial anastomosis, almost similar to an arterial anastomosis. Next is the hepaticogeinostomy, a very tough, thick bile duct, very tough, thick bile duct. We thought we can do a continuous anastomosis in this case. But by and large, it's usually a fully interrupted Blumgard-Kelly technique style anastomosis for hepaticogeinostomy. We tend to use an isolated ruling for the gastrojejunectomy anastomosis. Again, it's debatable, questionable, but the only point is if there is a PJ leak or HJ leak, it will be a controlled external biliary fistula or pancreatic fistula or a combination of both. We can continue to feed the patient. We can continue to refeed the bile, drain effluent through the feeding genomes. Certain things are made as a uniform step because our residents and younger surgeons can also perform. So this is side-to-side jejunostomy, usually done by our residents in our unit. But again, feeding genostomy is a must. Even if you do 1,000 or 1,500 ripples, doesn't matter. 2 drains, 1 anterior, 1 posterior. Again, SCPJ protocol. Feeding genostomy in all the cases. We place the drain before, then only do the feeding genostomy. We do modified Wilson technique, that is sub-serosal tunnel, and always fix away from the main wound so that if at all there is a re-acceleration for bleed, we should not be dismantling our feeding genostomy. So this is a Whipple specimen, classical Whipple specimen, last tube on the head of pancreas. So the histopathology confirming the preoperative CT scan diagnosis of solid pseudopapillary tumor, but without any evidence of metastasis. So follow-up 19 months after pancreaticoduodenectomy, clinically well, LFT is normal, but still the Doppler at 3 months, 6 months, showing there is a portal vein stenosis which was there in the preoperative CT scan, but no ascites, no shunt, very small esophageal varices, and shunt is patent on ultrasound. To sum up, it's a very rare presentation of a large solid pseudopapillary tumor head of the pancreas. So initially we assumed that it is a de novo EHPO with bleed, recurrent bleed. So just a shunt, forgetting there is something sitting on the right side of the abdomen. Reassessment after 1 month. Then we approached as a solid pseudopapillary tumor without an EHPO because there's a shunt which is working. Thank you. Thank you so much.
Thank you, Arun. It's a very nice presentation and very nice video. But I think we'll not have any discussions because we are already running out of time because the discussion once started on this topic, it will continue for next 1 hour. So I think we'll go to the next session now. So we ask Vinay, please start for the next. Thank you, all my chairperson.
Thank you so much.
To chair the next session, I would like to call upon Dr. Ajay Sharma sir, Dr. Sadik Sikora sir, who is going virtually. He will chair this session virtually on repeat pancreatectomy for recurrence.
Can we have Dr. Sadik sir online, please? Dr. Sadik sir, am I audible?
Yes, Sajay, good afternoon. Can you hear me?
Yes, sir. Sir, good afternoon, sir.
Yeah, good afternoon. I am here, very much here. Dr.
Yes,
Miyazaki is going to present online.
Hello. Dr. Miyazaki is going to present on repeat pancreatectomy for recurrence. So,
Is it online?
no, sir, he's here. He's very
Okay,
much here.
great. Great.
Yeah. So, I'd like, since Dr. Sadiq has been knowing Dr. Miyazaki since our SGPGA time, so if Dr. Sadiq can introduce him from
No,
his.
no, please go ahead. Please go ahead.
Sir, Professor Miyazaki has been working in Department of General Surgery, Chiba University since 1983. And he was promoted to professor and chairman in 2001 and also director of Chiba University Hospital and the vice president of Chiba University in 2011. Dr. Miyazaki has been president of the Society of Japan Hepatobiliary Pancreatic Surgery since 2012. He hosted 112th annual meeting of Japanese Surgical Society in 2012 and also 49th annual meeting of Japan Biliary Society in 2013 as a president of the Congress. He received an award of Japanese Society of Advancement of Surgical Techniques Research Encouragement Award in 1997, Japanese Society of Gastrointestinal Surgery Art of the Year, Section of Surgery 2015, and 25th Indian Association of Surgical Gastroenterology Conference at Pune in 2015 for delivering the ISG AIG oration at 25th National Conference at Pune in 2015. Dr. Miyazaki's research interests include HPV malignancy, HPV surgery, and liver transplantation. With that, I invite Dr. Miyazaki for his session today.
Oh, thank you. Thank you, Mr. Chairman. At first, I would like to appreciate Professor Kapoor and JSF meeting staff for your kind invitation. It's a great honor and a pleasure for me to be here. Today, I would like to talk about the repeat pancreatectomy for the pancreatic cancer recurrence after initial pancreatectomy, and also little surgery for pancreatic cancer recurrence. Generally, there are three main different sites after resection for pancreatic cancer: local regional pancreatic cancer, and liver, lung, and peritoneal metastasis. The pattern of the recurrence after curative resection for pancreatic cancer is investigated. Most frequent site of recurrence was extrapancreatic site in 60%. Isolated local regional recurrence was 17%. Among the extrapancreatic recurrence, the liver was the most frequent site of recurrence at 80%. However, it was shown the type of cancer recurrence did not significantly influence the prognosis. Most of these recurrent patients were treated by non-surgical treatment. In 1993, Professor Renoir in France reported that in 47 patients undergoing total pancreatectomy for pancreatic cancer, multifocal feedback, ductal adenocarcinoma was identified in 32%, and epithelial dysplasia of pancreatic duct was found in 25%. He pointed out the frequent occurrence of multicentricity of pancreatic cancer in the pancreas. The multicentricity of pancreatic cancer has been reported from 14 to 59% of incidents in previous research. As the pancreatic cancer arising in the remnant pancreas after initial pancreatectomy, Dr. Rossini reported of 6 cases of repeat pancreatectomy, and their pathological findings showed 2 out of 6 cases were identified as having independent cancer. It might mean second primary, not true relapse. But usually, from clinical standpoint of view, it is very difficult to discriminate real local recurrence from second primary, the preoperative. So I do not think it comes to be a crucial matter for clinical therapeutic implications. In a previous study in 2014, among 326 surgical resected patients pancreas cancer, 170 patients, 52%, recurred after surgery. Among these 170 recurrent patients, there are 67 patients, 39%, as having isolated local recurrence. Out of 67 patients with isolated local recurrence, 11 patients, 6.5% of all recurrence, 16% of all isolated recurrence received surgical redo surgery. The survival of repeat pancreatectomy was only described. Repeat pancreatectomy might bring about remarkable beneficial effects on prognosis. The 5-year survival rate was 46% in repeat pancreatectomy group, significantly better than unsected isolated local recurrence. As to therapeutic strategy for isolated local recurrence of pancreas cancer after pancreatectomy, systemic review by Dr. Gu shows the surgical redo surgery obtained better prognosis as compared with chemoradiotherapy and stereotactic radiation therapy. Recently, Dr. Kim from Korea also reported the results of surgical resection for isolated recurrence of pancreas cancer in 48 resections. In their series, the incidence of isolated recurrence was similarly as me, 24%, and redo surgery for isolated recurrence, or isolated local recurrence, and also isolated lung recurrence could obtain beneficial effects on the problem. So I'd like to show my experience case study. This 71-year-old woman with pancreatic cancer involving the portal vein came to our institution in 2011. She underwent pancreatic duodenectomy with portal vein resection as reconstruction. Pathological findings showed PT2 and EN2 and outer. Almost 3 years later, she has a recurrent region in remnant pancreas, as shown in this slide, close to the pancreatic jejunum. We decided to do the redo surgery for this isolated local recurrent region. Total completion pancreatectomy was done. Pathological findings showed PT1 and PM0 or 0 resection. After repeat pancreatectomy, she has enjoyed ordinary life. She died of old age without any recurrent sign on 9 years, 5 months after first surgery, 7 years, 8 months after second surgery. This other case, 61-year-old woman presented with pancreas head cancer, and she underwent Jaipur in April 2011 at the other institute. However, 51 months later, she recurred of cancer in remnant pancreas, as shown in this slide. She came to us, and she underwent total completion pancreatectomy in July 2015. Pathological exam showed PT1, PN1 outer resection. And then she is now very well without any recurrent signs, 7 years, 4 months after second surgery, and 11 years, 6 months after initial surgery. This special case in our series was 49-year-old man, preoperative CT clearly showed pancreatic tumor involving the common proper hepatic artery and the gastroduodenal artery very severely, and also involving portal vein. He had visited many institutions in Japan for surgery, and we planned a special scenario of surgical treatment with him. Due to obvious tumor involvement of common and proper artery, we decided preoperative coil embolization of common proper hepatic artery before surgery, as shown in this slide. The hepatic artery blood flow was shown to come from through the inferior splenic artery after coil embolization, as shown in this slide. We have already underwent 21 cases combined hepatic artery resection with pancreatic duodenectomy or total pancreatectomy by using this preoperative hepatic culture polymerization strategy in 2017. These strategies brought about right to moderate hepatic cellular damage transient, as shown in this figure, increasing ALT, ST level in all 21 patients. 2 weeks after cold embolization, he underwent pancreatic duodenectomy with combined hepatic artery without reconstruction and portal vein dissection with reconstruction using Vascular vein graft in August 2007. After surgery, he recovered very well without any serious complications. He had returned to his working life completely and had enjoyed family without any restriction. He had enjoyed his social life for 8 hours, 10 months after surgery without any recurrence. But he had recurrence 8 years after surgery in the isolated local remnant. MRI, CT, clearly demonstrated isolated local recurrence in the remnant after PD. Inferior chronic artery had still played a major role for hepatic artery blood flow after hepatic artery resection by first surgery. The reconstructed portal vein seemed very good patient. Preoperative EUS showed no invasion to the celiac axis. 8 years, 5 months after initial surgery, he agreed with reduced surgery. This slide shows the serious change in serum CA 1997 before surgery. We applied completion total pancreatectomy to him. During surgery, celiac axis and the inferior chronic artery were very carefully preserved. Operation time was 4 hours, blood loss was 500. He recovered very quickly after surgery and still very well at the present time. 15 years, 3 months after interpancreatectomy. 6 years, 6 months after second surgery without any recurrent signs. He is still working as a businessman and playing tennis on every weekend. Until the end of September 2021, we have experienced 72 patients of combined arterial resection with pancreatectomy for pancreatic cancer. Pancreatic duodenectomy with hepatic artery in 17 patients. Distal pancreatectomy with celiac axis in 49 patients, and total pancreatectomy with artery resection in 5, and resection of local lymph node recurrence in 1 patient. Among 72 patients of arterial resection with pancreatectomy, 39 patients required concomitant portal vein dissection. Until the end of November 2022, this year, we have experienced 35 cases of repeat pancreatectomy for isolated local pancreatic cancer recurrent in the remnant pancreas. And also we do dissected for other recurrent cancers in six patients of extrapancreatic local recurrence, mainly lymph node, 24 patients of liver met, and 19 patients with lung met, totally 84 patients, recurrent patients received reduced surgery. Overall survival was 35 patients who underwent repeat pancreatectomy was shown in this slide. 83% and 48% and 5 and 10 years survival after initial surgery, and also 46% of 5 years survival rate after. So total completion pancreatectomy are 2 different types. One is the distal pancreatectomy followed by whip, and the other type, whip followed by distal pancreatectomy. There are no significant difference of survival between 2 groups. Among 35 repeat pancreatectomies, 9 patients underwent combined vascular resection at second surgery. It was mainly combined portal vein dissection. However, no significant difference in overall survival between 2 groups. In our series of reduced surgery for recurrent pancreas cancer, there are 6 patients of extra pancreatic local recurrence who underwent redo surgery. As compared with overall survival of repeat pancreatectomy in 35 patients, similar prognosis was obtained in 6 patients with extrapancreatic local recurrence, as shown in this slide. Previous our report in 2020 shows the prognostic factor in patients undergoing repeat pancreatectomy for isolated local recurrence were lymphocyte to monocyte ratio and lymph node involvement in multivariate. CA19-9 marker level were not important role in factor. On the other hand, systemic review and meta-analysis about oligometastatic pancreas cancer to the liver was reported in 2020. It's shown patients of pancreas cancer with oligometastatic liver undergoing surgery after chemotherapy have significantly higher survival rate compared with patients treated with chemotherapy alone. Dr. Hamada also analyzed this issue by using U.S. National Cancer Database after propensity score matching patients who received multimodality treatment for liver-only metastatic pancreas cancer, such as surgery, chemotherapy, has a longer median OS compared to those who received chemotherapy alone, or 15 months versus 8 months. This study may suggest pancreas resection in patients with liver mets in combination with chemotherapy may be associated with improved survival in very well-selected patients. But I would like to show our data about surgery for hepatic mass of pancreas cancer. In our series, 25 patients with hepatic mass underwent surgical resection. We carefully selected patients for surgical resection of hepatic mass. As shown in the slide, the prognosis of after surgical resection is not satisfactory. However, patients with 1, 2, 3 hepatic nodules achieve better survival than patients with more than 4 nodules. Further careful trials should be waited for evaluating the role of surgery for hepatic oligometastasis. On the other hand, surgical resection for isolated lung mets achieved remarkably favorable prognosis as compared with non-surgical treatment group in our city. A multi-center French study of local treatment of pancreatic cancer metastasis showed local treatment metastasis from pancreas cancer, such as surgery, radiofrequency, and others, is associated with prolonged survival. However, it was revealed the factors associated with shorter overall survival were liver mets, lymph node N2 status, and synchronous metastasis. Generally speaking, it seems highly unlikely that one liver met seen on conventional imaging is actually the only metastasis region. At the present time, WHO International Clinical Trial Registry platform currently has 3 studies registered on oligometastatic pancreas cancer. The jury is still out. We have to wait these results. So I'd like to give some take-home message finally. When local recurrence after repeat pancreatectomy for pancreas cancer is identified, it should be evaluated whether local recurrence is isolated or associated with other recurrence by using CT and redo surgery should be considered an option. The treatment of the patient with isolated local recurrence of pancreas cancer after interpancreatectomy. Repeat pancreatectomy for the isolated local recurrence in the remnant pancreas after interpancreatectomy to bring about remarkable beneficial effects on prognosis of the patient. The prognosis after repeat pancreatectomy was not affected by combined vascular resection and type of second pancreatectomy. And 5 isolated hepatic mets from pancreas cancer might be generally not good at surgery indication, despite of oligometastasis at the present time. Isolated lung mets from pancreas cancer is generally slow growing as compared with other distant mets such as liver. After total completion pancreatectomy, the patient could be doing well ordinary life at the present time. So a pessimistic is a difficulty in every opportunity, and an optimistic opportunity in every difficulty. Success is tumbling from failure to failure with no loss of enthusiasm. Success is not failure. Failure is not failure. It is the courage to continue that counts. So I'd like to conclude my talk. Despite of recurrence occurs after interpancreatectomy for pancreas cancer, HPV surgeons should not give up surgery or easily. Some well carefully selected patients with isolated local recurrence could get a chance of long-term survival by reduced surgery. So I'd like to finally really appreciate Professor Kapoor for outstanding, long-standing close communication with him and your kind invitation to this excellent meeting. Thank you for all of your kind invitation. Thank you very much.
Thank you, Professor Miyazaki, for a wonderful presentation. Dr. Sadik, sir. Can we have Dr. Sadik, sir, on screen?
Yeah. Can you hear me?
Yes, sir. We can hear you. So, questions, I think, Dr. Sadik, sir, if you have any comments or questions.
Yeah. Can I just, firstly, it's always a pleasure and honor to listen to Professor Miyazaki. Unfortunately, I couldn't be there, but it's always a pleasure to listen to him. He's sort of summarized the whole talk very nicely with the take-home messages and the final conclusions of his presentation. What is interesting to me is that he has brought out two concepts, the multicentricity of pancreatic cancer and the recurrence. And it's difficult to figure out that which one we are dealing with when we are doing a repeat pancreatectomy. And to my mind, it raises a question that do these two behave differently? And that's why there is a significant difference in the management of recurrent lesions. For example, overall, if there are 30%, and in his series, about 27% patients having isolated recurrence, only about 6%, and in the review, about 3.5% were resected. So obviously, there is a strong selection. So could you sort of bring out or throw light on the fact that how do you select these? The ones which were not resected, what is the reason for them? And ones which are selected, which is a very select group now of about 6%. And naturally they did very well, because if you look at the survival figures of those resected, it's 83% at 5 years and 48% at 10 years, which is quite remarkable actually. So how do you select this, and what do you think is the key in selection of these patients?
Yeah, thank you very much for your nice question. The most important point is the patient selection, not all the patients, even for the isolated local recurrence. But for my selection in this previous study, only surgical feasibility, fitness, and vascular involvement of something. No other indicative useful the indicator is I didn't have at the time. After the multivariate analysis just showed the two predictive factors. But I expected at first the interval between the first surgery and the recurrence interval affected the prognosis, because that kind of interval might be affected by biodegradable behavior. But that interval does not affect any prognosis after second surgery. So I'm now checking about the genetic
Yes. Yes.
analysis in these all patients. But I'm now, I could not show any data about it. And that's my all. That's my all.
Yeah, thank you. I also thought that the interval between the primary and the resection may be a very critical factor in choosing patients for resection. And also the genetic markers or mutational markers may be very useful in determining who would benefit from surgery. Thank you very much.
Might be the genetic analysis result might offer more favorable patient practice.
The other question is technical. Could you throw light on what technical factors or difficulties you would encounter in a repeat pancreatectomy and you should keep in mind?
Pardon me?
Can you throw lights on what is the surgical difficulty intraoperatively that you have found during this repeat procedure?
During second surgery?
Yeah, revision
Yeah,
surgery.
of course, very hard to adhesion. But preoperative designing to how do you approach to this patient. That is only that thing is that don't induce any serious a very important factor to induce serious. That's only one.
In the meantime, we have one question in the audience before I take up. Yeah, yes, please.
Dr. Miyazaki, that was a wonderful talk. What we have noticed at MD Anderson was the local recurrences were isolated local recurrences were often remote from the surgery, take several years. And there's a higher prevalence of DNA repair mutations like BRCA mutations. So in the US, for instance, genomic profiling is now approved. Like 7% of like can have BRCA or PLB2 or the mutations. So I just wonder if these patients first did well because they have an intrinsically better prognosis and they may be enriched with some of these more favorable mutations. These patients should be considered for it. If they intrinsically have a better biology, they're going to do well.
Thank you. Thank you.
Yes, yes, please.
Transplantation or some other kind of.
So I'm sorry, maybe I could not give the useful comment to your question because after surgery, most of the endocrine and exocrine functional cover is depend on the endocrinologist in the institution. But as compared to the time when I graduated the medical school, as compared to that time, now the patients who underwent total pancreatectomy, the patient's condition is very improved, without no serious complications or serious disability. I have now encountered that kind of patient. Sorry, I just follow my comment.
Can I take one or two questions, Dr. Miyazaki? One thing is, suppose the primary tumor that you have resected for a PD, for a pancreatic duodenectomy, has a lymph node positive disease in the biopsy, and now you find that there is a local recurrence. There's only local recurrence after 3 years. So will it make a difference whether it was a lymph node positive disease at the primary time and now only local.
At the initial pancreatectomy?
Yes.
Oh, yes, of course, at the initial pancreatectomy, the surgical margin at the stamp is the success of R1. At the time I do the resection of 2 centimeters or 3 centimeters at first. But if the second frozen section reveals also very suspicious, at that time change without any hesitation.
I think we are running out of time. Second thing is you said about completion pancreatectomy once you had a recurrence after 3 years. If you've done a PD and then now in second surgery you are doing a completion total pancreatectomy.
Yeah.
Have you done a revision, redo PD again, meaning to say you have done a pancreaticojejunostomy again after the first surgery?
Maybe possible, but I did do that kind of surgery.
Okay. I just want to add that we had done 2 cases in which we had a local recurrence and we have done a revision surgery, and we did a revision pancreaticojejunostomy, and in one patient it was PET scan positive, but the final histopathology has come as negative. So that was my another question, that if you have a PET scan positive lesion with a normal CA19-9, will you consider it to be a recurrence because the final histopathology is negative for malignancy now?
Maybe it's another choice. Yeah.
One last question. Do you give neoadjuvant therapy prior to second surgery?
Second surgery, most of the patients, oh no, every patient, of course, recurrent patient, despite they receive postoperative adjuvant chemotherapy after initial surgery. And after the historical evaluation for second surgery surgical placement, no clearly demonstrated anti-tumor effect. So in our study, most of the patients, 35 patients who underwent second surgery, I did not give the adjuvant.
Because your all recurrence were late recurrence.
Yes.
You did upfront second surgery.
Oh, after second surgery, recurrence, most of the distant metastasis, lung or something, and some patients will die without any recurrence by old age.
We thank Dr. Miyazaki for a wonderful presentation and a very important take-home message that a surgeon has to be optimist rather than a pessimist. That was in his last slide. So we have to be optimist that if it is resectable and if we are able to do resection in this case, I think that's what Dr. Sadik wanted to know, that how difficult it was, and we have to know our limitations. And if it is possible, yes, it may be a pessimistic approach. So thanks, Dr. Miyazaki sir, and thanks, Dr. Sadik sir, to chair this session.
Thank you. Thank you very much.
I would like to call everyone for lunch. We will have a lunch break and we will assemble again and we will resume our session by 2 o'clock sharp, please.
to the post-lunch afternoon session. So this will be a panel discussion with the topic neuroendocrine tumors. It will be moderated by Dr. Vikram Chaudhary from Mumbai, who's a professor in GI and HPB Surgical Oncology, Department of Surgical Oncology, Tata Memorial Center, Mumbai. I would like to welcome sir.
Good afternoon. So we meet for the post-lunch session. I'm supposed to conduct a panel discussion on neuroendocrine tumors on JEPNet. We'll start with pancreatic neuroendocrine tumors, and if the time permits, we can touch upon few duodenal and gastric neuroendocrine tumor issues also. I have an esteemed panel with me. I have a pleasure to invite my teacher, Dr. Ramkrishna Prabhu, who is a senior professor of Department of Surgical Gastroenterology at JSF Medical College and KEM Hospital, Mumbai. Dr. Ilangu Sethu from Chennai, who is a senior consultant HPB liver transplant, renal transplant surgeon at MIT Chennai, and he also manages high-risk pancreatic diseases clinic at MIT. Dr. Asit Arora, who is a senior consultant and director of GI and HPB oncology at Max Saket. Dr. Rajesh Bhojwani, who is a famous GI surgeon from Jaipur. He's a surgical gastroenterologist with special interest in GI oncology. He did his MCH in surgical gastro from Delhi in 2001. He has been in Jaipur since last 20 years. He started first teaching program in Jaipur or Rajasthan, and he's attached at Sant Bahadur. I just introduced you. Dr. Bhojwani, please join us. Dr. Deepak Chhabra, who is a senior surgical oncologist at Lilavati and Hirananda in Mumbai. He has a keen interest in GI and HPB surgical oncology, and he was also the first clinical coordinator for Asia Pacific Unity Registry, for Deepak Chhabra. And then we have two faculty from MGM, Dr. Rajiv Klasliwal, who is an associate professor in Department of Endocrinology at MGM here. He did his DM from KEM. I think we were contemporaries in KEM. He completed in 2013. He has a keen interest in endocrine oncology. Dr. Rajiv, please. And finally, Dr. Taran Kumar Jain, who is an assistant professor here at MGM, who has a keen interest in theranostics, PET CT. He's practicing in this field since last 11 years. So we have covered most of the specialties in the panel. So I have a large panel. It is dominated by surgeons. We have 5 surgeons in the panel. One is a nuclear medicine specialist and another is an endocrinologist. We don't have a pathologist in the panel, but I think the experience of these people, they will cover the pathological aspects of the definite also. So we all know that so we have been asked to conduct the session in 45 minutes and 15 minutes are to be kept for the discussion with the delegates and the comments and the final discussion and the 5 minutes for final moderation. So we have around 45 to 50 minutes. We'll try to cover 3 to 4 case scenarios in pancreatic neuroendocrine tumors. And we will use the case scenario just to kickstart the discussion and then we'll go to the specific point of the clinical dilemma and the management of this tumor. So we know that the incidence of neuroendocrine tumor is rising and it is rising disproportionately to the incidence of other malignancies. Overall, if the incidence of malignancy is increasing, the incidence of neuroendocrine tumors is increasing more than that. And the management of neuroendocrine tumors not only involves surgeons, it involves endocrinologists, it involves theranostics specialists, it involves gastroenterologists, and the interventions range not only from observation and wait and watch, but directly up to the liver transplant. So it is not one person's job or not a surgeon's job only, but you need a multidisciplinary treatment team, and therefore the importance of MDT cannot be stressed more as managing the neuroendocrine tumors. So we started this activity in CMS in 2018, and barring the year of COVID, 1 year when we could not conduct a live clinic. We have discussed 431 new patients of definite in last 4-5 years. You can understand why I'm saying that the incidence of neuroendocrine tumors is increasing. So around 60% of the patients are male, and most of them are from 50 to 60 age group. But 70% of the patients are metastatic who present to the Japanese clinic. And therefore, I said that it is an MDG decision, you need a multi-specific treatment to manage. So let's kickstart with the first case.
Hello.
Yes, sir.
Vikram, let me just say that the incidence probably is not increasing, but awareness about the disease and the time, number of investigations and pancreatic protocol evaluations of the lesions have improved. So probably the number is a little skewed, because the numbers must be more, but we are diagnosing because we are understanding the disease more commonly.
I completely agree with you, sir. Whether it is a overuse of cross-sectional imaging for the minutest of the upper GI symptoms, or whether it is an increased awareness, we don't know that. But the number of patients who we are treating effectively is increasing, is what I meant. So yes, great point. So to just kickstart with the first case, 47-year-old male, abdominal pain since last 10 months. EOG showed multiple hypoetic liver lesions and probably a pancreatic body lesion, which was a primary. Biopsy from this lesion suggested a grade 2 neuroendocrine tumor, and the MIB index was 8%. Outside, the patient was started on monthly sandostatin LAR, which he received for 3 months. He had persistent pain, so he came to us after 3 months. So this is a grade 2 pancreatic neuroendocrine, probably non-functional. Patient has multiple bilevel liver metastasis. So what next? So patient has already undergone a biopsy. So maybe any one of you can maybe kickstart and maybe stress the importance of good biopsy and whether you can do away with the FNAC in this. Maybe Dr. Deepak.
I think the most important criteria was just mentioned is that we are getting more and more better, because probably the pathologists are also now seeing it better. With the knowledge improving, they are reporting more neuroendocrine tumors. FNAC, okay, let me just take the last point, FNAC versus biopsy. Is it possible to diagnose neuroendocrine tumors on FNAC? We've had many discussions with our pathologists, and FNAC definitely they can diagnose neuroendocrine tumors. But one of the important aspects of giving the clinical information, or for that matter, taking the ball rolling for diagnosing and treatment of neuroendocrine tumors, is to have the proliferation index, or what is called as the MIB. And second part is from the diagnosis, they need specific immunohistochemistry markers, which are the chromogranin, synaptophysin, and the neuron-specific inolins. So I think these IHC markers, as well as the MIB index or the Ki67, are done purely on a biopsy. So I would say even a fine biopsy, no, but proper good chunks of core biopsy.
Point. So they can commit the diagnosis of a neuroendocrine tumor, but you can't just manage the patient with the diagnosis of neuroendocrine tumor. You need a grade, you need to do IHC, and you need the MIB index. And that is the reason why you need a biopsy. Yes, go ahead, Doctor.
Yeah, so I think if you go by the pathologist's recommendation, they need at least 2,000 cells to come in. And whether these 2,000 cells come from an FNAC or FNAB, it all depends. And if you talk to the endoscopists and they do it US guided, it all depends on the smaller lesion, bigger the lesion, more the necrosis, and less the yield. You need more passes, maybe 4 or 5 passes. Smaller the tumor, less necrosis, even 1 or 2 passes can do. And even with FNAC, there have been reports wherein they have been able to kind of give you the grading in about 25, 30. Of course, if you do FNAB, you might be able to achieve that in more than 1.
So most of the time, yes, go ahead.
The key recommendation was to do both. So that the yield is much better than either one of them.
So when you are actually trying to diagnose a neuroendocrine tumor, if you have a suspicion of a neuroendocrine tumor, clinically, prefer a biopsy or a FNAB whenever possible is the take-home message. So there was a new WHO classification which was proposed. Now it's no more new. Actually, it has now come into practice since 2017, and now it's 5 years. But it's still not a well-recognized entity. So maybe any of the faculty can take this point and maybe stress the changes which were carried out in the 2017 WHO classification for the benefit of delegates.
So two major important updates which have happened from 2010 to 2017. One is if you see the classification, the neuroendocrine tumors have been now, which was called as NETs, have now been called as NENs. These are the neuroendocrine neoplasms because it has been believed that every neuroendocrine tumor is a potentially malignant tumor, and that is why you can't just put the word tumor to it. Second thing is that there has been a change in the grading where earlier on the tumors were graded on the basis of the MIB labeling index as grade 1, grade 2, and grade 3. There is a significant change in the grade 3, where earlier grade 3 tumors were called as neuroendocrine carcinomas. Now the neuroendocrine grade 3 tumors, they have also seen that there are certain tumors which are well differentiated, and that is why there is a new concept which has come in that there are well differentiated neuroendocrine tumors, which you call as the NET grade 3 or the NEN grade 3. Versus there is a second category where you call as the poorly differentiated, which could be either small cell or large cell. And these would be the NEN carcinomas. That is the real bad ones, the neuroendocrine carcinoma.
I think a perfect point, Dr. Shabda, thank you. So basically, when there was a NEC, so all grade 3 tumors were classified as NEC in the past. But now, from the Nordic Next study, we have seen that the few patients who have MIB KS7 or MIB more than 20 and who have mitosis more than 20, they still behave like well-differentiated tumors, and they still behave like NET. And therefore, there was a need to include these tumors who are grade 3 because they have KS67 more than 20, but they will behave like a grade 3 tumor, like a well-differentiated tumor. All poorly differentiated tumors who have KS67 more than 20 will be classified as neuroendocrine carcinomas, and then they are subdivided into small cell and large cell. So this is one of the major changes, that the introduction of the grade 3 neuroendocrine tumors, well differentiated, was made in this classification. So you try to identify the patients who have MIB more than 20 and who are well differentiated, and also the term mixed tumors, the manic, was changed into MINEN, and I think we'll discuss it later when we have a case. So yes, this is introduction of a new group here is what was achieved in this classification, and therefore I think we already discussed that. So on the biopsy, so therefore it becomes important now that the grade 3 tumors, whenever you get a patient with a grade 3 tumor, you need to prognosticate them accurately, because few of these patients are likely to do very well, like the well-differentiated tumors, and few of the patients may not do well and they behave like poor cancer. So is there any idea, or are there additional tests which we can do on at your center? Maybe is there any additional tests which you do on these patients where you can prognosticate them? Anyone of this maybe?
So, I mean, if you talk about the staging workup, I mean, how you
on a biopsy, like anything additional you can do or can prognosticate the patient? Like for example, if you have a grade 3 NET patient, how do you know that if this patient is going to behave like a NET or if it is going to behave?
So, see, one of the key factors you said was one is the differentiation part. So, if it is a well differentiated versus a poorly differentiated. Now, why was this need arose that you have to differentiate grade 3? So, more than 20% could be up to 40% or 45% could be higher. So, usually when we have those KI67 index, one is that you have to look at whether the KI67 is about 40 to 45% or beyond that. So most of the patients who have more than 45%, they usually end up into a poorly differentiated neuroendocrine carcinoma group. Other ones would be your mutational analysis that we do, right?
So the
About
molecular
P53
markers,
and TP53.
yes. So this is a neglected entity. That's why I try to focus on this entity. So a loss of ATRX and DAX and the mTOR genes actually can be seen on IST itself. So it is easily possible to actually do it with a routine IST, and also the loss of P53 and P53. So these things do not need much of the additional testing. So I think this is what is easily possible, and therefore, if you have a well-differentiated grade 3 neuroendocrine tumor, probably it is worthwhile to prognosticate the patients by doing these additional tests, because we know that the loss of ATRX and DAX is probably telling us that they are going to behave better as compared to the patients who have P53.
If you go to your previous slide, also you'll realize why biopsy was more important, because it takes the percentage of cells which show KI index. So you require, it is a hotspot, which in an FNAC will not be picked up. So that hotspot, they will measure the amount of KI. So if it is less than 50, it is, you will go in terms of of NET and more than 50 or 55, we say
Actually, it is done manually. And
yeah,
they have
if
to
they do it
see
manually, you have to look at the
almost
spots in that.
400 to 500 cells, and then they only can comment. But this is an additional point which we wanted to stress, that IHC markers can be done in addition to grade 3 tumors selectively, where you can prognosticate it. So a grade 2 pancreatic NET, non-functional, multiple bilobar liver metastasis. What next? What is the imaging approach in this case? Dr. Tarun, maybe you can start.
The all neuroendocrine tumor which is already diagnosed on the biopsy could be initiated with the imaging of the gallium DOTA-NOC or DOTA-TATE pattern. We have to characterize the lesions. Most of time it is standing between the grade 1 and 2 if they are showing the more traceability as compared to the grade 3 or poorly differentiated carcinoma.
Can you comment on this patient's DOTA now?
Yes, sir. We are seeing the MIP image on the left, on the right side of the panel, and it is showing the multiple focal hotspot on the mid-external region and the upper abdominal region, and the corresponding transsexual images of the patients in the PET-CT images. It is showing the multiple FDG-avid liver lesions, and last image at the thoracic region is showing the FDG-avid, tracer-avid scatter lesion in the left scapula.
So Goelium 68 DOTA is almost the gold standard now. It has a sensitivity and specificity is more than 90%, and it can be used not at the diagnosis, but also the response to therapy to detect the residual disease and recurrence and the progress. So at all stages of management of well-differentiated neuroendocrine tumors, the Gallium 68 DOTA is now a standard of care. So you said
for PRRT also depends upon your positivity of that also probably will be active.
So that's why at all stages of management of these patients, right filter follow-up, gallium 68 DOTA is the gold standard. You said DOTA, TATE, DOTA, TOC, NOC. So like just for the benefit of delegates, can you tell us what is the difference between TOC, NOC, TATE?
The neuroendocrine tumor has a characteristic of the SSTR expression. SSTR is a G protein coupled receptor, and it's a 5 type of the receptor commonly present the SSTR2 expression on the most of the NET tumors. For the SSTR receptors targeting, we are targeting the various octotypes. In the octotype imaging, we are using the TOC, NOC, or TATE. And here is the DOTA is a beta-dentate ligand which is binding the heavy metal as well as the octotype peptide. So DOTA is a do-decane tetraacetic acid, and TATE, TOC, or NOC is the octotype receptor binding agent. It is a SSTR analogs. It has a property to bind the receptor and lies inside the cell and used for the imaging as well as for the therapy purpose.
So when a clinician is demanding a gallium 68 DOTA, what should they write? TATE, TOC, NOC, or they should not write?
Sir, what is the available at the site?
So you don't have to mention it, whatever is available there.
Let me put this question to Tarun, that suppose if you have all three available, what will be your preference? The very fact that Vikram has put that particular slide, that there is a TATE, there is a NOC, there is a TOC, there has to be some difference. Why is there difference in availability? There is omeprazole, there is rabeprazole, there is pantoprazole, there is also that kind of thing there. So we need to justify to give the best approach to the patient. Do you have anything in your department which says that DOTA NOC is better than the TOC, or is there sensitivity?
In therapeutic purpose, we are using the DOTA TATE. So if we will do the imaging with the DOTA TATE, gallium DOTA TATE, say identical to the therapeutic purpose. If DOTA TATE is available, so do the gallium DOTA TATE first. If gallium DOTA TATE is not available, we have to do the NOC or TOC, whatever it is.
So now this patient, yes, go ahead.
Yeah, so it's only with the intention of doing therapy later. Suppose it's a grade 1 tumor, then should you do DOTA TATE or DOTA NOC?
So then all three octotype receptor peptides has a different affinity to the receptor.
Yeah.
Most of the tumors have the SSTR2 expression. For the SSTR2 receptor, the TATE has the highest affinity. NOC has the affinity for 2, 3, and 5, all three receptors, as well as TOC has a affinity for the 2 and 5 receptors. And what is the availability of the peptide at the in-house pharmacy we are using for the imaging?
How do they make a difference? what to make available?
Actually, sir, in-house pharmacy now time the available cost on all three peptides NOC is relatively cheaper as compared to
I think we'll move
That's
on
what I
because
wanted
we
to
have clinical aspects. So now this patient has DOTA uptake significant. Yes, yes, Dr. Raj.
But though we have these three molecules, I think that's correct me, but none of them actually in studies have shown to be showing any difference in terms of therapeutic efficacy with dog.
Most of the time, sensitivity and specificity will cross 90. So most of the time, it will be adequate irrespective of what you use. Okay. So this patient had a MIB of 8%, and this patient has a significant abdominal pain. He has weight loss. Do you think that there is any justification to do FDG PET in this patient at a baseline, Dr. Tarun?
Yes, sir. If patient is categorized in the grade 1 and showing the progression, even after the getting a treatment, we have to do the FDG PET. It's so that there is some de-differentiation or poorly differentiation between the tumor. If it is showing the more positive side in the FDG PET CT, it means the tumor is de-differentiating or it's going to the poorly differentiating part.
So basically, FDG PET is not a good tracer for low-grade NETs, but it is an independent prognostic marker and predictive of lower disease control rate and progression-free survival. So the patients who are particularly grade 2 or early grade 3 tumors who have DOTA IVDP, in those patients, we still consider an addition of FDG PET at the baseline just to prognosticate these tumors. And in fact, the therapy also depends a bit on that. So association of FDG slightly increases the sensitivity of baseline assessment in the diagnosis. Whenever there is a disease progression, it may also help us in maybe changing the therapy and maybe addition of chemotherapy to the regimen. Helps in prognostication because FDG IVDP definitely imparts a poor prognosis as compared to the patients who do not have FDG IVDP. And it is a step towards personalized medicine, definitely. Having said that, if you do FDG PET in all the patients who have grade 2 tumors, you see that the clinical impact of doing a baseline FDG and maybe therapeutic change, addition of chemotherapy, does not make a huge difference in the patients unless the patient's Ki67 index is more than 12. So maybe there is a justification of doing the FDG when the MIB is more than 5, but it generally doesn't make a difference in patient's outcome till the MIB is more than 12. So just some argument to use the FDG in low-grade tumors. Another practical point, you're seeing these two images. How do you say that this is a DOTA and this is the FDG? Can you just tell them for the benefit of the patient?
In the FDG images, we are generally seeing the brain part. It is showing the FDG uptake.
This is the FDG and this is the DOTA. So if you're seeing such images, that's how you know what is the DOTA and what is the. Thank you. So now, how do you use chromogranin in management of NETs? Raju, maybe you can now come in or not commented. So we all know that it is associated, it has a prognostic significance in management of JETNET. And go ahead.
So, yeah, chromogranin can be used as a marker. I think, especially in advanced cases, we showing progression there, it can be used. But to do chromogranin, especially in low risk cases, low disease burden states, we need to be careful. So I'm going in the general thing. So doing chromogranin is important, but when to do and how to do and how to interpret the chromogranin, that is much more important because chromogranin do not have very good sensitivity specificity. Somewhere around 70%, 60% depending on serology. There are false positives, there are false negatives. Especially when these patients, like very commonly, they are on PPIs or something else, which can, lead to false positive results. So that should be taken into account when you are interpreting, especially in the setting where there is low risk disease, low burden disease, especially when you are evaluating patients after surgery for recurrence or residual disease. So there, the utility of chromogranin is not very, very good. Even none of the guidelines are very, very confident in recommending it as a marker. It all depends on patient to patient, and especially it is of really great use in those patients with advanced progressive disease. Otherwise, it needs to be taken.
So basically, the
into
chromogranin
some-
levels you can see that is associated with long-term prognosis. The baseline chromogranin levels, if they are increased, probably impart negative prognosis. It is also helps you to assess the tumor progression. A rising chromogranin level should instigate you to evaluate the patient further in the follow-up. NST is also used at few centers. I don't have personal experience, but generally it is elevated in poorly differentiated tumors. Maybe that's the reason it's uncommon use. Yes, the chromogranin is the most commonly used. One of the limitations of using chromogranin probably it costs 6,000 rupees in most private labs, maybe more, I don't know.
maybe that's and
Vikram, if you sorry to interrupt. If you look at the most of the guidelines, I think I'll beg to differ from you in this. If you look at most of the guidelines, be it INET guidelines or NENET guidelines, uh, if you are planning a surgical resection or a treatment, say patient is planned for PRRT, is a grade 2 lesion or a grade 1 lesion, a baseline chromogranin should be done because it not only sets you the basic level, it helps you in following up the patient. It is recommended for progression and follow-up, regular follow-ups. So I think this is there in most of the neuroendocrine tumor guidelines, be it ENETs or be it NET.
just because of the cost reasons, maybe you'll use it judiciously. It is recommended and it is useful as far as decision making is concerned when the levels are very high. Otherwise, it is very difficult to differentiate a level of 300 or 500 and saying that disease has progressed without evidence of radiological backup and all. So its levels are in thousands. Definitely, you are going to consider it significant. But if levels are 300 or 500, I don't think so. 300 to 500 is the disease progression, or 600 is the disease progression. So everything taken into account. Agreed, Dr. and then Raji. So having said that, the use of chromogranin, which can be regular if there are no financial constraints, but using it very frequently, it ultimately it's not cost effective, and probably judicious use with DOTA, chromogranin alternating, or maybe some a practical solution is always found out by the clinician.
But always
who
take
this
it,
test.
always take it very judiciously because it is rather less sensitive in pancreatic.
Yes. And maybe I can like introduce you to this new test, which is called as NET test, which is a blood biomarker, or which is famously now a liquid biopsy is a new thing. It is a multi-gene assay, a PCR analysis of specific net circulating transcripts in the blood. So almost 51 genes are assayed, and therefore it has been simplified into a predictive biomarker test where a cutoff of 40 is used. And now, if the value is more than 40, it is associated with progressive disease and a short PFS. And if the value is less than 40, it is associated with stable disease and a longer progression-free survival. So it is still not available in India. I don't know if it is now available, but my colleagues were in the process of discussing with the REN lab to get it in India. I think it is going to come very soon. And in few selective patients, it is going to be costly, and maybe, but it is definitely more sensitive and specific as compared to chromogranin. And this is how the standard NET test results look. So you see that this is a mid-gut small bowel neuroendocrine tumor treated with PRRT, and now the result of a NET test is 33. So probably there is no disease recurrence or there is no progress. So this is something new which is going to, I think, come up very soon. Now going back to our patient, the patient had a screening 4 uptake, that is a very significant uptake on DOTA, and also a significant uptake on FDG. So now, what is your approach now? This patient has a non-resectable liver metastasis, a pancreatic primary, and a screening 4 DOTA uptake, and FDG PET is also grade 3. Significant DOTA uptake, significant FDG uptake, grade 2, non-resectable liver metastasis. Anyone?
I mean, we need to one ask a pathologist. They have to categorize grade 2 better for us as to what is the Chi-67 index in this.
It was 8.
8. Yeah. So I think now one of the protocols would be one. You said this patient had a long-acting somatostatin therapy which failed. Now we have to seriously look for other options. One would be PRRT, and secondly would be combination of PRRT plus CAPTEM. That is something which has really come up and showed really promising results. So I think this is something we.
So his response to octreotide is actually not objectively assessed. He just came after 3 cycles of 3 months of octreotide. But Tarun, would you like to make an argument for PRRT in this patient as a first-line therapy? So what is your choice of treatment?
Sir, now time patient is showing the very good uptake on the Totonov PET CT. Scanning score is 4, and it's the highest score what we are grading. So it's a very suitable candidate for the
Maybe for the
PRRT.
benefit of delegates, you can just say what is training for.
Scanning scoring is a comparative scoring. What we are doing, and we are taking the baseline uptake from the liver and spleen. If lesion is not showing any uptake, we are getting it 0. It's showing the very low uptake, but it is lesser than the liver, we are calling 1. If uptake is near equal to the liver, we are getting it 2. If uptake is equal to the spleen, it's calling 3, and it's showing the more than spleen, it's calling like Training score 4.
So if the uptake is more, so like in this patient, you can see that the uptake is more than 3.
Yes,
so
sir.
that's training
That's
score
a
uptake.
suitable candidate for the
So that's how you
PRRT.
assess the uptake on DOTA. And now going back to the patient, so what is the plan for this?
It is also showing the high uptake on the FDG. So definitely it's also have a poorly differentiated component with the well differentiated component. So we will combine the PRRT with chemotherapy for this.
So would you consider, I will argue for a continuation of octreotide in this patient sometime. Am I justified in doing that, or you will stress on moving to the, you have
Sir.
evidence to support your PRRT as a first line treatment in this patient?
Before the starting of PRRT, we are stopping the long-acting octreotide analog for at least for 4 to 6 weeks. We are shifting the patient from the long-acting octreotide analog to short-acting octreotide analogs. And for the short-acting octreotide analog, we are stopping them for at least 24 to 48 hours prior to PRRT therapy. And we are giving the PRRT therapy along with the combination of the chemotherapy. Generally, we are stopping the octreotide analog.
So basically, in this patient, a combination therapy of PRRT and chemo was used.
Vikram, can I just ask you, why not just give a trial for chemo only? If you go back to your options that you have shown only.
Trial for chemo, so basically the
See,
first thing
Ki-67 less than 10%. Capecitabine temozolomide has been proved that for patients with Ki-67 around 10.
Okay, I understood your question. I'll answer that. Basically, this patient, the indication for chemotherapy as a primary treatment can be counter-argued from the beginning only. The treatment of choice in this patient should be the first line would be octreotide. If it is not responding or if the disease progress, it would be PRRT. In few patients like this, an argument is made for addition of chemotherapy to PRRT, not the chemotherapy as a standard treatment. This patient has a significant DOTA uptake,
But we don't have current evidence to suggest that PRRT should be used as a part of the first line management. We don't have comparative studies to show that what is responding. When you give a combination of chemotherapy and PRRT to the patient, you don't know whether it's a PRRT working or whether it's a. I think there is a recent trial which is going on, which is recruiting patients to collect data. I think it's Netter. I don't know. I'm not sure whether that trial will give us more answers about whether what is more responsive in this patient, whether it's the PRRT or whether it's chemotherapy. So I think in this situation, I think continuing LAR with chemotherapy is option number one. Since you have patient has already taken LAR, continuing with chemotherapy, I would go better. Or possibly I would have selected a fifth option, that is chemotherapy plus minus PRRT, which brings down your third option as plus minus.
Dr. Vodwani,
I would, because the morphological uptake was much kind of not expected with the index of 8%. Now this was after LAR treatment. It is possible, and it has been reported in the literature. I mean, particularly with chemotherapy, but sometimes with LAR also, there can be a downregulation and less expression of MIB.
That's why you have to wait. Yes.
Yeah. So maybe it's a good choice to repeat a biopsy from the liver, confirm. It might correlate with your morphological depiction on the scans, and then you might have to change your, the kind of line of treatment.
So
Rather than
usually,
PRRT, you might go to chemo.
So with the assumption that the primary MIB is wrong, maybe you can repeat the biopsy. But sometimes if the treatment has continued for 2 years or 3 years, a tumor dedifferentiation is something which is known to happen in neuroendocrine tumors. And maybe that is one of the indications where the patient who did not have a primary uptake in FDG in a primary treatment, if he has an FDG uptake after 2 years of therapy when they have progressed, that's the time when you probably repeat the biopsy and try to find out whether the tumor has actually progressed. Having said that, first, yes, go ahead.
In the presence of a liver metastasis, the life of the patient is decided by the metastasis. In that situation, do you think assessment of MIB7 repeat biopsy would be okay?
Yes. Another argument
Only with
is
the intent of deciding the trial.
so these patients who have a dual uptake, there is an argument for another biopsy from the site where there is a FDG. So if you at all, probably these tumors are heterogeneous. Some patients, some areas have DOTA uptake, some areas have FDG uptake. So if your first biopsy is showing a well-differentiated tumor which has a low MIB, there is an argument to do the biopsy again from a site where there is a high FDG uptake, and maybe then compare the final, because the highest grade is what you have to take, and the therapy will be decided by the highest. But if you have a tumor which has where you are planned for chemo and PRRT both, probably it is not going to change your management, and maybe you can avoid it.
Vikram, absolutely going by your argument, this patient should get PRRT with chemotherapy rather than either of them single.
Yes, sir, that's
Yeah.
what was done in this patient. So this patient received 4 cycles of PRRT. He completed the treatment, and it was combined in a grade 2. The choice of regimen is cape temozolomide, and therefore it was combined with cape temozolomide. The patient did well. After that, he's still following with us regularly. Now, this is another patient. You can see that he has both baseline DOTA. You can see that there is a significant uptake in the sternum and the liver. Maybe Tarun, you can actually comment on the uptake rather than me commenting on it.
There are two images, and first is the baseline, and second is showing the post-treatment images. In the we can actually see there is in the MIP images there is significant resolution of the hot spot in the MIP images. After the treatment, there is a resolution of the tracer abbott superficial component in the scatter region in the sternum, and there is appearance of sclerosis. It means there is a healing of the region, and we can actually see there is a significant loss of the tracer abbott tissue in the liver, and there is only non-tracer abbott heterogeneous soft tissue density hypodense lesion is localized in the segment 4 and 5 of the
So
liver.
basically, it is suggesting a very good response. The same patient had an FDG uptake also, and the patient received 8 cycles of cape temozolomide along with 4 cycles of PRRT. I just put this another case to stress the importance of probably addition of chemotherapy to PRRT as a first line. And these patients, in our own experience, we just published this experience that whenever the Ki-67 is more than 5%, combination of PRRT and Kepten is probably the regimen to go, and it is improving survival. In the previous study, you saw that the multiple retrospective studies which were analyzed, that probably Ki-67 more than 12 is the cutoff, but we have used it at 5, and all patients with MIB more than 5 at our place undergo doll baseline imaging. But having said that, we are trying to recruit patients. We don't know whether this should be the first line, whether only PRRT can help, and you can treat the patients on progression with chemotherapy. So we are doing a randomized trial where a patient with a well-differentiated grade 2 tumor will be randomized into PRRT versus chemo group, and their outcomes will be assessed. It's going to be a big trial. More than 200 patients have to be recruited. We have reached around 60-65, which is an old slide, and I think. So now in a netted trial, a best supportive care octreotide with PRRT was compared with PRRT with a LAR high dose, and the benefit of PRRT in patients who have progressed on octreotide was proven. So Tarun, would you make PRRT as a first line therapy rather than LAR in all these patients, or you would like to go ahead with LAR only as a first line and then go ahead with PRRT?
There is a now time there is a NETR2 trial has been already completed. It's a NETR1 trial, whatever you have seen. In the NETR1 trial, they have used the lutetium and yttrium-90 both for the therapeutic purpose. In the NETR2 trial, they have only used the lutetium and dotatate for the therapeutic purpose. And mostly they have shown that if patient is showing it's non-surgical candidate, they are using the first line PRRT for the therapeutic purpose, and they found there is around 25% of the patients showing a significant response after the initial 2 cycle of the therapy, and there are 56% of the patients they are remain stable after the 4 or 6 cycle of the treatment.
Basically, you have arguing for the PRRT as the first line. Having said that, the response rate with the PRRT is usually in the range of 40 to 50%. You can see that this is a patient who has a significant training DOTA uptake, but after 2 cycles of PRRT, there is not significant response. This is a grade 2 neuroendocrine tumor. So this patient doesn't seem to have responded to your first line therapy, Tarun. So what do you want to do in this?
Sir, if it is not showing the response in the even after the first line of the chemotherapy, we can add the chemotherapy.
Okay. So there is no DOTA uptake in the FDG uptake in this patient. Anything else you can do? So that brings us to the intraarterial PRRT, where probably if the patient has not responded, the NETR1 post-hoc analysis told us that if the liver lesions are more than 3 centimeters, it's a poor prognostic marker for survival, and probably these patients can do well if you, rather than giving intravenous PRRT, you can consider intraarterial PRRT. It's more like a taste rather than just IV PRRT. And this is something which is now being assessed by a Lucia trial, where intraarterial PRRT is being assessed. The basic principle is the tumor burden is high in that lobe. You cannulate that lobe, give the PRRT directly into that lobe in the artery, And the second part of the another lobe of the liver will be taken care of by the second part of the first after that. So that's the intraocular PRRT. I think this is another thing which is coming up now. You can see that the same patient who did not respond to 2 cycles of IV PRRT, after 2 cycles of intraocular PRRT, there is response. Probably something to look at if the patients are not responding to IV PRRT. Yes, go ahead.
In the intra-arterial PRRT, there are a lot of the patient population. Actually, they are looking for the shunting before the planning of the patient. We are planning the patient for the rate therapy in the cath lab only. And we are giving the much more exposure in the cath lab in person. And there are chances of embolizing after the therapy and during the therapy, it's higher.
So it's a complex procedure. The costs are involved. But if your PRRT is not responding and if the disease is high burden, probably something which you can use selectively in few patients. Yes, yes, doctor. Go ahead.
Vikram, I mean, that's not the point. We do tear all the time for liver lesions, right? HCC. It's just a similar kind of lesion. You're using a different radioisotope. So I think it's not something that you can discount on that point. It's a very good treatment option for these selected patients.
I know, but who is going to treat? He doesn't want to do. I don't know why.
He's doing.
But here we are using around.
Basically, he just wants to raise the concern about the routine use, or maybe Dr. Tarun has worked with the in AIMS, and the group in AIMS has the highest experience with alpha therapy in India. Probably you can comment, maybe introduce the alpha therapy to the delegates and how you can use it in these kind of patients.
Sir, alpha therapy has been
maybe
introduced.
short.
Alpha therapy is introduced in India in 2017-18, and in the alpha therapy part, we are using the actinium-225 in the India, and we are binding the actinium-225 with the rotate.
Please stop us whenever the time ends, because
What is the difference between the lutetium beta emitters and alpha emitters? What we required for the therapy purpose, we required the short path length and high LET. The short path length is required because there is lesser damage to the nearest healthy tissue, and the high LET is required for the maximum damage to the diseased tissue. So alpha emitter is fulfilling both of the demands. So we are using now at time actinium-225 rotated therapy in which patients who are refractory for the beta therapy.
So basically, you can consider them if they are progressing on the beta therapy. It has a benefit of being active irrespective of the cell cycle, and it produces direct cell damage. And actinium and lead are the two things which are probably looked up to. Actinium is what is most commonly used. And again, the initial results are better. I think the experience at AIMS has increased further. This was the first publication with 35 patients. It is promising, but the cost is an issue, and exact indications need to be defined further. So this is something which we have to see if the patient is not responding to intravenous PRRT, intraarterial PRRT, and alpha therapy are something the new avenues which are available for these patients. Now, from these patients, now coming to the next scenario, these scenarios we'll just discuss the management and go ahead, because we have discussed most of the basic things. So this patient had a bilirubin of 2, and he came 45-year young male, hypodensic lesions in both lobes of liver, and a lesion at the ampulla. So there is an ampullary primary. However, the interesting part in this patient was the biopsy, which was minor. The MIV index was 60%, small cell type, poorly differentiated. So this is a metastatic minor. So maybe someone can take this, or what is a manic or a mining? So this is a terminology for the mixed type of tumor. Many neuroendocrine tumors have mixed component. The primary component is the neuroendocrine component. The other component can be an acinar cell tumor or an adenocarcinoma or anything. An adenocarcinoma with neuroendocrine tumor differentiation, or a neuroendocrine with some presence of adenocarcinoma or acinar cell carcinoma does not mean malignant. For a tumor to be defined as a malignant, the two tumors which are there have to be coexistent, and each component has to be at least 30%. So then only you can call it malignant. So this patient had a malignant. So this patient has a MIB of 60%. So obviously the DOTA PET was not done, and the first line investigation was the FDG PET. You can see that the lesions are there scattered throughout the liver, both lobes, and there is an ampullary primary. So in this patient, what is your first line treatment? Anybody?
I think we'll have to go for systemic chemotherapy for this. I think
a grade 3 tumor with a significant FDG uptake, systemic therapy, because it's a carcinoma.
Platinum and
the regimen has changed, and cisitoposide was used. After 8 cycles of cisitoposide, you can see that the patient has a complete metabolic response. I don't have a metabolic response images, but you can see that there is no lesion seen now, except a small 7 mm lesion in segment 7. So what next? So this patient has responded in last 6 months, complete metabolic response, only solitary lesion. The jaundice resolved, the periampullary lesion has also resolved to a certain extent. There is only a 7 mm lesion, solitary 7 mm lesion in the.
I think this patient has already, to begin with, was with a metastatic disease. Now it has responded with a small 7 mm lesion. It can be localized. Local therapy to that lesion of liver be more appropriate, and then wait, observe the patient.
Dr. Ilango, you can.
There is no guide.
Yes, sorry. We will just stop it after you.
There is actually no guidelines on this. I think each one does what is comfortable.
So that's why the importance of MDT and what why I was stressing the importance of MDT. There is no clear guideline for this clinical scenario. Now you have a patient who has complete response. At the same time, he has a neuroendocrine carcinoma, which is a very poor grade. So I think you can do whatever deemed fit.
Was it oligometastatic or was it beyond the confines of oligometastatic? That would probably will help you.
So that was
in
my next
decision
question.
making.
Did we have an MRI for this patient? Because many a times in such situations, MRI gives you a much more better prognostication of the liver metastasis.
But there are already multiple bilobar liver metastases.
Multiple bilobar.
So now they are not seen.
So now comes the situation that if you have MRI and if you are still seeing couple of more lesions in the liver, then I think
I would say all the
options are open. But if
Had it
one
been a
thing,
single lesion, probably would have gone and resected
what I
the
say,
ripples
all
along with
the
liver.
options
But
are
then, but
so I would still differ. Single lesion, I would agree with.
don't have to
that
argue.
Ablate
All
it and
options are
wait.
acceptable.
Ablate and wait because it's a minute.
Thank you. Maybe our audience can have questions. We had another interesting case where surgery was done. Actually, both these cases were inoperable. But if audience have some questions, we'll take them. Otherwise, we'll just. Yes, sir.
So I have faced two difficulties in these scenarios. The first is whilst you're treating, focusing on the liver bottom, right? I think you quickly referred to it. Would it be different if it's a GI prime? Do the rules still apply of resecting the GI prime? That's one question. The other has been after about 6 or 7 cycles of PRR, when do you stop? What is your target? Patient is doing reasonably well. Lesions are there, of course. And when do you stop? So what is the end point of that PRR?
End point is the maximum dose. Go ahead.
In the FD radionuclide therapy, there is some critical organs where we will decide how much we can give to the maximum dosage to the patient. Whatever we are giving to the patient, it causes some damage to these organs. In PRRT, there are two critical organs. First is the kidney and second is the bone marrow. For the renal protection, we are using the positively charged amino acids and glycoprotein for the renal protection in every PRRT cycle. And again, we are measuring the GFR after the therapy, and we are in the routine setting. For bone marrow, we are also doing the routine CBC at the time of the patient visit. If we found there is a potential renal toxicity or there is a higher bone marrow toxicity, then we stop the treatment and we will wait to recover. Then again observe the patient. If patient
Basically, what Tarun is saying, basically, the maximum possible dose you use and you stop. You wait for the disease to progress.
So conceptually, you're just trying to. So this is control. I mean, I'm not using the word palliation. Control. So why would you want to go up to almost resectables and create other problems?
Sir, actually, if patient is responding, patient is very well responded after the treatment, we will stop the treatment. If patient is not responding well after the treatment, we will add some drugs also, and we will try to search out other options if it is feasible. If it is not feasible, even after the other options, we can continue that.
You don't have to go to the toxic doses. The toxicity can happen even with just the word.
Under control. What is it? Sir, in NATA trials, NATA 2 trials, they have already given the 6 cycles, and in the end, we are giving generally 8 cycles, maximum 8 cycles.
So what is the dose which you basically give? Probably that will explain.
Sir, actually, in the one cycle, we are generally giving 150 to 200 millicuries for the one patient. If patient is adult, if patient is kid or children, we are giving between the 100 millicurie to 120 millicurie in per second.
And what is the total dose in one therapy schedule cycle?
150 to 200 millicurie.
After. And so such 5 to 6 cycles you can use. So 1 gray it is baseline treatment.
Sir, for the bone marrow, they have defined the 1.2 gray is the maximum recommended dose.
So 1.4 is something which can you like maximally stretch. And if you are deferred the therapy after 1 gray, you can actually after 2 years, you can re-challenge the patient with another PRRT, and maybe you can use it in maybe 2 cycles more, and even more if you're given a break of 2 years. And coming back to Dr. Nagaraj's question, is there a role of resection of the primary in patients who have a stable or responded liver disease? There is no prospective study as such, but there are multiple studies where they have shown that the retrospective studies that if you have achieved a stability or a response in liver-limited disease or metastatic disease, there is some role for resection of the primary in mid-gut tumors. And however, having said that, you have to be judicious in selecting the patients where you are going to target the primary. If you have a pancreatic head tumor, if you are going to do a Whipple, a treatment of a liver after that can get complicated. If you do a Whipple and if you do a biliary anastomosis, and if you ablate the liver lesions later, the patient might have very serious infection. Yes, Dr. Ilango, you can add.
I think they get abs.
Yes, so that's right. So you have to be very judicious in offering the surgery for primary after them in patients who have responded. So this concludes our session. Thank you very much. I thank Dr.
Vikram,
Kapoor for this.
Just to continue with Dr. Nagaraj's question.
No, our time is over. Okay.
Just to complete Dr. Nagaraj's question, if the small bowel lesions are there, probably the complications can occur. So with liver, probably the small bowel can also be tackled if there is a medical.
Yes, the small
Yeah.
bowel, distal pancreas,
Distal
are
pancreas.
maybe the standard surgery which you can offer after you achieve the stability. Whipple is something you should be using selectively. If you're going to plan a transplant maybe in the long run, which is a very uncommon thing, maybe there you can. So sir has given us 5 minutes graciously. So we can
we divide this, Vikram? Can we divide this into G1, G2, and G3? Let's the juniors
everything
take.
is for G1 and G2.
Correct.
There's
So G3 obviously no palliative surgeries for whatsoever.
G3 only you can do an R0, you can do a surgery. For R G3, no surgery. So this is for G3. I think we answered Dr. Nagaraj's question that there is some role to resect the primary if there is a disease stable. Dr. Ilango, you can comment on this. Is there a role of liver debulking in this patient if you have non-resectable liver metastasis?
Functional and symptomatic liver metastasis, we can do liver debulking. You have to achieve close to 90% of cytoreduction. And the safest limit to which they have pushed is at least 2 contiguous segments with well vascularized tissues and a good biliary drainage. It should be contiguous.
So, but the limit of 90 or 70 is not defined. Maybe maximum possible debulking is what is target stage. Maybe something the concept which is used in neuroblastoma can be applied here. And maybe this is, yes, there is a role for cytoreduction in these patients, probably improves the survival. And finally, Dr. Ilango can just enlighten us in few minutes about the role of liver transplantation in these patients of medical entities. So how do you choose the patients? And
transplantation is probably the final option that they may have. They should have, it should be well differentiated. So you exclude all poorly differentiated tumors, they go undergo transplantation. You must demonstrate stability of the disease. Primary must be completely tackled. There's an age criteria. We stick to 55. It's quite a rare indication, but the results are very good. It has a 5-year survival rate close to 70-80%.
I think in the context of the neuroendocrine tumor, you have to look up to 10 years survival, maybe otherwise it will be very difficult to justify. Thank you. I think we have tried to cover most aspects. Thank you, Dr. Kapoor, for allowing this extra time. And thank you, everyone.
I think all the guests can be on the side. So we want to have a photograph of all the faculty and the delegates of who have come for JSF. So I request all of you to please come on the stage. So we'll just take 5 minutes for that. If you have any of your colleagues who is standing outside for a tea or a gossip outside, you can request him to join us. So please, I request everybody to come on the stage for a photograph of all the faculty and the delegates together. There is another announcement that all the Sanjay Gandhi PGI faculty who are here, they are requested to please collect outside the reception by 5:30 p.m. by 5 p.m. Okay, again an announcement for all the SGPJ alumni to please meet at the reception or stall number 1 at 5 o'clock, please. All the SGPJ alumni.
I would like to thank the moderator as well as the panelists for a very informative discussion on neuroendocrine tumors. Moving on, we would now like to start the next panel discussion on cystic pancreatic neoplasms, which will be moderated by Dr. Mohammad Ibrarullah, who is a renowned surgical gastroenterologist from Bhubaneswar. I would please like to welcome you, sir, and we shall continue with our discussion.
Pointer. Can we have the first slide? Sorry. Good afternoon, ladies and gentlemen. So let's start with this panel discussion on cystic pancreatic neoplasm. And now may I invite my co-panelists to come to the dais. Dr. Jashwan, Dr. Kailash Kurdia, Louis Rizzo Martinez, Dr. Vivek Mangla, Sarvari Pujari, Paresh Tukhani, and Swati Purohit Joshi. Okay, from there, fine. Do you have mic with you, Dr. Paresh? May I request my panelists to introduce themselves? Dr. Yaswan.
Dr. Jaswan, Government Stanley Medical College, Director and Professor, Institute of Surgical Gastroenterology.
Myself, Dr. Kailachan Kuradia, and I am working as an assistant professor in PGI Chandigarh in the Department of General Surgery.
I am from Uruguay, South America. I am full professor in the Republic University in Montevideo, Uruguay.
Dr. Vivek Mangla, Director G and HPV Surgical Oncology at Max Institute of Cancer Care, Max Hospital, Vaishali.
Dr. Sarvari Pujari from Department of Surgical Gastroenterology, KEM Hospital, Mumbai.
Dr. Paresh here is on the first row. Dr. Swati Purohit is not here. We have one radiologist and a scholar surgeon. Probably the incidence of cystic neoplasms of pancreas is in the range of 2.5 to 13.5%. And these are basically incidental detection on imaging studies done on asymptomatic population. That means these patients are not symptomatic for pancreatic lesions, but they were subjected to imaging for some other reason, and that is where these lesions were picked up. The cystic neoplasm per se accounts for 10 to 15% of all cystic lesions of the pancreas, and this in itself constitutes 1% of all pancreatic neoplasms. Basically, for today's presentation or today's discussion, we have chosen these three tumors: serous adenoma, mucinous cystic neoplasm or IPMN, and of course the pseudocyst. Because any discussion on the cyst of the pancreas is incomplete without discussing pseudocyst, because that per se constitutes 90% of the cystic lesions of the pancreas. So anytime you pick up a cyst, that has to be differentiated from pseudocyst before you proceed further. So that is why we need to discuss this
entity as well. The purpose of today's presentation or today's discussion is to sort out the conundrum of diagnosis of this lesion because of their rarity as well as their variety, and of course the management issue. Because some of the tumors or most of these tumors are slow growing and they can range from benign to low grade to high grade malignancy. Some tumors are to be left as such, some are to be resected and followed up, some are to be resected and not followed up at all, or there's no need for follow up. So that is why there is array of management issues that we need to discuss. So for this, we have basically chosen 4 or 5 prototype cases to take the discussion forward. The first patient is a 40-year-old female, had dyspepsia, underwent ultrasonography where the SOL was detected in the head of the pancreas. And the ultrasound report was a mixed echogenic lesion. So obviously, once there is SOL in the pancreas, the next thing is to do a CT scan. A CT scan was done. And this is how the CT looked like. So let's start with our radiologist friend, what he thinks about this lesion. How does he interpret this lesion in the head of pancreas?
And the margins of the lesion, particularly where there is arrow over there, it is like lobulated. It is not invading adjacent structures. The duodenum is displaced, however, not infiltrated. The IVC and the aorta are not involved. So, considering the incidentally detected lesion with uniform cyst and lobulated margins with the central calcification of first differential will be.
Yeah. Anything else? Would you like to exclude or think of?
Like other lesions of the pancreas, why they are not, why they are MC and the mucinous cystadenomas usually have a non-uniform cyst and they lack central calcification. And the margins are not lobulated, as in this case, they are smoother.
Yeah. Another point to add is the clinical picture. She is a young female, and this is a lesion in the head of pancreas, which is characteristic of cirrhosis adenoma. So what next? Let's start with our surgeon friend, Dr. Jaswant.
Since it's incidental, cirrhosis carcinoma, we can observe the patient, repeat the investigation, we only let keep up growth are saying the same size or not.
You mean just follow up and nothing else, or surveillance of this patient, that's all. Anyone would like to differ?
So, so there is no diagnostic dilemma of CT scan. So, and patient having dyspeptic symptoms. So, in though ultrasound, there is no mention about any gall stone. So, I would also like to see any stone disease, whether it is
Any other pathology? I mean, you think this is just an incidental finding, so does not require any further?
patient because patient have dyspeptic symptoms. So,
That's fine. I mean, evaluating her symptoms are a different issue. But as far as this tumor is concerned, you think there is nothing more needs to be done, or she has to be just kept on follow-up?
it can be kept on follow-up.
Professor, would you like to add something?
In this case, I think it's very important to confirm the diagnosis. Maybe when you put here biomarkers, it's not useful because the SIA in this type of tumor is very low. Because I think it's serous cystadenoma. And the serous cystadenoma, I think, is originally in the acinar cells, not in the epithelium of the ducts of the pancreas duct. So the possibility of the biomarkers, the SIA, is very low, the result. Secondly, I think is use endoscopy. By endoscopy, use with function with fine needle is useful because 3 reasons in this. The dosification of biomarker in the fluid of the cystic. Secondly, to see the cells, neoplastic cells or dysplasia. And third, the presence and the test of mucin. That is very important to difference serose to mucin.
Okay. Vivek, would you still I mean, continue with further further assessment of this cyst, or would you stop at that serous adenoma?
Once the imaging diagnosis is very clear, as the radiologist concurs very well, the patient is not much symptomatic, then we would just stop at this.
Does the size make you uncomfortable?
If it's clearly a serous cyst adenoma, not exactly.
No.
If
How
there
can
is
you say it is a clear cyst adenoma? Just on the basis of one CT scan finding, you would dismiss it as
when we
serous cyst
practically-
adenoma?
when we look at any other of the cystic neoplasm, these are very characteristic imaging findings. The difficult part is quite often it will not present like that. The imaging diagnosis sometimes may not be as clear as in this case. So that's where you would definitely push for an EUS and a needle biopsy.
So where would you like to?
Yes, in this
investigate?
case, there is no diagnostic dilemma. US is recommended in serous cystic neoplasms only if there is diagnostic dilemma or the cyst is rapidly increasing or if there is any doubt of solid component or this case, it is almost clear.
Okay, so no use of US or anything?
Maybe we can ask the patient to come for follow-up and stable at the end of 1 year, then follow-up.
I mean, my take on this would be, since this is quite a big lesion and in the head of the pancreas, young lady, so that makes me a little uncomfortable. I will not sit tight on it saying that this is serous adenoma, rather than I'll confirm that this is serous adenoma by doing further biochemical test markers or US or US guided, fluid aspiration and thing. Would you agree or differ with me?
Sir, if there is any doubt, then can go ahead with US and cytology. Clear-cut diagnosis.
Okay, Jashwant, what are the different types of serous adenoma that you know of?
Microcystic or macrocystic serous adenoma. Rarely we get serous adenoma cast, but it's very, very.
Yeah, treatment options we just now discussed, I suppose. So what are the, the present type, where does it fit in? Which type?
For me, is mean this for the size, is a benign. I know there is a benign tumor, but for me is we perform an pancreatectomy and duodenopancreatectomy, and duodenopancreatectomy with a Whipple child procedure.
Fine. I mean, in fact, there is a treatment option starts from not doing anything to enucleation to local resection to Whipple's pancreatic or duodenectomy. Would you want to comment on this enucleation or local resection of this, Vivek?
A big lesion for a local resection or an enucleation.
Yeah,
Like
unlikely to be feasible. Yeah. Fine.
Or enucleation, the weight.
I think just to summarize what we discussed, the different types of serous cystic neoplasm are polycystic, where you have more than 6 cysts for about 2 centimeters in diameter, and there is central fibrous scar that we saw here and calcification. Then there is a honeycomb variety where you find multiple sub-centimetric cysts, which appears as a solid mass on CT scan. And there is oligo or macrocystic, which might mimic a mucinous cyst adenoma because there is probably one or maybe just very few cysts. This is another lady who presented with this kind of cyst. This was at a very earlier stage when we thought anything in the pancreas has to be resected. So basically, we went ahead and did a pancreatic or duodenectomy, and this is what the cut open cyst looks like. It's probably the polycystic variety. You find little larger size cysts, not exactly microcystic, but these are probably 1 centimeter or around 2 centimeter size multiple cysts in the head of the pancreas. Usually, the serous cystic neoplasms are asymptomatic, and the symptoms are usually, if at all it is present, it is non-specific, or it can produce pressure symptoms when it is more than 4 centimeters. Malignancy is extremely rare. There are only less than 30 reported cases till 2014. And some would consider resection if the cyst size is more than 4 centimeters, or if it is a symptomatic cyst, or most importantly, when the diagnosis is not certain. And the surveillance protocol is it's a semi-annual or annual surveillance. Of course, once you have resected it, there is no requirement for any surveillance because these are obviously benign cysts once you have resected, and that's the end of the story. This is a second patient, 21-year-old female presented with vague dilating pain in the left upper quadrant, no anorexia, weight loss. She has history of surgery 2 years back. You can see this midline scar where the report said it was a cystogastrostomy. And this is the CT scan she was carrying from that date. This is a 2-year-old CT scan. When she came to me, she came with this. And this is what the lesion. So, Jashwant, what's your opinion on this whole, management or the treatment which we had undergone in the past?
Probably they were thought to us pseudocyst and done gastrostomy.
Yeah.
Consider the age. I would like to suspect a solid neoplasm of the pancreas. And second diagnosis, mesocystic neoplasm.
First diagnosis you said is?
Solid neoplasm of the pancreas.
Solid. Okay. Yes. Sir.
Sorry, I understand well because was performed in the first operation and cystogastrectomy. I am not understand because the no history of acute pancreatitis, no history of chronic pancreatitis, so no history of trauma. So what is this image and send this to procedure and make to do an cystogastrectomy? That is my first question. Second, the image for me it have an solid component is one, but I think that when the first surgery performed and the surgery, he take a biopsy of this or not. It's not clear the first operation, the first surgery for me, but now is okay.
Fine, I got your point.
After I know my opinion.
I got your point. The very fact is, it said that eyes don't see what mind does not know. Obviously the surgeon has done a cystogastrostomy because he is not aware of the existence of this particular kind of tumor. Because very first look, there is absolutely no doubt this is a cystic tumor and nothing else. That's what my impression was. The moment I saw it, I knew we are dealing with a case of a cystic tumor of the pancreas, not a pseudocyst. Yet this patient had a cystogastrostomy with this premise that this is possibly a pseudocyst. Clinically, professor has already alluded to that there is no history of pancreatitis, acute pancreatitis or chronic pancreatitis in the background for it to be called a pseudocyst. Radiologically, what do you think, like the point where you want to differentiate a pseudocyst from a pseudocyst tumor and from a cystic tumor?
The neural thickening on the inferior-medial aspect. So these are the points which will be like against the source.
Even with the history of pancreatitis in female, think twice before diagnosing the case of cirrhosis. So always rule out the cystic of the pancreas.
Yeah, this is the tail aspect and is the intrapancreatic lesion. So very classical, and is a young female, 20 and 21-year-old female. Of course, pancreatic tumors can also present with pancreatitis. That's another story. But the fact is there is no preceding history of pancreatitis in this patient. That itself is a strong point against this being a pseudocyst.
One more thing, sir. If you see the density of not there.
Yeah, this is what the cyst when we investigated her, this is how it looked like, non-contrast, and this is a contrast, and this is that earlier one. So, would you like to quickly comment on this? The septations there. You can clearly see the septi, and which is enhancing with contrast. This one. Right. So obviously, we went with the diagnosis of cystic neoplasm. And would you still do a US in this patient, or will you go ahead with surgery? Kailash?
Again, the radiological imaging of cystic neoplasm and all the symptoms. So we can go ahead with surgery without further
Yeah, US obviously is not going to add anything to our management plan in this patient because she's a young girl. She has a tumor in the tail of the pancreas, which is possibly a cystic neoplasm. So obviously the treatment here is resection, nothing else. So US will not make any substantial change in our management plan. So possibly you can go ahead with it. This is what we did. Jaswant, do you think any different management you would have done in this patient? Because we had to do a tail resection along with splenectomy with a margin here.
But malignancy only we should go get
Otherwise,
radical resection.
what would you have done? Same thing, yeah. Okay, if it is possible to preserve the spleen, you can, but here it is so closely associated or so closely applied to the splenic hilum that it was just impossible, to preserve the spleen here. So we had to do a resection with a 1 centimeter margin here in the pancreas. So can't call it a distal pancreatectomy. It is in fact a tail resection along with the tumor. Yes. That aspect we really did not consider. I can say that technically it was a little difficult because he had a cystogastrostomy, so we had difficulty in dissecting that plane. But whether would you do a revisional gastric surgery also for this patient, Vivek? What would be your? I mean, why we did not think so is because the tumor is already there for 2 years. It has not significantly increased in size. Septa was enhancing, but there was no solid component as you can see here. So this was possibly a benign mucinous cystic adenoma, not a malignant variety. That's the reason we did not think of anything else. Yes.
But I would add here is if you look at the first imaging,
yeah.
You just go back to that first imaging, the stomach is so far away. I think technically very difficult to do a cystogastrostomy.
But anyway,
technical ingenuity to do a cystogastrostomy. So this, what Dr. Sharma is saying, is very valid. Surgeon may have gone in with the intent of cystogastrostomy, but may not have done.
No, the operation note was written that it's a cystogastrostomy.
In this case, if you
Operative
find
note.
stomach adherent there, then you would just remove it and block with this rather than just take out the stomach wedge there as well. Whatever the biopsy, benign or mucinous cystic neoplasm, whatever it looks.
Okay.
If the stomach wall is densely adherent, then it, all of the
No, your point is well taken. You think this is a malignancy and this cirrhosis has been breached. I mean, at least the capsule has been breached and it has, yes. So there is a point to consider that.
there also this imaging, this tumor is and so just 99 was very but thinking of something short of surgery or giving some kind of neoadjuvant treatment, suspecting a malignancy. Suppose
Would you really suspect malignancy here? The cyst has been there in the same size for last 2 years and young lady, she is in perfect health and all that. So, and thankfully, retrospectively speaking, we can say we are right. This was a benign, in fact, mucinous adenoma. There was no malignant component seen here.
Normally, following these type of surgeries, because since it's not a mucous anastomosis, stomach will be separate, cyst will be separate after a couple of years.
Yeah, there are some additions, but we could, I mean, yeah. Fine, we have discussed all these points already. So, this was a 51-year-old lady, diabetic, incidentally detected cystic lesion on ultrasound. And this is how the ultrasound report read. Mild pancreatic atrophy, heterogeneous parenchyma with calcific foci, main pancreatic duct dilated, 4 to 4 millimeter. No intraductal calcific foci noted, thick walled cystic lesion with septations and internal debris noted at the pancreatic body region. So it's very obvious, like he's referring to acidosis. And then we did this CT scan. So what would be your interpretation, Jaswant, from this CT scan?
Quick, pseudocyst or tumor?
So we should always, from being female, should always rule out tumor.
Tumor. I think all the panelists would agree that this looks very much like a tumor. Yes. Radiologists have a different take on this.
The MRCP, we can see the dilated MPD.
US finding is reported that is maybe some worrisome because of IPM.
No, that is ultrasound report. I'll come to US report later and also the fluid analysis. No, previous one was ultrasound report. Okay. But I think the very first look at the MRCP, I would think, at least I'll be inclined to think that this is a cystic tumor, not a pseudocyst. Anybody in the audience would like to differ? Feel that this is a pseudocyst, not a tumor? Kindly raise your hands. Or if you agree, you think this is a pseudocyst?
That the only thing is that in this particular patient, I would definitely go ahead and evaluate before deciding what I'm going to do.
Exactly. I think you have a point there.
With one patient, even if there is no background history of acute pancreatitis, but there is some calcification reported on the.
There is background of chronic pancreatitis. I mean, that's fairly, yes, well understood.
This is one patient where I definitely before deciding on anything further on this patient, do a further evaluation and endoscopy.
Exactly. I mean, I take your point, but at least my take on this is again well demarcated cyst, as you mentioned, well demarcated, which is very unlikely, I mean, unusual in pseudocyst. You don't find such a well defined cyst, and that way again, this is an intrapancreatic location. So probably, I mean, looking at this, at least my impression was this is a cystic tumor, not a pseudocyst.
But when you see the Wilson duct, behind the tumor is dilated because it's by compression. But
You mean this dilated duct is because of the tumor compression rather than chronic pancreatitis?
the main duct in the first part is maybe with a small dilatation.
Yeah.
I open the door for acute for pancreatitis, for chronic pancreatitis.
No, you agree or you don't agree? You think this is
No, I opened the door. I opened the door for chronic pancreatitis.
okay, fine. Like we proceeded further, as was suggested, we did a endoscopic ultrasound, and this is what the report is again. Impression chronic pancreatitis with pancreatic cystic lesion at the body, probably pseudocyst, to rule out macrocystic SCN. So next obviously is fluid analysis, because again ultrasound US does not lead us anywhere. Yes.
Can I just make
Please.
to go back to the CT? So we need to see all the cuts, and I think MR.
This is MR.
If this is post pancreatitis, disconnected, there is a so we will need to see all the plates. I'm just saying that.
No, we are basically debating this is a pseudocyst, you think, or this is a cystic tumor? Sorry?
If it is at all related to pancreatitis, then that's not a patient who is clinically silent. Rare to have a patient who is sort of pancreatitis is silent and
Chronic
they get a
pancreatitis. I mean,
disconnected
this is
duct
not acute pancreatitis. That's all
disconnected.
referring to chronic pancreatitis. She's a
I'm-
diabetic lady.
I am referring to acute with disconnected duct.
Okay. Fine. And this is what the fluid analysis report again does not take us anywhere. CEA here is grossly elevated, cystic fluid, serum is normal. Amylase slightly elevated here, but by and large normal here. And CA99 again, just some elevation here. So what would you plan as a surgeon? Now you have completely investigated this patient. Would you still hold on, do a cystogastroscopy, do nothing, do a cystogastroscopy or resect it, presuming that this is a tumor?
Yes. It's curious for a chronic pseudocyst for a chronic pancreatitis. The amylase in cyst fluid
Yeah, this
is
is the
very low.
distorted finding. This should have been very high if it was a pseudocyst or a pancreatic true cyst or a tension cyst, as in chronic pancreatitis.
Usually
So this is
it's
very
higher.
unusual.
Usually it's higher by the communication between the pseudocyst with the system.
Okay, so I thought keeping all this in mind, so obviously, since that reports are very ambiguous, giving the benefit of doubt to the patient, we decided to resect this patient, resect this tumor. And this is what. So do you think a pancreatic preserving resection would have helped here or a median pancreatectomy? Vivek, quickly.
Once we are in doubt as to what exactly this fluid is not exactly corroborative. I believe somebody must have tried to look for mucin there as well. You can just do muc staining on the cell block or something. But then if it is not a pseudocyst, then I think a formal resection would be.
Yeah.
You know
No,
that this
what
fish
I'm
fluid
talking of
available
is
is not
clinic
elevated.
preserving. Clinic preserving or a pancreatectomy, a median pancreatectomy. Do you think that would have sufficed here?
There is a diagnostic dilemma here. I would just
That's one. And another thing is that very close to the
did you check for
pancreatic, portal vein. So that is one reason we decided in favor of a total distal pancreatectomy rather than a median resection. And this is what the histopathology is. It's not a tumor. And they said it's the inflammatory cyst, probably intrapancreatic cirrhosis of pancreas related to chronic pancreatitis. Any
Even if
comment
they
on this?
say pseudocyst, it is not always so. When 2% of cystic surface is enough to sustain the cyst, you have to take a millimeter cut before ruling out any true cyst. In mucinous cyst, you go once it increases in size, they go for atrophy, degeneration. Only 2% of cyst surface is enough to sustain the cyst. So with single biopsy, we cannot say.
No, this is a resection biopsy.
That's a biopsy. We have to do many cuts, not single cut. So it was done or not, we do not know.
Even this could be a false positive,
Yes.
false negative
Yes.
report for tumor.
Yes. Centimeter cut they have to do.
I would still not agree with
go
you.
there.
Because when the entire specimen is there with the pathologist, it's very unlikely that.
So no people don't do that actually.
Yeah.
You have to do centimeter by centimeter cut if you suspect. Because
Yes,
CA is
Professor,
raised,
quickly.
CA raised mucinous is neoplasm. Amylase is normal. Could have asked the pathologist to do more section.
Okay.
Comment on it. Now I open the door for the control and follow-up because all the evidence, clinical and use endoscopy and biology in the study of the fluid is the pseudocyst. The pseudocyst was evacuated totally by the use ultrasound. So maybe you can wait, control, and to see the evolution, and after that to proceed if consequence.
Right. Thank you, Professor. I think from there we proceed on to this case. Just one image, radiological imaging. Quickly, you can comment.
The large, what is smart? The case pattern and the calcification located at the septa with the papillary projection.
Yeah. What is most important part is here is that. Yes. So obviously this is a cystic neoplasm, but of malignant variety, cystic neoplasm malignant variety. If you look at these nodules here, projections and irregular wall. All right. So just to quickly summarize about MCN, this is a benign. This can range from being benign to low-grade malignancy to frankly malignant tumor. And this is histologically lined by mucin-secreting columnar epithelium. And presence of dense ovarian-like stroma is pathognomonic, which probably Dr. Yashwant was referring to. CT scan, these are usually thin-walled separate cysts, but these are the disturbing features, axial calcification or papillary projections or biliovascular invasions, which would point towards its malignant nature. Sorry. Management, usually there is again a difference in approach, but if it is a less than 4 centimeter in diameter and elderly patient, and there is no intramural nodule, so likely to be a benign cyst where you may possibly wait, but most of the people would go in favor of resections because they consider this to be a malignant or potentially malignant tumor. This is what the recommendation by various society also. This is American Gastroenterology Association, International Association of Pancreatology, and this is European group for management of cystic tumors. So where and the first two groups would, outright go for resection. Here they will give some criteria. If the tumor is meeting this criteria, then they would recommend resection. Battery has run out. This is the fourth patient, and there's a 58-year-old male, diabetic, painless progressive jaundice, gross weight loss, anorexia. Ultrasound shows IHBRD and dilated CBD and multiple cysts in the pancreas. This is how the ultrasound looks like. Nothing is there for imagination, it's very much there. And then a CT scan was done. Doctor, radiologist friend, can you? Sorry. Image went away from the computer. Anybody here to correct it? No. Screen has gone blank. I think power we disconnected, sir. The battery is run out. Can you restart it? Oh. Right. Yeah.
There was a parents wanted to observe operated.
No, there are some indications for surgery. Like if it's more than 4 centimeters, if it is symptomatic, then obviously this has to be operated, or when the diagnosis is in doubt. But I think now with the availability of good imaging techniques and US and all those, you can be reasonably be sure before surgery that you're dealing with SCN. And in that case, perhaps you can wait. I mean, that's what my take would be.
But sometimes you have a symptomatic patient which when may not be related to the tumor and may not happy after. So maybe these points.
I think, yeah, we can discuss that at the end in the audience round. And Dr. Joshi, back to you.
Side branches as well. The largest one is located in the head wing. And the image on the first one, upper left, it shows that the duodenum is pushed medially like a bulging papilla which can trigger.
This one.
Second row, that the coronary forming the largest in the side branch, like in the unstable.
Yeah, possibly an IPMN of mixed variety. And one more finding here is the CBD is also grossly dilated. You can see, and up to this mid CBD level, up to the head of the pancreas, it's proximally grossly dilated, and it's not traceable beyond that. And we did a side wing endoscopy. Initially, we thought this was a ampulla or the papilla, but it turned out that the papilla is, below that. This is the medial wall of the duodenum, which has been eroded by the tumor, and what was overlying it was very characteristic or the very classical finding, that plug of mucin over that tumor, which is very characteristic of IPMN. This is what the MR CT looked like. The duodenum is stretched out here. CBD is grossly dilated, and there are, there's multiple cysts involving pancreatic duct. Diagnosis-wise, this tumor was first identified by this gentleman, Osashi, And he gave a triad on ERCP, which can now be extrapolated to other imaging findings also, like what we have found in this patient, like a dilated pancreatic duct, bulging ampulla, and presence of mucin. At least all these three we could demonstrate in this patient by different technique, of course. One is by side-wing endoscopy, by CT scan. So this was obviously is a case of in IPMN, no doubt, and mixed type. So what treatment plan for this, Jatwan?
This in the head of the pancreas and jaundice there, Whipple's resection with the process section of the duct.
Kailash, would you agree with them?
Yes, sir. And I also explain the patient regarding patient may need a total pancreatectomy and regarding if it's a long-term complication also.
That's fine. Professor?
I agree, but this patient is not diabetic now, and secondary after the surgery, the diabetic is the complication.
Any difference of opinion, Dr. Vivek? And
I would do an EUS in this patient just to look at the pancreatic tail dilatation and be sure there is not a field change there. That is an important thing that is going to help
No,
you decide.
don't you think these are tumor involvement rather than dilatation, secondary dilatation to the tumor here in this region? I would think this is a diffuse involvement of the pancreas involving both main as well as side branches.
A lot would depend on, I would kind of base that decision looking at very carefully at the MRI images for the duct as well as doing an endoscopic ultrasound in this patient also to be sure that, especially considering the
What
fact
more finding would US give you other than dilated?
if I'm not looking any mural nodule grossly on the pancreatic duct, duct distally, and it's a smooth dilatation of the duct, not a multicystic kind of a dilatation of the duct, then I would kind of conserve the pancreatic tail in that. So that way, because if the same situation, if there was not so much of a cystic mass seen in the head, there you could probably have done whatever you felt like. But
How
then
much
this
time
patient
left?
looks like a head dominant disease with, you're not sure what's happening in the tail. That's my take on it.
Quickly, I think, I mean, to me, at least my take would be this was a candidate for total pancreatectomy, provided this is resectable. But unfortunately, this patient had duodenal involvement. You can see the duodenal erosion, complete duodenal involvement. And the CBD is also infiltrated in its entire length, I mean, the intrapancreatic length. So this was basically a locally resectable, unresectable tumor. In addition, he was in a very poor nutritional status with a serum albumin of 1.4. So we just could not do anything. We just offered him a palliation for his jaundice in terms of endoscopic stenting and tried to keep him in the follow-up, which did not turn up because this was advanced disease. Maybe he did not live long enough to come back to us. Okay, just quickly. This is a 76-year-old male doctor. He's in fact a surgeon. He's in regular follow-up. He's a non-diabetic, non-dyspeptic, no anorexia. Had a cystic lesion on the head of the pancreas on ultrasonography. So obviously next MRCP was done. And this is what the finding is. Dr. Joshi, quickly, now that time is running out. So really, would you agree that this is the upfront IPMN side branch variety? Yes. Sure. Possibly this is the case of branch duct IPMN. So what do you advise the surgeon? I mean, the patient who happens to be a surgeon here, Dr. Jaswant? He's very much worried. Once I told him that this is a tumor, IPMN, he read up IPMN that this could be malignant. So he is very much worried. What exactly would be your advice to
really
him?
characterize this over endoscopy ultrasound.
Yeah. So just briefly about this particular entity. This entity was first described in 1982, characterized by focal dilatation of the pancreatic duct lined by mucin-secreting tall columnar epithelium cells with papillary projections. Main duct, it could be main duct variety where the main duct could be more than 5 millimeter in diameter, or a branch duct variety.
communicating with the MPD, or this could be a mixed variety where both main as well as branch ducts are involved. This is what is important, that this is a potentially malignant tumor. In fact, 18% may have invasive carcinoma with the branch duct, and that with the main duct is about 43%. So when you advise this surgeon, like how do you try to, advise him, Kailash?
Sir, after looking the imaging and see is there any worrisome or high risk feature.
So what are the worrisome features?
So
Yeah.
worrisome feature is if the main pancreatic is 5 to 9 millimeter is dilated, and if there is a mural nodule which is less than 5 mm, and the patient having history of acute pancreatitis, and so these are the worrisome feature, or maybe elevated CA19-9. So if they're having a worrisome feature, then we further with the endoscopic ultrasound. And if the patient has high risk feature, then we directly go for
surgery. But what about this patient? Like,
so in this patient, the MR imaging is not showing anything. So we
it's probably less than 3 centimeter size and not showing any mural nodule or anything. And in fact, this has remained static over a period of 2 years. The patient, the surgeon is still under my follow-up. And he has been to TMH, also got an advice from there that he has to be followed up. That's all he's doing. He hasn't, he has been doing reasonably well without any further deterioration in the symptoms, nor in the size of the nature of the test. So this is the summary of how you manage IPMN. This is for the branch duct variety. This is what we have already discussed. High-risk stigmata, they go for surgery. No worrisome features, then they go by the cyst size. More than 3 centimeter, close surveillance required. Worrisome features, you do a US, definite features on US, then you go for surgery. Otherwise, again, follow up. And this is how you follow up this patient or keep them under surveillance when surgery is not done. And for main duct IPMN, these are the criteria. Surgery is strongly recommended when the MPD is more than 1 centimeter, there is jaundice, there are mural nodules, or, like. This is the follow-up protocol. Of course, this is very standardized, so we will not discuss that. Just last patient, I think I'll just take 2 minutes because this is a very interesting and important patient, and that we'll finish with that. This is a 43-year-old male presented with retention vomiting. He was a known alcoholic. Endoscopy showed gastric residue, D1, D2 dilated, obstruction at the level of D2. And this is what the CT scan is. I think quickly I'll read it out for you. You can see the stomach and duodenum are grossly dilated, and there is a abrupt cutoff here. And this is the head of pancreas. You find a cystic lesion here. And as you come down, it's more defined, getting more defined in the uncinate process region. This is where it is, and the duodenum is stopping here. I mean, this is the site of obstruction. So what's the opinion of the panelists on this CT scan? Share very quickly. Vivek?
Not really sure what's happening. I would take the help of an endoscopic ultrasound, definitely.
Exactly. I think that is what was done in this patient. And this is what the US finding is: atrophic pancreas, cyst in the uncinate process, irregular wall. That's again that little odd point. Then that is the amylase level, as Professor mentioned, is a very high amylase level, pointing towards it being acidocyst in nature. And the CA99 was within borderline. I mean, just mildly elevated, or you can say almost normal. So, do you think it could still be malignant? Cystic tumor or a cystic degeneration in a malignant tumor? Jeffron?
Very rare, actually. Rarely the tumors can come.
No, what I'm trying to ask you that would you evaluate him further, or maybe on table also evaluate him, or you just go for a bypass of surgery and that should be the end of his problem?
Maybe on table I will evaluate.
Yeah, that's exactly what we did. This is what the operative finding is. Pancreas is firm to hard, obstruction at D3, no other abnormality. We did a transduodenal frozen section biopsy, and that excluded malignancy. I mean, that was normal, no evidence of malignancy. So gastrojejunectomy was done, and finally the patient made an uneventful recovery. So this was a case of basically chronic
alcoholic pancreatitis with duodenal obstruction by a pseudocyst, which mimic a tumor. So I think let's go to audience round if there is no other discussions from the panelists.
I agree with the behavior, surgical behavior in this case, because the problem of the patient is the gripper. Is gripper aortomesenteric gripper. Is the stenosis in the third duodenum, and the third in the third section duodenum, in the third part of duodenum. So the this procedure resolved the problem of the patient. That is very important because the solution of the pancreatic, the chronic pancreatitis in this patient is very, very difficult.
All right. So any questions from the audience or any points the audience would want to raise?
I think one treatment option in cases with indeterminate cystic lesion of the pancreas is we can do the cyst wall biopsy intraoperatively and frozen, then we can decide whether it is pseudocyst or cystic lesion, cystic tumor.
That's fine. So anything else? Yeah, Nagaran.
So there are, so as you started, there are many patients, elderly. One thing I wanted to clarify in the panelists is that these tests, leave alone serous tests, they are pre-malignant and not malignant. And the reason I'm saying this is so when you discuss with the patient, it's very different to say this is pre-malignant and that there is a malignancy. There is some confusion amongst us. So I think you just need that clarification that malignancy is seen when you have a solid nodule and maybe a focal thickening, but the rest are pre-malignant. That's very important for the patient to realize. They may choose not to do it.
No, once you say pre-malignant, then obviously this becomes an indication for surgery.
Not really. If I'm 82 or 85 with multiple comorbidities, I may choose not to because it may be a Whipple's at that. So I don't know what.
I think that's a very valid point. We would, when we are looking at these cysts, we would also be looking at what age this patient is, what patient symptoms are. In a younger patient with the same lesion, probably your threshold for surgery may be lower. But a patient with significant comorbidities and the elderly age group, as Dr. Nagral said, the answer probably lies somewhere in between in being selective as to what to do in a younger patient. Probably the indication for surgery will be a little more liberal in a younger patient for surgery. In an older patient, you will be like a little skeptical about kind of, you just observe this patient, it's move. The answer probably lies somewhere in between that yes, this is a subset of patients where it would always be gray areas and you would opt differently depending on the age
Just
of the patient.
one more minute.
Yeah. Sorry, one more?
One more thing, though the literature is not much, but now there is a therapy is also for cystic tumor and have comorbidity and high risk. Maybe endoscopic guided ablative therapy can be.
True. I mean, just before I conclude, I think I just wanted to highlight that a lot of advances have been done on the US front in the evaluation of the cysts, and these are some of those, where a genetic study or the DNA study, all those can be done. You can take a through needle, you can take biopsy as well as then there is confocal, endoscopic, endomicroscopic. All these are very significant as far as available. If it is available, then certainly that will help you to come to a conclusion about the nature of the cyst, whether we are dealing with a benign cyst or a malignant cyst. So that's all. And I think this is a summary of the cirrhosis, the pancreatic cystic neoplasm. And for the postgraduate students who are present or who will be interested, these are some important studies they should refer to know more about this entity. Thank you very much.
More thing. During surgery, in case of cirrhosis of pancreas, normally it will be adherent to the surrounding structure. It will be separate actually.
I would like to thank the moderator and the panelists for such an extensive discussion. Before we disband for tea, I would request everyone inside the auditorium to please download the app called Kahoot, K-A-H-O-O-T. It will be used for the quiz which will be held later today. We shall disband for tea and I shall see you soon. by 4:20. Sir, it's already 4:15. So 4:25, I hope you guys will come back, all of you. Thank you. Please kindly be punctual. Thank you. I'd like to welcome you all back for the next discussion on vascular resections and pancreaduodenectomy. I would like to invite the chairperson, Dr. Rajesh Bhojwani, Senior Consultant and Director of GI Surgery at SIDS SDM at Jaipur. Along with that, we will be joined online by Dr. Kalyasaran from Chipmer, Pondicherry, Associate Professor in the Department of Surgical Gastroenterology. Along with that, Dr. Vikas Gupta, Professor in the Department of Surgical Gastroenterology from PGI Chandigarh. I welcome you all.
Very good evening. And a very good evening, Professor Zadomsky and my fellow chairpersons, Professor Kalarasan and Dr. Vikas Gupta from Chandigarh. We are now reaching one of the most interesting and awaited sessions on vascular resection in pancreatic duodenectomy. And it's indeed a pleasure to introduce Dr. Nicholas J. Zadomsky, who specializes in general surgery for IU Health Physicians Surgical Oncology. Dr. Zadomsky earned his medical degree from Medical College of Ohio and returned there for an internship and residency. He also completed a fellowship at Mayo Clinic, Rochester, Minnesota, and Indiana University Medical Center. Professor Zadomsky, please.
Good afternoon. I appreciate the privilege of presenting our work at the second Jaipur Surgical Festival. I'll look forward to the chance to visit Jaipur in person. I've been charged with speaking to vascular resection in pancreatoduodenectomy, and I'd like to focus on portal vein thrombosis after venous reconstruction during pancreatectomy, highlighting the timing and risks. This is work that was performed by my colleague, Dr. Alexandra Roche, our youngest faculty member here at IU Department of Surgery. The close anatomic relationship between the SMV and portal vein, as well as the posterior neck of the pancreas, venous involvement by tumor or inflammatory adhesions happens commonly. Portal vein involvement was historically considered a sign of advanced and unresectable disease. In 1984, Fortner described regional pancreatectomy with en-bloc venous resection, regardless of vascular involvement. This procedure was soon abandoned due to the high mortality and morbidity, with no change in survival benefit. In the 1980s, 1990s, and 2000s, the concept of portal vein reconstruction after pancreatectomy was refined from better defining the indications for resection with Ishikawa classification to confirming that venous resection was safe. This scope of work led to the expert consensus statement from Evans and colleagues in 2009 promoting venous resection as a standard of care in order to achieve negative resection margins. The current indications for portal vein resection in pancreatectomy can be divided into 4 cardinal categories. Venous resection is most commonly planned preoperatively based on cross-sectional imaging, but in a minority of patients, it can be decided intraoperatively either after tumor involvement is detected or venous injury. Venous resection can also be indicated in benign pathology with significant inflammation, such as chronic pancreatitis, cyst or pseudocyst, or for malignancy as well defined here by the 2020 NCCN guidelines for borderline resectable pancreas cancer. Although venous resection during pancreatectomy is safe in experienced hands, it is still associated with many severe potential complications. The leading complication, venous thrombosis, has been described in up to 1/3 of patients after venous resection and reconstruction. Although most patients remain asymptomatic in the acute or chronic phase, portal vein thrombosis may be associated with mesenteric congestion, bowel ischemia, or may lead to chronic portal hypertension and liver failure. The risk of SMV portal vein thrombosis after resection remains unclear. Our goal was to describe the prevalence and risk factors of venous thrombosis. Between 2007 and 2019, all consecutive patients undergoing portal vein resection during pancreatectomy at a single academic institution were included in this study. The primary outcome was prevalence of postoperative thrombosis. Secondary outcomes were risk factors associated with development of thrombosis. Standard statistical analysis were performed. Surgical procedures were all performed with curative intent by a team of surgeons with significant pancreatic experience. 5 types of venous reconstruction were routinely performed: venorrhea, patch repair, primary end-to-end anastomosis, and interposition graft either with autologous vein or prosthetic vein graft. 2,700 patients undergoing pancreatectomy during this time period, 220 underwent portal vein thrombosis. Sex ratio was close to 1. A mean age of the population was 65 years, and median follow-up was 175 days. The primary indication for pancreatectomy was malignancy in 92% and also included pancreatoduodenectomy in 82%, distal pancreatectomy in 7%, or total pancreatectomy in 11%. Among 220 patients with vascular resection and reconstruction, 36 or 16% developed thrombosis postoperatively at a median of 15 days. 6% of patients with postoperative SMV thrombosis occurred within the first postoperative week. The operative time for this entire cohort was 381 minutes, estimated blood loss 800 mLs, and clamp time for venous reconstruction was 21 minutes with a range of 5 to 90 minutes. The mortality of the cohort was 6.8%, morbidity 47.3%. Median hospital length of stay was 9 days. 4 types of venous reconstruction were used: venorrhea in 18%, primary end-to-end anastomosis in 65%, 14% had autologous vein, internal jugular vein in 29%, and splenic vein in 2%. Remaining patients received prosthetic grafts, either cadaveric vein, bovine carotid artery, or PTFE or Gore-Tex graft in the last. The median clamp time was longer for grafts versus venorrhea or primary anastomosis. Significant difference was found in the rate of thrombosis according to the venous reconstruction technique, ranging from 13% after venorrhea or end-to-end anastomosis to 23% with autologous vein and 83% with synthetic graft. As shown on this Kaplan-Meier curve, the patency rate of the portal vein reconstruction was excellent overall, 93% at 1 month and 89% at 3 months. When patency rates were compared based on reconstruction technique, not surprisingly, prosthetic graft reconstruction was associated with significantly worse patency. Portal vein thrombosis was associated with increased 30-day mortality, overall complication, and length of stay, though none of these variables reached statistical significance by multivariable analysis. Multivariate analysis to evaluate independent predictors of thrombosis. Patients with thrombosis did not differ significantly from those without in terms of demographic, premorbidity, comorbidities, and interestingly, neoadjuvant therapy, clamp time, pathologic vein invasion, resection margin status, postoperative pancreatic fistula, or type of anticoagulation were not associated with increased risk of thrombosis. The one positive finding was that patients who developed postoperative sepsis had a 4.5 times greater risk of developing portal vein thrombosis. In summary, this series of 220 pancreatectomies with portal vein resection, 16% developed thrombosis postoperatively at a median time of 15 days. Reconstruction with interposition graft carried a higher risk for thrombosis, and postoperative sepsis was an independent risk factor for developing portal vein thrombosis. These data suggest that portal vein thrombosis after resection is common. Primary repair may be attempted if possible technically. The use of interposition graft should be weighed against the higher risk of thrombosis. As the prevalence of portal vein thrombosis is significantly higher in those with postoperative sepsis, low threshold for treatment and high threshold for suspicion should be kept even in asymptomatic patients. I'd like to thank you again for the opportunity to present these data. I will invite anyone in the audience to help visit Indianapolis, Indiana. If you are in the neighborhood, please give me a call. We'd be happy to host you. I'll highlight the fact that Dr. Roche's data are published online in the Journal of Gastrointestinal Surgery, if you'd like a closer look. And here's Dr. Alexandra Roche. Thank you.
Is professor available for answering? Okay. Can I have Dr. Kalarasan and Dr. Vikas? Okay, they are there.
Yeah.
Any comments, please? Dr. Kalarasan and Dr.
Yeah. Yes, sir. Yeah, thank you for the permitting me to participate online. And I think Professor Zaromsky is there for comments or no?
No, he's not available.
Okay.
It was a recorded video.
Yeah. So I think the main issue which has been highlighted is the risk of thrombosis more with prosthetic grafts. And also he has highlighted that up to 30% can be asymptomatic. So the point to be discussed is, so what should be the strategy in the immediate post-operative period when these patients, like especially when we use prosthetic graft, what should be the strategy with respect to the post-operative imaging to diagnose this portal vein thrombosis early? Because when we initiate the therapy early, the success rate is higher compared to a delayed initiation of therapy. I think that's one thing which can be discussed.
Maybe after Dr. Vikas's comment, we can invite opinions from the house as to whether they are actually using anti-platelets after a venous reconstruction, after pancreas.
Yeah. Thank you, Dr. Rajesh. And in fact, what I feel, what our experience is that prosthetic grafts may immediately there is a risk of thrombosis, but long-term patency of prosthetic graft is much better compared to end-to-end anastomosis, because when we are doing end-to-end anastomosis, there are a lot of shear forces and traction on the vein, which predisposes to some microscopic tissue trauma and thrombosis. However, delayed thrombosis is not a very problematic situation because it's a slow process. By that time, collaterals do develop. And as a matter of fact, whenever prosthetic graft is used, anticoagulation has to be given. We always prefer to use maybe unfractionated or low molecular weight heparin perioperatively when prosthetic graft is. Otherwise, when we do end-to-end anastomosis, we don't use any anticoagulation. Only maybe antiplatelets we give for a short period of time, maybe 6 weeks or so.
I think one of the important messages from his lecture was that if the thrombosis comes, most of them will present within the first 15 days. And therefore, one has to be careful in the first 2 weeks, and there should be some kind of screening modality on table on the unit to screen those patients and then take care of these, and then prevent sepsis also, because that predisposes to graft thrombosis. Having said that, I think there are now many other authors and many other units which are working on various other types of grafts, and particularly the peritoneal grafts, which can be which are made available from the patient there itself, and vein grafts from elsewhere. And they have, I think, from Heidelberg, they have published a long series of more than 400 patients, wherein they have published results of various types of grafts. But I think maybe let's invite opinion from the house. Most people would prefer a venous reconstruction rather than a prosthetic graft when involved. However, in Indian settings, I'm not sure as to how many surgeons are getting to operate upon patients post-knee as well. Can we have some?
Can I make a comment?
Yeah, sure, please.
Yeah, in fact, doing for a venous reconstruction, doing end-to-end anastomosis is more convenient and more easy. And secondly, doing end-to-end anastomosis, your clamp time will be maybe around close to 10 or 12 to 13 minutes, not more than that. And however, when we are doing a prosthetic graft, we need to fashion 2 anastomosis. It takes a bit longer. And by the time you end up anastomosis, you see a lot of bowel congestion is there. and which takes its own time. And patients, usually these patients where prosthetic grafts is, continue to have persistent acidosis, maybe for a prolonged period of time, maybe for 12 hours or 14 hours perioperatively.
So do you tend to routinely clamp the SMA before you
No, we don't tend to declamp the SMA, but we do clamping of SMA if we anticipate that maybe this reconstruction is going to take beyond 30 minutes.
And just one more comment is, if you expect the venous reconstruction to be much more complicated, the clamp time is going to be more. One of the option which rarely will be useful is a temporary mesoportal mesocaval shunt. So you have an interposition between the SMB and the vena cava till the time the reconstruction is completed. So that's one way of preventing bowel congestion in complicated venous resection and reconstruction.
Plan outline instruction based on the preoperative CT scan. Each preoperative biliary drainage because high bilirubin level can have potential problems in the prostate when you have prolonged solvent.
Yeah, but most surgeons would not, because it does not take more than 20 minutes in a planned resection. It does not take more than 20 minutes, and this is well tolerated usually. Maybe we can have opinion from Dr. Kalerasan, Dr. Because do you do a routine preoperative biliary drainage in these patients where you're contemplating venous resection?
Particularly if the bilirubin is beyond 15 or beyond 10 or 15 or so, I prefer to do biliary drainage. If bilirubin is something like 5 or 7, then I don't think biliary drainage is required, because
is it
clamping
intended at venous reconstruction issues?
No, what I feel is, clamping portal vein in the setting of a cholestatic liver causes more of hepatocyte damage compared to doing clamping in patients without cholestasis. But I don't have any literature proof on that. There is no data available on this aspect, but this is my practice, what I follow.
Dr. Kale?
So I think the indications for pre-op drainage does not differ just because we are going to do a venous resection reconstruction. So the indications remain same. The standard indications, there are no specific, like we don't drain just because we are going to do a.
So I think most surgeons would not drain just with that intention. The indications might come otherwise and might coincide, but not with that intention perhaps. That's one. And secondly, there's now enough data which tells you that if it is a well-planned venous reconstruction, preoperative, it has much better outcome than one that gets decided on.
And another point which I want to highlight is regarding the ligation versus reconstruction of the splenic vein. So there is a lot of debate on that, but I don't know what is your practice, but in my practice, most of the time we usually prefer to ligate a splenic vein if we are not getting adequate length. If it's a short segment resection, maybe 1.52 centimeter resection, then end to end can be done easily. If it's beyond maybe 2.53 centimeter, then splenic vein, we usually prefer to ligate splenic vein and then do end-to-end anastomosis. But there are many groups who prefer to do anastomosis with a splenic vein if they are not getting the length, or they will, because at times doing a straight anastomosis with splenic vein in situ, a long segment is resected, then it can cause some kinking of the SMV. So that to avoid that, splenic vein has to be ligated sometimes. And there are many groups who feel that splenic vein should be drained routinely.
You were talking, yeah. Yes, last question, please. Sorry, because just a quick comment on that. I think it is important to take a look at IMV also preoperatively.
Yeah.
That gives you a good route.
Yeah. I think either one of the three veins, IMV, left gastric, or splenic vein should be preserved.
Yes, I agree.
Yeah, I agree.
Last question, please.
Thank you. Even for a short segment resection, if it is lying within the region of the splenic vein attachment, I usually detach them. It gives us a better length, less tension as well.
Yes.
The other thing is that renal vein is really available, so it should not take much time. In an end-to-end anastomosis, it is good to mark. A lot of times, in a complex situation like this, a small twist in the vein in an end-to-end anastomosis with an interposition graft will thrombose later.
Yeah.
But if it is a late one, we have not faced any problems. And we routinely use aspirin, and we routinely, even for regular reconstructions, small reconstructions also, we clamp the SMA because of the bowel congestion. This has helped us avoid the pancreatic.
Yeah, I think that's a very valid and good comment. The portal vein is very forgiving. And once you are
Yeah.
through the first 2-3 weeks, I think you can stay relaxed. Thank you very much.
Thank you. Thank you very much. Yeah.
Thank you.
Thank you very much. Thank you. Thank you, Vikas and Kalarasan.
Thank you, sir. Thank you so
Everyone
much.
is wondering why I am here. So I am here to introduce the next session. First, I would like to invite the chairpersons, Dr. Lalit Mohan Sharma, one of the senior medical oncologists with us here at Mahatma Gandhi Hospital, and Dr. Naveen Gupta, who's a clinical hematologist with us. And while they are taking up their seats, and I would request them to formally introduce the speaker, but I would give an informal introduction of the speaker. Dr. Vivek Roy is my batchmate from MBBS from AIMS in early 1970s. He is a clinical hematologist. You must be wondering why he is here in this program. I can recollect when I was doing my MS, he was doing his MD. And before that, he was the topper in surgery. So I was very worried that one seat of surgery has already gone. But fortunately for me and fortunately for him, he decided to go for medicine. So when we were preparing for the final MS exam, my most close friends were actually medicine residents. So I used to have breakfast, lunch, and dinner with them. And one day they were talking about hepatosplenomegaly. So I just overheard some discussion. And lo and behold, my long case in the exam is hepatosplenomegaly. So that is why I am here. And that is why I thought I will informally introduce him, Dr. Lalit and Dr. Naveen.
Thank you, sir. So I think the majority of the introduction is being taken care of by Kapoor, sir. Dr. Vivek Roy is a hematologist and oncologist with more than 25 years of clinical and research experience in hematological malignancies and stem cell transplantation. His areas of interest include bone marrow transplantation, multiple myeloma, amyloidosis, and hematological malignancies. He's a senior consultant at Mayo Clinic in Jacksonville, Florida. It's a pleasure to have you, sir, with us, Dr. Vivek Roy.
Students who are participating online, that is why I always tell students that don't treat surgery only, read the ancillary subject.
Well, thank you, Vinay, for this very nice setup. I almost feel trapped in the middle of this eminent gathering of surgeons. But without any question, I'm really thankful for your invitation and for the invitation from the organizers to give me this opportunity and honor to speak to this eminent collection of surgeons. I don't have any financial disclosures. My only disclosure is that I'm a hematologist. You can see that lonely red cell there in the middle of all these surgeons. I'm not going to talk too much about hematology. What I do want to do, how do I advance? Here. So my goals really are to share some perspectives on splenectomy as a hematologist, and basically focusing on the evolving role of splenectomy in contemporary practice, and probably focus more on the health consequences of splenectomy. There is some new data that is emerging that I want to highlight. So talking about common indications for splenectomy, these indications that I have written on this slide are certainly not comprehensive, and they are not meant to be. There are only 2 points I want to make. One is that about 70% of these splenectomies that are done in an elective setting, non-trauma elective splenectomies, are for a hematology indication. So it is helpful for the surgeons to be familiar with the hematologic conditions. And the second point I want to make is that for a lot of these conditions, our need for splenectomy or our utilization for splenectomy is actually going down. And those are the down arrows that I have put there. And the reason for that is that splenectomy rarely cures the underlying disease. The goal of splenectomy is to interrupt the pathobiology of the disease with the idea that it will alleviate the symptoms, it can be helpful in diagnosis, and sometimes we use it as a preemptive measure. For example, splenectomy in a myelofibrosis patient before we take them to bone marrow transplant. And obviously, splenectomy should always be considered in the context of what other treatments are available. And since the field, both surgical and medical fields, are constantly evolving, the role of splenectomy is bound to change over time. So I want to share with you 3 clinical cases and to highlight some points. And hopefully I'll be able to give you a few clinical pearls, or call it teaching points, that can help you take better care of your patient. The first one is a 38-year-old woman who presented with severe thrombocytopenia during workup for fatigue. She had otherwise no medical history, and a clinical diagnosis of ITP was made. She was treated appropriately with corticosteroids, responded, and the steroids were tapered. But she relapsed 2 years later. So what are the options now? And as you all know, ITP is immune-mediated destruction of platelets. We are fortunate now to have many different potential treatment options. And the 2011 guidelines of American Society of Hematology had recommended splenectomy as the preferred second-line therapy. But that is not the case anymore. The 2021 guidelines actually put splenectomy much lower down. And at each step of the decision points, there are multiple options that can be equally valid. So even in the 10, 11-year time frame, the indication or the timing of that has changed. As a result, in contemporary practice, splenectomy is often delayed for second or even third line, but the overall use remains the same. About 25% of the patients with ITP will end up needing a splenectomy at some point. And it is safe despite thrombocytopenia, and I'll show you some data. But the point I want to emphasize also here is about 3 to 5% risk of thrombotic complications, even though the platelets are low. And here are some studies that we did in Mayo Clinic, and I'll not go into details because of lack of time. But the red line is the splenectomy, the other blue line is the other treatments. And both at second line and at third line, you can see it can provide durable control of the condition. So I want to spend a few minutes on preparing for surgery for patients with ITP, often have very low platelets, and they are at risk for infections later on. So a very, very important point is to vaccinate these patients against the capsulated organisms, particularly pneumococcus, and we'll come back to that in a minute. Question often comes up when I talk to my surgical colleagues is, what is a safe platelet count to do splenectomy? And there is not a single answer. There is a distinction between ideal and what is achievable. You may want a platelet count of an arbitrary number of, say, 50,000, but that may not be achievable. The patient's condition is so severe that you just can't get 50,000 platelets. So a dialogue between the hematologist and the surgeon as to what is doable is really important. Various strategies can be used to temporarily raise platelet counts, whether it be platelet transfusion. There used to be a dogma that patients with ITP should not get platelet transfusions. That is not true, and there is absolutely no contraindication to them getting a platelet transfusion if necessary. Other strategies, IVIG, steroids, the thrombopoietin mimetics can be used. But to be honest, they are not always effective, and sometimes we are forced to take the patient to surgery, even with less than ideal platelet count. What we have found in our practice in Mayo is transfusing platelets during the surgery. The idea is, because the half-life is very short, if you transfuse platelets while the surgeon is doing their procedure, more of them will be utilized for hemostatic purposes. and you can achieve a temporary hemostasis till the spleen is out, and then the platelet counts tend to increase. So I consider this as another sort of clinical pearls or something to keep in mind, a trick up your sleeve, whatever you want to call it, in this condition. I will skip this slide because hopefully COVID-19 won't be with us for too long. So coming back to the question of is splenectomy safe in ITP, probably the best data comes from this study published about 3 years ago, more than 100,000 patients who had splenectomy. And I know you cannot read this slide, so I'll blow up the relevant part. The first column is the ITP patient, and the last column is the second column is the non-ITP patient, and this is the mortality. And the ITP mortality was 0.5%, non-ITP patients 2.2%. So it is at least as safe and maybe even safer than patients who are undergoing splenectomy for other conditions. So case vignette number 2. This is a patient who is a 64-year-old man who was evaluated for kidney transplant. And during his initial consultation, the physician noticed he had a mass in the right upper quadrant with the left upper quadrant with clinical characteristics of splenomegaly. And to cut a long story short, he was noted to have a very enlarged spleen. As they were evaluating it, it was detected that there are some clonal B cells in peripheral blood circulation. Question is, what is the next step? So this patient most likely has a hematologic condition. We don't know what. It needs to be confirmed for both diagnosis and treatment planning. And splenectomy was performed both as a diagnostic, as a next diagnostic step. And what we found was he had hairy cell leukemia. It is a rare type of leukemia, and the cells can involve bone marrow, but they tend to congregate in the spleen. And in these patients, splenectomy can be not curative, but can treat the underlying cytopenias, sometimes for extended period of time. So this is an example where splenectomy can be for potentially curative. So the clinical pearl or the point I want to make here is just having a clonal B cell in circulation does not necessarily give you the diagnosis, because this is a very common condition in the general population. 2 to 3% of individuals above the age of 60 have clonal B cells if you look hard enough. So just having that does not tell you anything. You have to find further corroborative evidence to make the diagnosis. All right, let's move on to the third case. This is a gentleman that was referred to me for stem cell transplant for myelofibrosis. He had a huge spleen, which is not uncommon in myelofibrosis. He had a fully matched sibling donor available. The question came up whether anything needs to be done for the massive splenomegaly, and if so, what can be done? So why would you want to do something for the splenomegaly? The main point here is that it can cause not only a lot of symptoms and complications, it can delay and graft. So we don't want to have the spleen very large going into transplant whenever possible. The flip side is the spleen can be the site of hematopoiesis. So just removing it is not the answer unless you have something else you can do to address the lack of adequate hematopoiesis. So this is Mayo Clinic experience, and 2 points I want to highlight. One is the high mortality that can be seen in these patients because of multiple potential complications that can happen. So splenectomy is not simple and straightforward in patients with myelofibrosis. And point number 2 is the improvement in thrombocytopenia in our series was 0. So sometimes there is a tendency to remove the spleen in these patients in the hope that the platelet count will then improve. But at least in this series, we did not achieve that goal in any patient. So something to keep in mind that thrombocytopenia alone should rarely, if ever, be an indication to do splenectomy in this situation.
So what about splenectomy before the stem cell transplant? Stem cell transplant is the only curative modality for myelofibrosis. Splenomegaly can lead to delay and engraftment, but doing a splenectomy is risky. And in the end, whether to do it or not remains controversial. There are no randomized studies, variable results from single center studies, and it is not clear if there is an overall benefit. Different centers tend to individualize the decision. Okay, moving on about the surgical risk, I will not spend any time. You guys know more about it than I do. So what about other potential complications after the transplant? The most important one I want to highlight is the infection risk. Spleen is a major immune organ, especially in children, and principal site of removal of opsonized bacteria. And something to keep in mind is these are the bacteria that are less susceptible to T-cell mediated immunity. So if you remove the spleen, the person becomes particularly sensitive or susceptible to those infections. The risk of life-threatening sepsis is 2 to 5 times the normal population. Some studies have shown that the risk is highest in children and then tend to get less, but it never reaches the baseline population. There is always a higher risk. And not just the encapsulated bacteria, but also in the Indian context, in particular, the risk of malaria or serious malaria. So what can be done about it? Vaccination, vaccination, vaccination. All patients with splenectomy should have vaccination 3 to 4 weeks at least ahead of time if possible. I know sometimes that is not possible. In that case, do the vaccination as soon as you can after the procedure. There is strong rationale for these patients to receive antibiotics prophylactically lifelong for at least 10 years. Patient awareness, and I think I should add there, the physician awareness is very important. It is reasonable to give them a medical bracelet or a card or something that they can carry with them. So if they are incapacitated, the treating team can find out if their patient is splenectomy. I tell my patients, consider fever as a medical emergency, seek medical intervention, help indicate or advise immediately. A very important clinical point to take care of these patients. Other long-term effects. So one thing, as you probably all know, but I do want to emphasize that patients after splenectomy have long-term leukocytosis, lymphocytosis, monocytosis, and they can have morphologic changes. All these changes, whether they cause any adverse effects or not is unclear. But if you think about it, body has designed elaborate mechanisms to get these cells clear. And now with the spleen gone, it is not able to do that. It is not inconceivable that there may be some long-term adverse effects that we are just not aware of. But at a minimum, we know that these higher blood counts can persist for a long, long time. And I see at least 1 or 2 patients every year who are referred for evaluation of lymphocytosis or thrombocytosis. And you take a good history and you find out they had a spleen removed 6, 7 years ago, and that's the end of the story. You don't need to do anything else. Third point I want to emphasize as a long-term side effect is the risk of venous thrombosis. 3 to 7% post-surgical risk, even in ITP patients. The risk of thrombosis is long-term. It's not just post-op. It tends to last longer than that. And it is particularly high in patients who have splenectomy for hemolytic anemia. Most notably, for some reason, a condition called stomatocytosis, where the thrombosis risk has been reported as high as 40%. We don't know why, but it has been mentioned or at least proposed that this should be considered a relative contraindication because the thrombosis risk is so. What can we do to prophylax
for these thrombosis risk, it is not clear if anything more than the usual prophylaxis that you undertake in your general surgical patients is necessary, but really there is not any good research data to guide us in that context. Cardiovascular risk, this is an emerging field. There is now pretty reasonable data, not very robust data. The data comes from case series and case control studies, but not randomized trials, showing that the ischemic heart disease risk and risk of other atherosclerotic events is 2 to 5-fold higher after splenectomy than in non-splenectomized patients. There is also a higher risk, a higher incidence reported of pulmonary arterial hypertension. Now, whether this is related to small microthrombi in the pulmonary circulation or there is some other thing going on, it is not clear. So I think the data is quite suggestive. I would not call it a conclusive data, but still something to keep in mind when you have patients with splenectomy that you are following long term. So finally, some take-home messages of what I have been talking about last 15, 18 minutes. Number one, ITP remains the commonest indication hematology-wise for splenectomy, although we are doing it later and later in the clinical course of these patients. It is safe. It can be done safely, even with low platelet count. Infection risk, please be aware of it, take appropriate precautions, teach your patients whatever needs to be done to avoid that rare patient who develops life-threatening sepsis and may pass away even before they can make it to a good medical facility. 3 to 7% thrombosis risk. We talked about it, and cardiovascular. So thank you for your attention and happy to take questions. And here is my email. Feel free to write me later on if you will. Look forward to any comments or suggestions to make the presentation better. Thank you.
Good evening. Good evening, sir. Sir, what is your cutoff level to start antiplatelet post-operative in this patient?
Mike, please. Sir. We start low molecular weight heparin prophylaxis with platelet counts as low as 30.
30.
30. Yep.
We usually what in our practice what is the cutoff level? More than 3 leg, 5 leg, 7 leg will start antiplatelet post-operative. In the post-operative period, these patients develop increase in platelet count. Many of patients develop 5 leg, 7 leg, 8 leg. So what is the cutoff level to start antiplatelet?
I get your question. I misunderstood your question. So we do not start prophylactic anticoagulation irrespective of the platelet count. If they are more than 600,000, I think that's what you're talking about, we would put them on low dose aspirin, not on heparin. I thought you were talking about post-operative thromboprophylaxis. In that context, we are comfortable giving them low molecular weight heparin with platelet counts as low as 30,000. But because of the risk that I showed you, all these patients should be getting thromboprophylaxis for the first 4 weeks or so after the procedure.
Another is the antibiotic prophylaxis. Which age group you prefer to give the antibiotic prophylaxis comparing young age children or adults? Which age group you will give prophylactic antibiotic post splenectomy?
All of them.
Which antibiotic?
Penicillin. Penicillin. I mean, obviously, unless they are allergic to it, then you choose the appropriate alternative. That's a great question. There is no good data. What I showed you and the limited data that is available, you should use it at least 10 years. Some people I know
stop the prophylactic antimicrobials after 5 years. There can be a little bit of individualization. You know your patient well. If the patient is reliable, they understand their condition and the risk. And more important than the patient, the family understands it. It may be reasonable to stop that sooner. But if you weigh the risks and benefits, taking the penicillin is very low risk. If somebody has taken it for 5 years, taking it for another 5 years does not add much of a risk at all. So those are the considerations that go into, but at least for that long, and in my opinion, ideally lifelong. I have actually never seen it. So I know it has been described. It is a manifestation of venous thrombotic problems. I personally have not seen it. The risk appears to be very low. That's all I can say.
There was a belief in unit that vax may not be necessary for children above 5. Rest may not need. What is your policy as far as vaccine is concerned?
So our policy is to vaccinate them. So as I showed in the slide, there is some controversy about whether the risk is higher in children compared to adults. There are some studies that would suggest that. And that would be the justification to be more aggressive with prophylaxis in children for X number of years, at least say 10 years. And by that time, a lot of them will be into the adult age group. But the data that is out there, it's old data, all suggests that the risk of infection never goes down to baseline. It is always higher than the general population. And because of that, it becomes a question of balancing what are the risk side from your intervention versus what is the potential.
If I might ask you, have you seen OPSI? Have you seen a patient with OPSI in your experience?
Have you seen what?
Overwhelming post-pancreatic infection.
Yeah.
Have you?
Yeah. I've seen meningococcal infection and very dramatic, unfortunate situation. Patient passes away in 24, 48 hours.
Yeah, actually, Dr. Bhatta is referring to the All India Institute group, GI surgery department, which in its patients with portal hypertension where splenectomy and shunt is done, do not give prophylaxis. But Bhatta, my answer to your question is, OPSI will never come to you. It will go to primary healthcare and die there. That is why. I have also seen one young lady who managed to reach us, but by the time she had already, and this was a splenectomy done by us, and by the time had developed irreversible multiple organ failure and died in our hands. So as Dr. Vivek said, that OPSI is like rabies, 100% mortality. So it is better to take the vaccine. I disagree with Dr. Piyush.
Splenectomy done for trauma or cyst or something else, non-hematological indication. Should we follow up this patient just for count, blood counts? Are they developing thrombocytosis or every 6 months or every 1 year?
Short answer is no, unless there is another reason to do it. These patients will all have mild lymphocytosis, mild monocytosis. And what often happens is you rightly never followed the count, but then 5 years later, they have a count done for something else. And somebody notices lymphocytosis, and there's a whole track of investigations get started as a result. That's the point I was trying to make, that to be aware that these things do happen after the splenectomy and not do unnecessary tests.
We recommend all the 3 vaccines for all age groups.
Yeah.
Question from my side for the surgeons. Do you see any difference in complications vis-a-vis laparoscopic splenectomy versus open splenectomy in patients where the indication could be, say, an ITP with low platelet counts? Or any of the surgeons would want to answer. This is a question coming from a hematologist to a surgeon. Like, what do we expect?
Open versus lap. Additionally, you may see additional lap complications. Other than that, the splenectomy complications are same, but additional lap complications like anything from various to injury to the than that, no special.
I would beg to differ, and I have a contradictory opinion. The complication rate with laparoscopic splenectomy is much.
Yeah, that's true. But the type means the special things are only because of.
For a
But
patient,
definitely the recovery is fast, pain will be less, and everything will be.
for a patient with very low platelet counts, coming from a hematologist, if I'm referring to a surgeon, again, as Farad mentioned, transfusing during surgery would be the best course. But at what platelet counts would surgeons usually feel comfortable in taking the patient up for surgery?
30 to 50,000. 30,000.
We have operated patients at 5,000, 5,000, 7,000. Because these are desperate situations.
My question to Roy, sir. Sir, we often see around 12 lakhs, 15 lakhs of platelet count after splenectomy. So usually what we follow may be wrong, but above 6 lakhs, we will start hydroxyurea. Below 6 lakhs, up to 4 lakhs, we keep them on because that is right.
Yeah, so I know some centers do that. To my knowledge, there is no data to support it. The rise in platelet counts is very high, I use a different sort of terminology, 600,000 or a million, same idea, is the risk of thrombosis in reactive thrombocytopenia is very low. So even interventions like aspirin will take care of it. Most of the time, these are short-term fluctuations, maybe 72 hours, 4 days, something like that. And then this will settle down. At least theoretically, hydroxyurea is a chemotherapy, and there is a potential risk if you expose a young patient, oftentimes these are female patients, to a chemotherapy type drug, which is not absolutely necessary.
I think in the interest of time, we close this. And before we close, may I request Priyanka Soni to say something about it. So with this, we close this session, and thank you so much.
Thank you.
Professor Roy. We truly
Thank you.
enjoyed.
I think now I would like to call upon Patta Radhakrishnan sir because we have to conduct a quiz. I hope everybody has downloaded that Kahoot app on their mobile because everybody is participating in the quiz and we will get a lot of prizes in that quiz, I hope. So please download the app if you not have done yet. And yes, sir, I'm hoping that I will get the prize.
Good evening. This quiz, as I usually do, is on the Kahoot app. I'm sure you would have downloaded the Kahoot on your mobile phones. You have to open it. I shall put up a pin which comes on the screen, and you need to see the pin to get into the game. You all have to write your name. Please write your proper name. Otherwise, if you write Venus or Moon, it's difficult to make out who's there. And I don't know whether it is going live on the Zoom. If it goes, I think others can participate from elsewhere as well. It's open to everyone because we don't see many postgraduates here. Everybody is a student. We are learning. And there are 3 prizes, and the first prize is rupees 10,000, second prize is 8,000, and third prize is 7,000. The money is with me, and I'll hand over to the winners. Right, we'll go on to Kahoot now. It'll take about half an hour. Can I have the screen? Now, here we are for you to get the pin. Yeah, that is the pin you see on the screen. The pin number is 2947265. And I'm just waiting for the players to log in. I just wait a little more time for more people to log in. I'm sure you can see your names on the screen. Okay. There are about 36 of you here. Can I wait for a little more while? Okay, I'm starting now. Yeah. Have you logged in? The money is very enticing, I know. I mean, during open quizzes, the no answer, the prize used to go to the quiz master, but unfortunately, here that option is not there. I think, yeah, ML has joined, Arun. Okay, you're starting now, Dr. Chaube. Here we are, but I don't see your name. Are you there? No. We are losing money, I'll tell you. Okay, here we are. Okay. Yeah, the first question is this. According to the HCC bridge study, the mean age of incidence of HCC in China is 67 years, 63 years, 52 years, 46 years. According to the HCC bridge study, the mean age of incidence of HCC in China is 67 years, 63 years, 52 years, 46 years, and your time is up. Here we have the answers. The correct answer is 52 years, and some 11 of you got it right, but I don't know why, how the 63 number came in. But here we are, here are the winners at the moment. Santosh is leading, and close by is Govind and Krishna. We'll see, this is in the HCC bridge study of about 18,031 HCC patients from 42 sites in 14 countries. You see the mean age of HCC diagnosed in Japan is 69, China is 52, and Africa is 46. We'll go to question number 2. Median survival in HCC after treatment is highest in which country? South Africa, Taiwan, Italy, North America. Of these 4 countries, which has the best result for HCC after being treated? South Africa, Taiwan, Italy, North America. I'm sure a lot of you will get it right. Right. As I rightly predicted, a good number of you got it right. And this is where the scoring is now. Santosh is still in the lead, and Harshil has come up a bit. I know what makes you laugh, but anyway, you see, these are the figures. Because of strict surveillance in Japan and Taiwan, these HCCs are caught very early, and they have very good survival figures as compared to the rest of the world. I shall move on to question number 3. I'm sure you all are aware of Gallard score. All the following are a part of Gallard score except gender, AFP-L3, alcohol, and descarboxyprothrombin. Of these 4, one is not part of Gallard score, and what is it? I'm sure this also should be a difficult one. And this is to estimate the possibilities of HCC in cirrhotic patients. And there we are. Excellent. I think almost all of you got it right. Alcohol doesn't figure in this Gallard score. This is an easy one. And here we go to look at the scores. Yeah. Krishna has gone up the ladder. And, those are the actually 5 players got all the 3 right continuously. And now again, and if you see that alcohol is the wrong option, the Gallard score, G for gender, A for age, another A for L for AFP, another A for AFP L3, D for descarboxyprothrombin. It should be a highly accurate model for detection of HCC in patients with cirrhosis. I shall move to the next question now, and here is your question. In phase 3 celestial trial, the following drug has been proved to be better than placebo in treating advanced HCC. This shouldn't be a difficult one either. Regorafenib, sorafenib, cabozantinib, donafenib. I don't know why they get these names, but they sound very exotic to me. Of these 4, there's one drug which is used in phase 3 celestial trial and which is proven to be more beneficial than placebo. Which one is this? I'm sure you would have got it right as well. Oh, I'm sorry. I think this must be a tougher one. Because a good number of you got the wrong one as regorafenib, and the answer is cabazantinib. Here we are. The leaders, the new leader has come up, and you see here this in a patient who's previously treated with sorafenib. This is in a group of patients with HCC, advanced HCC, who's already been treated with sorafenib. In them, between placebo and the cabazantinib, the people with cabazantinib did better. With this, we'll move on to the next question. Yes, here the fastest finger will get the. You just look at this gentleman who spoke to us yesterday from a distance. Who is this gentleman? Daniel Azole, William Lancaster, Guido Torzilli, or Osman Abbas Sug. A person who didn't smile even once. Who is this gentleman? It shouldn't be difficult, but I mean, he should have been there yesterday. Oh, almost all of you got it right. I thought this is going to be a difficult one, but then I think they were very attentive yesterday. I think the organizers have done it well. And, here we are. And that's how Ilonga, I don't see you in the list till now. And this is gentleman, he looks much happier and smarter in this picture, but he's an Italian liver surgeon from Milan. And his area of specialty is precision surgery for malignant liver tumors. He spoke on navigation liver resection yesterday, if you remember. All those frowning most of the time. And I think almost all of you got it right. With this, we'll move on to next question. Liver Met survey, I'm sure most of you know this, is launched in 2006 by this gentleman. Who is he? Henry Bismuth, Blumgart, Paul McMaster, Rennie Adams. Liver Met survey is launched in 2006 by which of these gentlemen? Bismuth, Blumgart, Paul McMaster, Rennie Adams. I'm sure this is also an easy one. And most of you will get it right rather. It's a huge database. And as I predicted, the good number of you got it right. It's Professor Rennie Adams, and we'll see the scores before. Yeah, Vikram is a new entrant, but all others are more or less in the same positions. And, this is a gentleman who initiated the LiverMed survey. It's actually a French government initiative, and it's got a database of more than 70 participating countries. And it focuses on patients operated for colorectal liver metastasis, whether resected or not. And it's open to anyone and everyone across the world, whether private or public. There are only set criteria. You have patients with colorectal metastasis, you can enter into that data and enrich it. This is Professor Rennie Adams. With that, we shall move on to the next question. Here it is. There was a talk about TAD yesterday. All are true about transient hepatic attenuation differences, except there's a relative increase in hepatic arterial flow. There's a decrease in portal venous flow. It's visible during the portal venous phase of CCT and may be associated with HCC. One of these is wrong. One of the responses is wrong about PHAD. Which one is that? Yeah, I think, see, associated with HCC is the right response, actually, in the sense that it does happen, but the correct answer is it is not visible during the portal venous phase, but it is visible during the hepatic arterial phase. I mean, I know this is a bouncer, I should say, and we'll see whether any newcomer has come into the group. Milland has come in, and we'll see. Yeah, see, transient hepatic attenuation differences you see in the screen are lesions referred to areas of parenchymal enhancement visible during the hepatic arterial phase of helical cyst. Yeah, sometimes this HCC also can look like this, so that is not the right response. And with this, we shall move on to the next question. And this is the question that I'm sure most of you know, the Ligro trial. Ligro trial is Dutch, Scandinavian, Korean, or American? The Ligro trial is Dutch, Scandinavian, Korean, or American? See the fastest finger first. You know, that is a marking there, so you can't use resources while answering this quiz. And I'm sure good number of you, as expected, have got it right. 14 of you got it right. The Scandinavian trial. And we'll see where we stand now. Oh, Satish has been answering correctly for the last. First time I see Ilongo at the bottom of the ladder. I'm sure he's slowly will climb up. And in the Ligro trial, ALPS improves resectability compared with conventional two-stage hepatectomy in patients with advanced colorectal metastasis. And this is Scandinavian multi-center control trial. Ligro trial is Scandinavian. Well, then with this, we move on to the next question. Okay, this is a slightly unusual question. Autoimmune pancreatitis is associated with all these cancers, except pancreatic cancer, gastric cancer, lung cancer, prostate cancer. Actually, a majority of the autoimmune pancreatitis patients will get a malignancy within 1 year time. They can get any of these except one, and which one is that? And I'm sure this shouldn't be a difficult one either. And here we are with the answers. Oh, I'm surprised. Pancreatic cancer is the correct answer. And most of you got it wrong. I don't know why, but see, before we, oh, Ilongo has just climbed up multifold. Now here, see, the autoimmune pancreatitis can develop any cancer other than pancreatic cancer. Just to say that autoimmune pancreatitis is not a precancerous condition for pancreatic cancer. They get around 50% of all cancers detected in autoimmune cancer patients comprise mainly 3 types: gastric, lung, and prostate cancer. Thus, autoimmune pancreatitis appears to be associated with cancer organs other than the pancreas. I mean, that's a great message. Now, with this, I shall move on to the next question. This must be an easy one. Who is the convener of National Cancer Grid? Be easy for those who have heard this term. Is it Dr. P.V. Desai, Dr. Jagannath, Dr. C.S. Pramesh, or Shailesh Srikant? Who is the convener of National Cancer Grid? Shouldn't be a difficult one. And here we are with the answers. Yeah, I mean, half of you got it right. Pramesh is the right answer. And you know, interestingly, some of you marked Shailesh Srikande. That's not the right answer. And Lunga slid down a little bit. And there we have PJK, whoever it is in the top. And this is Pramesh. This National Cancer Grid was created to form a union of cancer centers. There were about 54 to start with. Now I think they crossed 100 in the country. They're all interlinked. They share data. And this is just to raise the standard of cancer treatment across India. If you are into the cancer grid, we can always get advice from the Tata Memorial. And you know, this is a government initiative, central government initiative. And with this, we will move on to the next question. It shouldn't be a difficult one. Wang et al. It's a 2021 publication, recommend the number of lymph nodes to be removed during distal pancreatectomy for adequate lymphadenectomy in pancreatic ductal adenocarcinoma, the tail of the pancreas. In tail cancer, what should be the appropriate number of lymph nodes that need to be removed? This is by publication by Wang group. Yeah, I think the time is getting over, and I do not know. You may have some confusion in this area. And the correct answer is 19. And a lot of you got it as 16, which is not true. 19 is the number. Even I was surprised, but 19 is the number, and that is the correct answer. I will see whether this is going to change the fortune of some of. Yeah, here we are Oh, Ilango is almost at the hanging the bottom. PJK is still in the lead. With this, we'll go to the next question, and this is the next question. Oh, this Wang and colleagues used the SEER database to analyze lymphadenectomy, and they found that a minimum of 19 lymph nodes ought to be removed and examined in order to ensure the quality of lymphadenectomy, and that has a positive impact on overall survival of 7 months or more. I think that's a good information. Yeah, this is the question. Next question. And this shouldn't be a difficult one. Who on earth is credited with the world's first heart, lung, liver transplantation together in 1987? Which gentleman? Is it Tom Starzl, Russell Strong, S.T. Fans, or Roy Khan? Which of these four has been credited with the world's first combined liver, heart, lung transplantation in 1987? Shouldn't be a difficult one. And the correct answer is Sir Roy Khan. Good number of you got it right. And here we are with the winners at the moment. It's just the same. Milongo has disappeared from the horizon by tiny pickup. And being a transplant surgeon himself. See, Sir Roy Khan is a great painter. If you remember, that I'll remember about Dr. Roy Khan's paintings. His most notable achievements are the world's first heart, lung, liver transplantation in 1987. Also, the first successful combined pancreas, stomach, liver, kidney cluster transplant in 1994. First liver transplant itself in 1968. And the first intestinal transplant in the UK in 1992. Too many accolades to Sir Roy Khan, and a good number of you got it right. And I'd met him once in 1993 in Chennai when he came to one of the Royal College meetings. And yeah, the next question. Yeah, this world famous liver transplant surgeon is presently working in which country? France, Israel, Germany, Switzerland. He was standing in the same podium just a day ago. Have a look at this gentleman. Where does he work at present? France, Israel, Germany, Switzerland. If you listened to him yesterday, that's the wrong answer. He's a Frenchman, and he was talking about utility, futility, utility versus futility, you know. And the answer is Israel and not. He belongs to France, but he moved to. Anyway, the issue is the Quizmaster edition is fine. That's the latest news. Okay, but you see, I can't change the thing. Anyway, I think certain things you can't help. Anyway, I should have done more research. Anyway, we'll go on to the next question. What is not true about olaparib? This drug called Lynparza, is it used in ovarian? What is not true? All are true except one. It is used in ovarian fallopian tube cancer. It is useful in BRCA1-2 germline variant of pancreatic cancer. It is an alkylating agent and it can cause tremendous hair loss. Which one of these four is not true? I think almost all of you got right, but last time we missed the score. Yeah, here we are. PJK is not lost his position, first position till now. I think there are not many questions left now. So Ilango is back in the reckoning. So this particular drug called olaparib, sold under the brand name Lynparza, is not a chemotherapeutic agent actually, and it's useful especially in pancreatic cancer, which is got a BRCA mutated germline. It's also used in ovarian cancer. It's not a chemotherapeutic drug. That's what I want to convey. Now we'll go on to the next question. Have a look at this and say, what is this condition? Actually, I've seen a patient, about 43-year-old, just a few days ago. Is the patient, have a look at all the 4 images. What syndrome is it? Birt-Hogg-Gibbs syndrome, Von Hippel-Lindau syndrome, PTN hematoma syndrome, or hereditary leiomyomatosis and renal cell carcinoma. Have a good look at this picture. And what is this condition? I'm sure all of you, or almost all of you, will get it right. And there we are. Almost all of you got it right. Although an occasional person is very amused by the other names. Here we are. Yes. These are the people in the lead. As long as you stick on to the 3rd position, you'll get money. You can share. Von Hippel-Lindau disease is a rare tumor syndrome that involves multiple organs, which includes CNS hemangioblastoma, multiple renal tumors, adrenal pheochromocytomas, and pancreatic cyst pancreatic tumors. Actually, the one I've seen has got a tail malignancy, one head malignancy. In between, there's only cysts are there in the pancreas. By both kidneys, one kidney is a massive tumor, one kidney is a small tumor. Brain is free. Actually, I'm not sure what to do. So she would merit a total pancreatectomy, which is a patient who had a routine ultrasound for a health check, no symptoms. Anyway, here we are moving on to the next question. Okay, this is a simpler one. Gallbladder and bile duct cancer awareness month is which month? Is it January, February, October, November? Gallbladder and bile duct cancer awareness month is which month? February is the right month. I don't know, some of you might have been in Kolkata, but the IASG would have got this information. February is the month. November is the month for pancreas. Oh, PJK, whoever it is, still in the lead. ML, I don't see you anywhere. Connection. Don't blame the connection. February, we say batteries are low. It's a gallbladder bile duct awareness month. Okay, next question. The Oslo Comet trial deals with what? Laparoscopic versus open distal pancreatectomy for tail cancer, laparoscopic versus open central pancreatectomy for body cancer, laparoscopy versus open resection for HCC, laparoscopy versus open resection for colorectal metastasis. Which one of the 4 is the right answer for which is the subject of Oslo Comet trial? Yeah, we have almost done now, and almost all of you got it right. Wonderful. And that is the right answer. That is laparoscopic versus open resection of colorectal liver metastasis. I think this was discussed yesterday. Here we are. The winners are almost holding to their positions, and there are just few more questions to go. We'll move on to the next. Yeah, this is the Oslo Comet trial, a prospective randomized trial on open laparoscopic liver resection for colorectal liver metastasis. Next question. Regarding Fukuoka guidelines, you need to pick the right response. Actually, of the 4, only one is the right response. And which one is that? First, Fukuoka guidelines were laid down in 2014. Mucinous neoplasm of pancreas have been excluded. The number and not the size of mural nodules suggests malignant potential. And AGA guidelines on IPMN are more aggressive. Of these 4, only one is correct. And which one is that? Regarding the latest Fukuoka guidelines. Yeah. Mucinous neoplasm of the pancreas have been excluded is the right response. And 8 of you got it right, the others didn't. And actually, if you see the American guidelines about treating IPMN, they're very conservative, they're not aggressive. Yeah, PJK is way ahead. And this is the 20th meeting of the International Association of Pancreatology in Sendai, Japan, which is focused on the surveillance of IPM and branch duct. And they've also addressed the significance of mural nodule size. Size is important, not the numbers, to predict invasive carcinoma in high-grade dysplasia in branch duct IPMN. And the other parts of FIPOC guidelines are left unchanged. What are the initial ones done in 2012, actually? Mucinous cystic neoplasm has been excluded from the revised guidelines, given that there are very few remaining points of controversy regarding this entry. With this, we shall move on to the next question. As I said, there aren't many left. Okay. Pancreas journal. Who's the editor-in-chief? It's a tough one. Tough one. I agree. Editor-in-chief, one who gets it right has a chance. Ashraf Mustafa Rashid, Suresh Chari, Wei Liang W. Go, Miklos Sahintot. Who is the editor of this journal, Pancreas? Surprise, a lot of them got it right. It's Vijay Liang W. Go. He is the chief editor-in-chief of this journal, Pancreas, and not Dr. Suresh Chari. And we'll see if there's any change. I just want to see PJK slide a bit down, but I think it's too far high up. Ilango keeps sliding. Now it's trying to hang on. There's no fifth and fourth prizes. Sorry, Ilango. You have to try very hard now. So that is the journal, and that's the editor. Okay, next question. Oh, this is a little tricky one. ILBS was formally inaugurated in the year 2008, 2010, 2012, 2014. The Institute of Liver and Biliary Sciences inaugurated formally in which year? You can take a chance. A friend might help, but you will not, you lose the fastest finger first. Yeah. You'll see the score now. Yeah, I mean, almost half of you got it right. So in the year 2010, and the scorecard is like this. Yeah, I think the leaders are more or less the same. Nickel from KM stands in second position, and ILBS, the foundation stone was laid in 2003, and the first phase of the building was built, completed by PW in 2009, and the formal inauguration was done in 2010. And since then, the director has been Dr. Sareen. 2010, it's all 12 years. And the thing, the institution has grown by leaps and bounds. With this, we'll move on to the next question. Okay, big 5 lessons from a surgeon's life. Dr. Chobe is not allowed to answer this question. This book is written by Dr. Kapoor, Dr. Sanjeev Haribhakti, Dr. Palnivelu, Dr. Adarsh Chaudhary. Who wrote this book? It's been released just about a week ago. Big 5 lessons from a surgeon's life. It's available on Amazon for some of you want to buy, and that is the right answer. Good. That Haribhakti will be very happy to know that people know that he's written a book, and that is available online. And actually, if you can log into the speeches that happened during the inauguration, the 5 speeches, wonderful speeches. Adarsh Chaudhary spoke very well. He spoke the best, rather. Nagiriti, of course, yes. I mean, they're all wonderful speeches, I should say. Here we are. These are the leaders. And actually, PJK has gone to 10,000 score, which is difficult to reach. We will go to the next question. Yeah, this shouldn't be a difficult one either. Dr. Leslie H. Blumgart originates from which country? I hope there's no one to correct me. Is it from Tennessee? Is it from Zurich, Switzerland? Is it from Paris, France? Is it from South Africa? Which country does Blumgart belong to? South Africa is the right answer. So many of you thought it's France. Not true. We'll see the scores. Oh, Telugu is back again. Telugu, I think there are only 2-3 more questions for you. Two. No, don't drop out. Okay. Here. He's a dentist, right? That is it. Okay. The latest version of Da Vinci Robo is X, XI, SP, SI. Which is the latest version of Da Vinci Robo? This isn't a difficult one either. Right. A lot of you got it right. It's the XI is the latest version. And let us look at the scores. Oh, here we are. Chetan, there's some fire burning in his belly, as you can see in the picture. But Chetan has also gone to 5 figures. And I think there are only 2-3 more questions, if I'm not wrong. No. Okay, this must be a difficult one, but take a guess. What 10 is the biography of which famous surgeon? A GI or hepatobiliary surgeon? So, Rangabhashyam, Srikhande, Bhale Rao, Professor N.M. Gupta. What 10 is the biography of which famous surgeon? Actually, this book can't be seen on the internet itself. I have a copy, but that's Professor Rangabhashyam. I was his last student before his retirement. And let us see the scores. Oh, Telugu, you are very close now. Oh. This has been wrongly arranged. That's the Dr. Rangabhashyam. Okay. What is Lustgarten Foundation known for? What is Lustgarten Foundation known for? Colon cancer, pancreatic cancer, liver cancer, gastric cancer. Which cancer? This shouldn't be a difficult one either. Pancreatic cancer is the right answer. And most of you got it right. I think last question or last but one. This is not a difficult one. Is Samaranandi currently my mentor, president of which AIMS? AIMS Delhi, AIMS Raipur, AIMS Jodhpur, AIMS Rishikesh. You all should get it right. AIMS Rishikesh is the correct answer, so it will not going to alter the pattern of winners. Correct answer there. AIMS Rishikesh. I think with this we'll come to the final thing score. Vikram, third prize. PJK, second prize, and first one is Chetan. It's Chetan Kantaria. Unfair, sir. Okay, Professor Chaube, please come on stage to hand over the prizes, please. I didn't know. And actually, I'm amazed. I thought Chetan was a student, young student. The third prize of 7,000 rupees to Vikram. Please, Vikram, come up. Can you have the lights on, please?
Yeah.
Hey.
Lights on, yeah.
I didn't know this is this Vikram. Come on. Where you sharing the answers? Okay, all right. Well done. Congratulations. The second prize to PJK Oh, PJK is from JIP. Did you win that quiz in? This is 8,000 rupees. In ISG. Oh, that's a colleague of yours. Congratulations. Well done. PJK full name.
I am Dr. Pradeep Jaikumar. I am an assistant professor in Adyar Cancer Institute.
And please clap Dr. Chetan Kantaria. You know, I mean, he's up to date. No, if he comes as an examiner, you'll all be in trouble. Thank you. Thank you.
3 cheers for the quiz master.
Thank you.